Good morning everyone. Welcome, Namaste and Vanakkam to all of the faculty gathered here, and to kick off the second day of our academic sessions with the PVD, and for the aortoiliac session we will have a panel discussion on surgery versus endovascular, how to choose. I call upon the faculty to enrich the stage. Dr. Girish Vavadekar sir, Dr. Sanjeev Kumar sir, Dr. N. Shekhar sir, and Dr. Bhavesh Arun Popat sir. And the chairperson for this event will be Dr. Neeraj Nirmal Pandey. I also call Dr. Raguraman L to join the session.
Neeraj is going to start in say a couple of minutes.
Yeah. So for aortoiliac occlusion, open surgical repair has remained the historical gold standard. It has demonstrated consistently good patency rates even up to 10 years. However, the complication rates associated with open surgical repair are not insignificant. Also, there are few patients with comorbidities, etc., who are unfit for surgery. Extra anatomic bypass is an option there, but the patency rates are not very good. So there was kind of an unmet need which was met by endovascular therapy. It all started in 64 when daughter performed the first angioplasty. In 74 the first iliac lesion was treated. By 85 we had adopted the kissing balloon technique for bifurcation stenosis. The patency rates were not very good, but then in 92 the balloon expandable stents were introduced. The patency improved but was still not really excellent. Then there was the introduction of self-expanding stents for external iliac lesions, and in 98 essentially the Dutch iliac stent trial sort of cemented the role of endovascular techniques for aortoiliac disease and showed very good clinical success at 2 and 5 years. So now for aortoiliac occlusions we had options. We could do it endovascularly, we could do it with a proper anatomical repair, we could do extra anatomic bypass. And to address this issue of choosing the options, the task group got together, formed the classification. By the time the first classification came out in 2000, it was already outdated. The group got together to make the second classification. And in 2007, when this task 2 classification came, they recommended open surgical repair for these type D lesions. But as they say that rules are mostly made to be broken and are too often for the lazy to hide behind these rules. This was taken to heart by interventional radiologists and they have evolved, and now a lot of these lesions are being done by and are being able, the endovascular specialists are able to tackle these lesions using endovascular techniques. So the one question is, can you do it? And the second question is, should you do it? So should we do it and how should we approach these lesions is the topic of discussion for the panel today. We have an esteemed panel here to discuss this, and I think we'll start with Dr. Bhavesh. So I talked about the task 2 classification and what it recommended for these severe type D lesions. In the past 2 decades, how do you think the evidence has evolved, and what were the landmark trials which actually took us away from this dogmatic statement of the task 2 classification?
So I think world over, once the task guidelines came and task 2 guidelines suggested that the C and D be preferably taken up by surgery, mostly D. And then I think in terms of current guidelines, if you look at both CERC as well as ISVIR guidelines currently, almost all of these guidelines tend to give us the idea that endovascular first approach seems to be the mantra at all levels in terms of guidelines. Now, obviously, it's not as simple as it sounds. There are various aspects to be considered when you're taking decisions. You have there was a period when a COBEST trial demonstrated that the covered stents probably had a much better outcome as far as task D lesions were concerned and task C lesions were concerned in terms of patency rates as compared to bare metal stents. In fact, there are a couple of trials comparing self-expanding stents versus balloon-mounted stents, and now some of the trials, especially in task D lesions, seem to be suggesting that self-expanding stents could do a better job as compared to a balloon-mounted stents as well. Though the traditional teaching has always been that the ilia costium involvement and you would do kissing balloon-mounted stents in these patients. Obviously, you have various studies being done in terms of you have a stack trial earlier and the Dutch trial. We were trying to show whether you would do a balloon angioplasty and a bailout stenting versus a direct stenting in these patients. Obviously, these data again suggested that direct stenting may make more sense, the risk being the embolic phenomenon going down and causing distal embolizations in these patients. So I think world over a period of time, people are moving to endovascular first approach as compared to the surgical ones. Obviously, surgical skills are also improving over the period of time, and you would see the extra anatomical bypasses probably have really poor outcomes. Most surgeons would agree with that. In terms of morbidity and the mortality associated with even the aortoiliac bypasses, seem to be questionable, in that terms. So yeah, endovascular approach first is the current dictum across the globe, and most guidelines would follow that.
Yeah. I invite Dr. Girish to join us on the stage. Okay. So
that said, obviously, what's most important is to realize the lesion morphology, the extent of the lesion, the calcium involved within the lesion, as well as whether you have a landing zone or not for the devices or the stents to be placed. Yeah. So probably others will take over.
So I agree that the guidelines are sort of giving us a subliminal message that endovascular first is the way to go. But are there any anatomical prerequisites which you look for, or are all lesions amenable to endovascular repair these days? It's for Dr. Bhavesh, just a short.
So I think as far as we are concerned, if there is a adequate landing zone below the renal arteries in the infrarenal aorta, as well as adequate landing zone lower down, I think endovascular first approaches are mantra in most of these cases. We've done cases where we've landed a stent across the renal arteries. These are not the great cases to be picked up for endovascular. Unfortunately, some of these patients had very bad comorbidities and lower ejection fractions, and they had to be taken up for these procedures. But otherwise, surgical probably in those scenarios may make more sense.
Yeah. So I think severe calcification is another problem which we encounter in cases of these severe aortoiliac disease, which sort of hamper the success of endovascular procedures. So Dr. Girish, welcome. How do you see the role of intravascular lithotripsy in these aortoiliac lesions?
See, if it's a focal area, and IVL is very good. But I want to, as Bhavesh said, most important is if it is even close to the renal, endovascular is not the answer. Surgery is the answer. Yes, if, as he said, if the patient is not fit, then there are alternatives. But primary first mode of treatment would be surgical. As far as IVL is concerned, undoubtedly, if there is gross calcium, now there is a caveat there also, in the sense that if it's a coral plaque, IVL does not work. So if it is a generalized circumferential calcium and causing a stenosis, yes, IVL is the way to go. But if it's a coral plaque, no. Again, surgery is the next option. Sir, what do you think?
Yeah, I'm the sole surgeon here.
But you're good enough for all of us.
No, Girish has been a great friend over the years. See, I started vascular surgery in the 80s. So I've been doing for the past 40 years. So I used to do around at least 10 cases of aortoiliac reconstructions every year, 10 to 12. Now it is reduced to 0 to 1. We don't do as many aortic reconstructions as we used to do earlier. Majority of these cases are being done endovascular. But there are 2-3 points anatomically I want to stress on. Like Girish and Dr. Mahesh has already said that. The aortic block, the calcified atheromatous plaque is usually very close to the bifurcation at the level of IMA. Between IMA and the renals, if you are seeing an occlusion, majority of the time, because we have opened all of them, we have seen, majority of the time it's only a thrombus. So when you try to do any endovascular intervention when a patient comes with a juxtarenal occlusion, you are in deep trouble. It can embolize into kidney, it can embolize distally. To tell you, one of my patients, this man had an occlusion just above the IMA. So I did an angioplasty and then put a stent. Everything looked fine. And at the end of the procedure, I found one chunk of thrombus in the femoral where we had the sheath. And so we did a femoral embolectomy. Patient was fine. He was eating normally. Next day, he started behaving abnormal. And he started having abdominal complaints. When we did, he had an embolus has jumped, missed the renals and gone into SMA. Which is so surprising. The renals are absolutely fine. When we did the completion angiogram, renals are normal. So when you just take a shot, you see the origin of SMA, it looked fine, so we left it. So we didn't really look at the distal SMA. But the chunk of thrombus has jumped and gone into the SMA. And by the time we did open up and redid the patient, it was already 24 hours gone and we lost him. So things like that can happen. So whenever there is a juxtarenal occlusion, do not try endovascular. That is one strictly. Second thing is when the patient has visceral artery stenosis associated with this. So like an SMA stenosis, renal artery stenosis, it's always better to do a surgery where we can give a definitive, I'm sorry. So it's always better to give an open surgery where we can put a bypass to the visceral arteries along with the reconstruction of the aorta. That is better. Third thing is the landing zone, which you are stressing on. Many times we are seeing the lesion is precariously close to the common femoral, or there is some disease in the profunda, SFA disease. So the outflow is the most important thing. If you cannot assure a good outflow, your stent is likely to thrombose. So it is in such a situation, it's always better to do a hybrid procedure where you can do an endarterectomy of the common femoral. I know there are people who put stents in the common femoral, which I think is not a good idea because common femoral is a superficial artery which can be done under local anesthesia and is the most important artery for all kinds of future interventions. You put a stent and actually you're creating trouble for yourself later. So it is better always to do a common femoral endarterectomy, you do a profundoplasty, ensure a good outflow, and then you can bring the stent. You can actually, endarterectomy under the inguinal ligament can be done so that the distal external area can be cleared. So you can actually land the stent just above the inguinal ligament. So you also avoid crossing the inguinal ligament. These are all certain advantages. So I agree fully that surgery is the very, very limited role. Majority are being done endovascular, which is correct. Only thing is don't overdo things. These are the things where you have to look at and be cautious about.
And continuing with this endovascular first philosophy, I wanted to ask, does an endovascular procedure which has been done first adversely affect the surgical outcomes if the patient requires surgery further in life?
Yes. That happens when you take the stent all the way up to the renal arteries. So see, whenever a thrombus happens, the thrombus extends up to the first patent collateral. That will be the renal artery. So it goes up to that. So when you are opening up, so we have to put the graft at the just below renal level. The stent, I mean, it's not an absolute hindrance, but it is a hindrance for us to put. So now we have to put a clamp suprarenal and then do the anastomosis. So it makes the surgery slightly more difficult. I fully agree, extra anatomic bypass, the results are very poor as compared to that. The other point I wanted to mention is, see, when you look at Western data always talks about the actual brush aside a primary patency and they keep hopping on the secondary patency is very good. So by meaning secondary patency, that means you already intervened again. Yes. Our patients are paying from the pocket, majority. They are not insurance patients. The insurance is still very, very low. So they are paying from the pocket. So you should offer them the best. So overdoing endovascular sometimes can be a problem. So you combine it with a hybrid procedure like that, I think your results will be very good.
Yeah. And what is your take on a lot of surgeons I've seen doing an axillo bifem?
See, we used to do that earlier whenever a patient is unfit for surgery. See, now that endovascular option has come, that extra anatomical bypass has come down very, very much. Now we reserve it only for an infected case. You have an infected aortic aneurysm. I mean, after a bypass or after an endovascular procedure, you have to explant. You have to remove the graft, tie off the aorta. There we do an endovascular, I mean, extra anatomical.
So that means to say axillo bifem is the last option that
yes,
you do.
absolutely true. Absolutely true.
The other thing is that not only, as sir said, that how close you are to the renal, but also if you are going to do common femoral stenting, there again is a major issue, because for the surgeon to do a bypass would be a major issue there.
And continuing on the points made by Dr. Shekhar regarding primary patency, secondary assisted patency, all those things, I would like to ask Dr. Raghu, when we evaluate research, like we see a lot of small cohort studies, etc., which show excellent primary patency, almost comparable to open surgical repair, but they are assessing like 12 months data or 24 months data. So when we critically evaluate research pertaining to severe aortoiliac disease, on which we of course base our decisions, what should be the key outcome measures which we should look at?
Yeah, I agree with what's been said. I want to bring in a couple of things. Why is it that in 2007, when the task criteria came out, and definitely for C and D lesions, they said that it should be surgery first, and what is it that has kind of shifted the focus? What are the inflection points? And one of the key inflection points that's not been touched upon is the imaging part of it. CT scan. We have a better understanding. Now, if you sneeze, you get a CT scan. That's what's happening, and I'm sure it happens to my parents here in India too. So imaging is really good. So you know where the plaques are and where you extend it to. The second point that we need to touch upon is most of these patients, at least in our practice, have critical limb ischemia. So they are not purely aortoiliac disease. So they have multi-level disease, and that's a prerequisite for CLTI. So I take Sir's point on board, where we tend to do a hybrid procedure involving the common femoral and then either an upward stenting or go downhill to try and get inline flow down. And the second inflection point was the covered stent that Bhavesh touched upon. CHIRAB and the use of covered stents have really made a difference to the outcome. Coming to research, now when you look at surgery from a point of view of early mortality and morbidity is high, whereas durability is better in surgery than compared. So how do you kind of balance these two things? If you go and ask patients, they want to come in and out of the hospital quickly. They don't want to stay there for a long time. They're afraid of mortality. But durability is something that you postpone for another day. So what we did in the UK is we are actually randomizing 628 patients to the EWalk trial, and they get randomized to open endovascular repair versus open versus endovascular. And what we did is we did a survey amongst practitioners, and we felt that coming from 2007 to now, there is a certain level of equipoise, and that's what you're seeing here. People say, yes, you should offer surgery, and yes, endovascular is equally good. So how do we go about it? So what we are doing is we are randomizing it. Last 2 minutes. We are randomizing it. We have now randomized about 300 patients. We have 300 more patients to go. Surgery could be anything, and endovascular is purely aortoiliac stenting, but with a potential hybrid option. And my own feeling is surgery will win. That's my gut reaction. But we are going, and what we are looking at is amputation-free survival at 1 year and 2 years, and we are also looking at economic analysis at the end of 5 years as to what will happen, how much money is being spent on either. But surgery in the UK is much more expensive than here.
No, that is what you have to look at. See, you can't extrapolate what is being said in the West completely to our situation. So you have to look at our patients' economy and how much money they are spending. So you have to offer something which is more long-lasting than something which is only a quick fix. And you keep on doing, you say, if you tell that man after a year you will need a re-intervention, I'm sure he will opt for surgery.
Okay. So, yes, I could gather that long-term durability and cost-effectiveness of the therapy, these are important points to be looked at. And I think the patient who would benefit most are seen probably by Dr. Sanjeev at AIMS. People are visiting that tertiary referral public sector hospital. They would, of course, they come from far-flung areas, they are not the most financially stable patients. So they would like a treatment which would be long-term durable and cost-effective as well. So if you could just tell us
so
what
I
your
will
practice
quickly
is.
summarize because we are running short of time also. But I would like to start this discussion with, rather than saying endovascular first, endovascular second, or endovascular third, let's talk about patient first in these patients. And then maybe an intervention which could be endovascular or surgical, because we are not looking just at a technical success. We are not a plumbers. We are a doctors. We are a clinicians. Let's talk about the durability of the procedure, the benefit which the patient is going on. With those words, I will quickly say that in the last 2 decades, as we have seen that there are a lot of trials, cohorts, anecdotal studies, no RCT at all about the task C and D lesion, and this is one which has been going to publish in this month. But if you look at all those trial and the evolving data, our strategy, task A and B, I think there is no doubt, whatever the group of patients are that, we are going to do endovascular. The real contention is about the task C and D lesions, and in a low surgical risk patient, what should we do? So in the last decade, in the low surgical risk patient, in task D lesion, we often send this patient to surgical revascularization. As sir is saying, he was doing a lot of revascularization those days. But now we have changed our strategies with the evolving data, with the results of the CRAP procedures, kissing stand and all those. Now what we do is that we divide this task D lesion or C lesion into easier task D and complex task D. So what I mean by a complex task D lesion is that a lesion which is a long latham of occlusion. For example, aortoiliac occlusion which is more than 10 centimeter, or if it is extending above the inferior mesenteric artery, within the realm of the renal artery, that is within the 1 or 2 centimeter of the renal artery, or even if it is extending into the CFA, we call this lesion as a tough task D lesion. Any lesion which has got a calcification more than 5 centimeter with 270-degree circumferential calcification, we call it as a tough task D lesion. Anything which has got, sometimes these plaques are often associated with a lot of thrombotic burden, as sir highlighted, one of the patients who faced the complication. So a plaque with thrombotic lesions are again a tough lesion. The last lesions which I would say will be a tough lesion will be lesions which are, or the arteries smaller in size. For example, female patient, they have often a smaller artery of about 5 or 6 millimeter, and the results will be poor if you do endovascular. So all these kind of lesions are actually tough lesion. And when I say calcification is just not a disease, it's an expression of a disease. It's because of CKD, because of the diabetes. So there are multiple comorbidity associated with this patient, and if you do endovascular in this patient are going to fail in the terms of durability. So what we do, the simpler task D lesion, we go for endovascular. The complex task D lesion, as I said, we go for a surgical. That's our very clear-cut approach. In terms of CLTI versus claudication, again, we know that CLTI you do endovascular in this patient, the durability is often question mark. So we advise this patient to go for a surgical, and in claudicant we have our own experience, and we have shown the results is very good in simpler task D lesion presenting with claudication. So endovascular is our choice. That's how we deal this group of patients.
I think this has very aptly summarized the discussion. I'll not take much more time. I thank the panelists for being here, and thank you for being a kind audience.
Thank you, thank you, thank you.
Thank you for the amazing session and finally bringing out the fact that the patient remains the center of the problem. And for the next session, I call upon the chairpersons. I think they're the same persons again. So, Dr. Raghuraman L, Dr. Girish Avadekar sir, Dr. Sanjeev Kumar sir, and Dr. N. Shekhar sir. I think there was no need to leave the dais at all. Good. And for the presentation, I invite Dr. Vinay Kumar for the tools and techniques for difficult IO2 iliac CTO cases including CRAB.
Hi, good morning all. I'm Vinay Kumar, one of the consultant IRs practicing in Bristol, UK. I would like to thank ISVIR for this opportunity to talk on tools and techniques for difficult IO2 iliac CTO cases, including CRAB. The expert panel have touched upon most of the points that I was going to cover or discuss in this presentation. So I will brush upon certain slides and not take too much of your time. So we've already discussed what complex lesions are in IO2 iliac segments and what evidence there is to rationalize the endovascular treatment of difficult IO2 iliac CTO cases. And I'll try and discuss the basic tools and some ancillary tools which will help optimize the results in treating the difficult IO2 iliac CTOs. Some tips to optimize the results, and we'll try and discuss a few cases of CRAB, which is covered endovascular reconstruction of the aortic bifurcation, and ongoing research, which again Dr. Raghu has touched upon with the EVOC trial, which we are a part of in Bristol. So complex IO2 iliac CTOs, again there is no debate about endovascular treatment approach first for type A, type B, and most of the type C lesions. It's only the type D lesions with involvement of bilateral common iliac and the external iliac arteries, plus or minus involvement of the aortic bifurcation and the distal aorta, which make these lesions really difficult to treat. And as discussed earlier on the panel, if the common femoral arteries are involved, the best approach is a hybrid surgery with treating the common femoral arteries with endarterectomy followed by IO2 iliac stent grafts. There was quite a lot of debate about the open surgery versus endovascular, which I think is reasonable, mainly because there's a vast body of evidence regarding open surgery. Chu et al. In their systematic review in 2010 have identified durable patency results with surgical options, namely the IO2 bifemoral bypass, with patency results up to 90% at 5 years, which slightly drops down to 70% at 10 years, which is still significant compared to the endovascular options. Whereas the key parameters like the 30-day mortality and the complications is where endovascular can slightly trump the surgical options. So the 30-day mortality is 3% with the surgical options, and the complication rate go up to 16 to 21%. And in terms of endovascular techniques to treat these difficult IO2 iliac CTOs, the techniques we have are the kissing iliac stents, or the recently, I wouldn't say recent because the first CRAB was performed in 2013 with, now we even have the long-term follow-up outcomes for CRAB, recently published in 2025. And most of the procedures could be performed endovascular if common femoral arteries are not involved, and as discussed, hybrid approach when common femoral arteries are involved with endarterectomy followed by IO2 iliac stenting. I totally agree that we do not have any good quality RCT to compare endovascular treatment options with the surgical options. However, the meta-analysis by Salem et al. Published in CVR in 2021, which have looked at close to 9,300 patients, mainly the task C and the task D lesions, analyzing 66 studies. Majority of the patient groups were surgical patients, close to 6,000, and 3,500 of them were endovascular treatments, both kissing and CRAB. We can see from these Kaplan-Meier curves that the primary patency rates at 1 year is not too different between the surgical and the endovascular options. However, the results do taper down with endovascular treatments with primary patency rates dropping down to 70% in contrast to 88% with the surgery. As discussed, the secondary patency rates are almost similar between the two options, but that means more re-interventions to keep the patency of the stent grafts. And the parameters where the surgery slightly is less beneficial than the endovascular option is with the 30-day mortality, which is less than 1% with endovascular options, and morbidity is also less with endovascular option with faster recovery and less impact to the healthcare costs with the endovascular options. Why are these lesions challenging? What makes these task D lesions challenging? It's mainly the long segment bilateral occlusions, which again one of the speakers expertly put as or divided as the simple task D and complex task D lesions. So if there's long segment occlusions, bilateral occlusions, involvement of the aortic bifurcation or the distal aorta above the inferior mesenteric artery, long segment calcium, involvement of common femoral artery, which will need hybrid approach, and if you're planning to treat with endovascular, you may need multiple access, mainly the brachial or the radial access. As with most IR procedures, the useful thing to have is a proper planning, and ideally you would need a CT angiogram prior to tackling any iotoiliac CTOs. So with CTA you can plan your access, get all your measurements in terms of the diameters, the length of the stent you want to choose. MRA will be useful in certain cases where there is contrast allergy, and duplex is useful to quantify the common iliac artery disease, which will help determine whether the patient needs a hybrid surgery or purely endovascular approach. And useful tip again discussed on the expert panel for CIRAV when you're planning, always need to evaluate the patency of the mesenteric arteries, namely the celiac and the SMA, so that when you cover the inferior mesenteric artery in these patients, you don't give them complete bowel ischemia. So it's very useful to look at the patency of all the mesenteric arteries and refer them to surgery if that is the case, or at least try and think about revascularizing those vessels before you take on these cases. And with CT, you plan your access. I treat most of these lesions with bilateral retrograde access, percutaneous, and open if common femoral artery is involved with endarterectomy. And brachial or radial approach is useful in distal aortic occlusion so that you can have a target when you're trying to cross the lesions either from below or from the arm axis. And some of the simpler tools like the vascular sheets, it's a basic prerequisite for any procedure that we do in IR. For tackling iotoiliac CTOs, we start small, either 4 or 5 French sheath, and then upsize to bigger sheath sizes, which is required for the appropriate stent placement. And ideally, I use long sheaths to position the balloon-mounted stents so that I'm not barebacking the balloon-mounted stent across a tight lesion, because you run the risk of knocking the stent off the balloon if you're trying to track a balloon-mounted stent across a tight lesion. And very useful to pre-dilate with a 4 or 5 millimeter angioplasty balloon if you're struggling to track even the sheath across a tight lesion. And again, we've touched upon this on the expert panel discussion regarding use of covered versus uncovered stents. There is absolutely no debate about using the balloon expandable stent for common iliac artery, which allows precise deployment and high radial force. And for the external iliac artery, to allow for the conformability of the tortuous external iliac, you would prefer a self-expandable stent in comparison to balloon expandable. Whereas debate still lasts around the covered stent versus uncovered stents in use of in treating the iotoiliac CTOs. We generally, as a team at Bristol, we prefer the covered stents. It's mainly backed up by the COBEST trial to reduce the rupture and reduce re-interventions, particularly in difficult task D lesions. Again, we've gone through this COBEST trial, which has shown less re-intervention in the covered stent group, which makes sense to me, at least in treating the difficult task D lesions. One of the dreaded complications of doing an iliac intervention is iliac artery rupture, particularly the external iliac, or very difficult, small, heavily calcified task D lesions. Some of the procedural factors are if you oversize your balloon or the stent, or high pressure inflation or aggressive pre-dilatation of the balloons can lead to iliac artery rupture. The useful tip is to have precise measurements from the CTA so that you size it appropriately, stepwise dilatation so that you don't go too aggressive, and most importantly, to have the covered stents and the appropriate sheets in the room rather than outside when you do a procedure. The other useful tools for the ioto-iliac interventions, the complex ioto-iliac intervention is a re-entry device. There are various re-entry devices on the market. The cord is out back, the Bentley B-back catheters, or historically just the back end of the pterymo. I prefer the out back because that's the device that I've used on a regular basis. It's a device which has a needle that exits proximal to the distal tip of the catheter. You can also adjust the throw length of the needle to make sure that you're entering the true lumen appropriately. This is useful in flush occlusions with a significantly resistant proximal cap when you fail to cross it either while luminal or subintimal approach. And one useful tip is to use the re-entry device early in the case when you fail to cross with standard wires, just to make sure that you don't create a big subintimal space which might make even use of re-entry devices really difficult. The other useful tip is to have really high magnification images so that you can clearly understand the anatomy. And especially if you're working in small vessels like SFA and popliteal, you do need to do DSAs in 2 orthogonal planes to make sure that you got a good imaging before you use the outback. Again, this was touched upon on the earlier discussion, the intravascular lithotripsy. I totally agree, it's useful in focal disease and particularly useful also in heavily calcified small vessels, mainly because it does not induce barotrauma. The way the shock wave works is by delivering the shock pulses at very low pressures of 2 to 4 atmospheres. So you generally don't take it up to higher pressures as with a standard angioplasty balloon. And for iliac arteries, they come in various lengths from various diameters between 8 to 12 millimeters with a length of 3 centimeter. The one useful tip that I would give regarding IVL is to adequately oversize the balloon. Because you don't inflate it to higher pressures, you need adequate wall opposition, and you can achieve that only by oversizing. The IFU is 10%, but I would suggest go up to 20% just to make sure that there's good wall opposition when you deliver the shock pulses. And the way the shock pulses works is by inducing the energy transfer into calcium, which leads to more fractures, improving the vessel compliance, and better wall opposition of the stents when you use it later. So moving to a few cases. So this is a case which demonstrates the role of intravascular lithotripsy. The lesion per se is not very difficult to treat. It's not a complex task-T lesion, but still, if you look at the imaging, the very first image, both aorta and the iliacs are heavily calcified. And there is also an indwelling right-sided iliac stent, which was previously intervened on. And currently, the patient presented with left-sided claudication. So I've used a 12 millimeter shockwave balloon across the left common iliac. The third image is the post-IVL angiogram, which shows not a perfect image. There's still significant areas of residual stenosis, but you can see the difference it made on the fourth image when I used the covered stent, where there's good wall opposition. Because usually when you use a covered stent without vessel prep, you see that there's some indentation on the stents. The stent fails to expand fully. So there is definitely a role of IVL in focal calcification and some small vessels, heavily calcified vessels. Next is a simple kissing iliac stent procedure done in a 55-year-old construction worker with bilateral claudication. The first image shows bilateral iliac artery occlusion, more significant on the left with involvement of the aortic bifurcation. But the distal aorta per se above the aortic bifurcation is really healthy, so I decided to just go ahead with simple kissing stents with balloon expandable stents. And now moving on to CIRAB. CT is vital in planning a CIRAB intervention, mainly to get adequate measurements, the diameters and the length of the stent that you're going to use, and also to understand how calcified the vessels are.
Last 2 minutes.
So in terms of when you start out doing a CIRAB procedure, I would suggest to start out with slightly simpler cases than really taking on more complex infrarenal occlusions. So just so that you're completely understanding of the steps involved in the procedure. So the way I do it is by bilateral retrograde groin access and good quality angiograms to make sure demonstrate the complete anatomy. Followed by, in this case, I used IVL for the left side mainly because it was heavily calcified, followed by the aortic stent. I choose a 12 or 14 millimeter Bentley aortic stent, and the key thing is you're deploying the stent over just one wire, and you need to withdraw the second wire back into the iliac, or at least at the level of the aortic bifurcation. Certain tips to make sure that you don't lose the access completely is either parking the catheter and the wire from the non-aortic stent side, just so that you are not losing the access. Or the other step you can do, what I've done here is, I've used a snare catheter, as you can see in the second image, which has snared the wire from where the aortic stent is placed. And then I slide the snare back further down, just below the level of the aortic stent. And once I've deployed the aortic stent, I will slide the snare wire back into the aortic stent, so that I make sure that I don't lose the access. 1. 2, I'm back into the lumen and not going behind the stent. The next step would be to dilate the aortic stent, only the proximal 2/3 to the appropriate size that you measure on the CT angiogram, usually a 16 or 18 millimeter, and leave the bottom 1/3 unflared to give it a tapered configuration. After that, it is simple kissing stent maneuver. So you need to deploy balloon expandable covered stents in iliacs, and the final image is a good result with good flow, laminar flow down both the iliac arteries. This is just a slightly more complex version of CIRAB with distal aortic occlusion. So I'll probably just take one more minute if the panel is okay. So it's slightly more complex case of CIRAB with distal aortic occlusion. Here, in the second image, you can see that I've placed my catheter from the non-aortic stent side, just below the level of the aortic stent, parked in one of the lumbar arteries, again making sure that I'm not losing the access. And after that, it's simple kissing stents, building it downwards to get good laminar flow. And the reason why I choose the tapered configuration of CIRAB is excellently demonstrated on this flow dynamics paper by Jebing et al., published in Journal of Vascular Surgery. On the left, you see 4 different configurations and their respective cross-section imaging on the right. A is kissing uncovered stent, B is kissing covered, C is CIRAB with tapered configuration, and D is CIRAB with non-tapered configuration. And the key thing is to note that the radial mismatch is much less in CIRAB with tapered configuration, which gives an optimal shape of the neobifurcation, which improves patency and reduces the complications. These results from the CIRAB was first published by Goward et al. In 2015 with good technical success rates of 95%, but again, we don't have longer term data compared to surgery. So primary patency rates are 83% at 2 years, secondary patency 95 at 2 years, 30-day mortality of 0%. Only recently, the long-term data going up to 5 years was published by Ruwenhorst et al. With 5-year primary patency of 77% and secondary patency of 95%. EVOC trial has already been extensively discussed by Dr. Raghu, so I will skip past this. So key take-home message is CIRAB is highly effective for long aortoiliac disease, although there is a debate about which option to choose for difficult task D lesions. Proper stent sizing and deployment is critical, and you get those measurements from the CT. Adjunct tools like IVL and the re-entry devices improve your success and durability, and need more owners on the part of IRs to bring out quality research data with longer term follow-ups so that it can stand out amongst the surgical options. And trials like EVOC will help rationalize CIRAB for difficult task D lesions. Thank you.
Great talk. One word, subintimal or intraluminal?
I always try to go luminal first. If only luminal fails, I try to go for subintimal.
And when do you give up?
It's with the current tools and techniques, it's very difficult that you don't cross at all. Most of the lesions you'll be able to cross with re-entry devices, even with subintimal re-entry. If one axis fails, have a low threshold to switch to the other axis. So if ipsilateral retrograde fails, try contralateral. If that fails, you can always get arm axis, brachial or radial axis to try and cross the lesions.
You will still try a retrograde axis first, or
yeah,
come?
Most of our procedures we do with retrograde axis first.
But once you create a subintimal plane, then does it not become little difficult to get back into?
The thing is, again, we have very low threshold in using the re-entry devices, which helps us in precise re-entry into true lumen. So we don't try just with the wires for a long time, create a massive subintimal space, which makes it very difficult for the re-entry devices to be used. So I have a very low threshold to use the re-entry devices.
Yeah, maybe, but you're coming from the top, would it not, you can even avoid using those re-entry devices.
it's just about the logistics of the room layout and other things. We are more used to the retrograde access options. But again, if those fail, if we can't cross, we'll again have a low threshold to come from above. But in our approach as a setup, as a team, we always try the retrograde access to cross these regions.
A couple
Time
of
is
points
up.
I would like to discuss is, one, when was this task classification done and decided that which should be endovascular, which should be?
It was mainly a guideline. It was not.
Okay. When was it?
I think the two reiterations. I do not know the exact years.
It was years ago. 2007. Yeah. And today's, yeah.
And they
Yeah,
have
but
actually
it's
updated, they have
13
updated
years ago. So I think that has to change. Somebody has to change it. We can't, because the technology has changed, everything. Saying that, we today even ask the vascular surgeon, distal aorta, iliacs, their first choice is endovascular. So nobody wants to open up the abdomen. So now we have to change that whole concept of this task 2, where we have to modify our techniques and our decision making for doing these aortoiliac lesions. One. Secondly, I don't know about the rest, we don't have re-entry devices in India. And very, I mean, less than 1% that we fail. So I think that this re-entry devices are not the way to go. You have to spend a little more time, and sure enough you will cross.
Yeah, the only reason why we go for re-entry devices early in the case is mainly to avoid creating a larger subintimal space. It's again, I totally understand that totally different setups, different healthcare costs and economics are in play. But just the way we do the procedures is just to make sure that we don't create a big enough subintimal space.
In other words, what I was saying was, what I was trying to say when I said this intraluminal versus, so don't dissect and keep dissecting far enough. I think that's
one quick question for you. So regarding the technical point, do you have any experience of using self-expanding covered stent in the aorta for CIRAB, or you always go with the balloon mounted cover stent?
So yeah, we go with balloon mounted covered stents for the common iliacs and self-expanding covered stents for the external iliac if it's heavily calcified.
No, for the aorta.
For the aorta, we always use the covered balloon expandable.
Because there are certain anatomies which are not typically funnel shaped, they are more tubular. So even self-expanding stent in our setting, we often use in this setting. And there are also papers which not talk about the self-expanding covered stent, because the contemporary data about the CIRAB is regarding the balloon expandable covered stent. But there has been recent publication which also talk about the 1 and 2 year patency with this self-expandable covered stent in the aorta. So that's also an area where there had been change in the technical hardwares and these applications.
Yeah, I mean, I personally do not have any experience with self-expandable uncovered stent in aorta.
Thank you. I think we are running short of time, so we'll take this, and thank you for your brilliant lecture, and thank you for the lovely audience for hearing us. Thank you very much.
Thank you for the enlightening lecture, Dr. Vinay Kumar, sir. And thank you to the chairpersons for an amazing discussion. Thank you, sirs. And continuing with our session, we move on to the femorals. And here we have Dr. Raghuram L. sir. I think we are going to keep Raghuram sir for quite some time here. So, and for the chairpersons of this session, Dr. Vimal Someshwar sir, Dr. Pankaj Banode sir, Dr. Pawan Kumar sir, Dr. Arun Sharma sir, and Dr. Hirdesh Sani sir. We'll start off with CFA disease strategies.
As the chairpersons are settling down, I think my talk was almost turned down in one sentence by Sir when he said there's no role for stenting in CFA. So here's the rebuttal to that. Strategies, these are my disclosures. So there are always issues around why endovascular treatment of the CFA is the last bastion in PAD treatment. Now, you looked at aorta-iliac and you're going to look at femoral and crural, and everybody is going endovascular. And the question is, why not the CFA? What is the available evidence, and what's the developing research and technologies that are pushing us towards treating CFA? And for people who are not yet doing it, what are the technical aspects? How would you choose winners? Our eminent surgeon in the room kind of summed it up in one sentence. There is a problem with the CFA, and that's calcium. And that is the biggest problem. And those of us who've seen that really know that this is a very calcified structure. I'd also like to expand for the juniors in the room to try and understand there is a classification. Essentially, the question that we're asking ourselves is it purely the CFA that's involved, that's type 2, or is it extension into the external iliac, that's type 1, or the more difficult one, is it type 3 where it extends into the SFA and profunda, and type 4, not that common involvement of a bypass graft. Now the other thing is the torsion and compression of the CFA is a huge problem, which is why there is a thinking that stents are not a great idea. The French don't think that. The British are slightly behind and they're following. I don't know what the Americans feel, but there's a thumbs up from Kumar, so there you go. What does the evidence say? When you look at systematic review, what are the two important aspects? When it comes to immediate post-procedure, the wound hematoma rate, wound infection rate are much higher in open compared to endovascular. But when it comes to efficacy endpoints, that what happens with durability, the primary patency is much better with open, and reintervention is much more with endovascular. So we have a problem over a long period of time, and similar to what we're discussing with the aorta-iliac disease. There are a lot of current options for calcium modification. We will look at a few of them. Before, what used to happen is people used to do an angioplasty that was done across the peripheral arterial system. When it comes to the CFA, 40% of cases still have a residual stenosis, so you don't get the lumen gain. And then when you want to use a stent, you have the risk of restenosis, the risk of shuttering off of the profunda femoris and other places. That's why intravascular lithotripsy has really made a difference. Now, before we jump onto if you want to Google the cauliflower study, what they looked at is almost about 2,000 patients. Now, in this study, they were using just plain balloon angioplasty and drug-coated in some patients and stents in some patients. But when you compare open versus endovascular, there is still a drop in patency from 96 to 82% when it comes to 1 year. So open does much better with these technologies. You should remember that it's a non-atherectomy study, non-IVL study. Now, what about nitinol stents? And I think there is going to be some discussion with oven nitinol stent, that is the Supera. Now, even there is about target present revascularization is 92% is freedom from it. So 8% of patients end up having revascularization, and restenosis is around 12%. So why use intravascular lithotripsy in calcified arteries? Vessel preparation, I think, is unmatched to anything in the market. And I know that Kumar is going to speak about atherectomy, so this is a direct provocation. no need for a filter, low atmospheric inflation, decreased dissection risk. Now, if you look at the PAD 3 results in the CFA, there were pretty good outcomes with IVL. Coming back to that classification that I said, if you're trying to understanding that classification, once again, in my aortoiliac disease, I said that CT has made a real difference. Trying to understand the extent of the disease is extremely important. If you don't understand the extent of the disease and your strategies of how you're going to achieve CFA revascularization, then the outcomes will be much poorer. So if you look at this particular patient, it's a box standard CFA disease, and it looks pretty horrible when you see the angiograms. That is quite a calcific disease that's extending into the SFA. But when you use the appropriate sized IVL catheter, and previously it was discussed that you shouldn't use a small diameter catheter. If you use an appropriate size IVL catheter, you do get good results. Now, that's the pre and the post. Now, one of the key indications for treatment of CLTI is revascularization of many segments, and that is where the challenge comes, because you're revascularizing some external iliac, you're revascularizing femoral and SFA. So if you look at this box standard patient, 79, not the fittest individual, is there an endovascular option, is the MDT question. Look at the angiograms, there's some common iliac disease, there's common femoral disease, there's disease of the SFA, and a proximal SFA occlusion. So what we are seeing more and more are frail patients, and we are seeing patients with multi-level disease. So when you have multi-level disease and fairly good crural runoff, when you have multi-level disease, you start looking at options for treatment. The IVL balloon is very expensive, so the key thing is for you to determine that you use one balloon and fudge it across many segments, because you can't afford to use two balloons because they're very expensive. So once again, use the CT scan in order to measure and get an idea. So we decided in this particular patient to use an 8 millimeter balloon, which helped us pulverize the calcium in the common iliac, treat with a 10 mm angioplasty with a good inflow result, then go down and treat the common femoral, which is about 7 millimeters, with an 8 mm balloon, and the proximal SFA with a fairly good result. So you start off with something like that, and you end with something like that. So the final question is stent or not to stent. Now, if you look at this particular article that has come up in CVIR, common femoral arteries that are resistant, the patency is better with stents. And if at all you want a stent, which stent do you want to use? So if you look at this patient, older patient who's had a renal transplant with quite significant common femoral disease, we don't like stenting the common femoral for obvious reasons, right? So here's the angiogram. It's quite a significant amount of common femoral. So what was done in our unit was this patient was treated. First of all, the balloon size was inadequate. It was a 6 millimeter balloon that was used. And then this was the final result post-treatment. This is not going to last. We all know this. And it didn't last. It didn't treat his critical limb ischemia. And if you look at the post-procedure CT scan, you can see that there is quite extensive calcification that is still left within the common femoral artery. So we had to go back into that common femoral artery. This is the angiogram. So it's obviously worsened from where you left it. This is 2 months after the treatment. And then we used the right IVL catheter, 8 millimeter, into both origins. And once you've done that, some amount of kissing stent angioplasty led to this result. So when you see this result, there is still a significant recoil in the proximal aspect of the profunda, there is recoil in the proximal aspect of the SFA, and there is recoil in the mid-CFA region. So we had no choice but to stent it. We did not cage it. We did a kissing balloon stent of that reason, and it looked reasonably good. See what we have done to the calcium that we have not removed. What it's done is it's kind of pushed it centrally. This is a huge amount of calcium that is left there. And this guy's critical limb ischemia improved, his ulcers healed over a period of time. So the question, so where are we? Are we at a position where we can stand here and say that endovascular intervention is here to stay? There are two trials that should interest you over the next few years. One of them is this particular trial called the PESTO CFA trial with 306 patients. This is being done out of the US, I believe. And the second trial that interests us is the RAF trial. It's a NIHR trial. We've got the money for it, and it is starting next year in March. We are going through the final aspects of it. It's 504 patients, 1:1 randomization between open surgery and endovascular. So what we intend to do is to look at 1 year and 5-year patency with a primary endpoint of composite of death or amputation. So I would stop by kind of giving the juniors in the room, if you're going to start treating CFA disease, the ones in blue are the ones you want to start off with. The ones in red, you may want to kind of think back on it, because, you know, the ones in blue are the ones where it's stenotic lesions, there's mild or moderate calcification, not significant calcification involving the bifurcation. And I'd like to invite you to the British Society meeting, 2026, 4 to 6 November at Birmingham. Thank you for your attention. Was there a question on the floor? We have 3 minutes time.
Yes, a lot of time there. So I could see that you're itching to go on a debate mode with Dr. Kumar here. So last time we had a beautiful debate with you and Dr. Pereira. Just a quick question actually. Regarding the RAF trial, it's means endarterectomy versus endovascular treatment. So what the methodology for endovascular treatment means? You try with IVL first, IVL fails, you go for stenting, or you directly means it's a step-by-step, or everything is a single-step procedure?
So we have a problem in the UK. It's an NIHR funded trial. It's a public trial. It's not company based. So the way they use it is pragmatic. It is left to the endovascular specialist. The only thing that we ask is at the end of the procedure, you have less than 30% stenosis. So the device, what they use, and the technique, what they use, is left to the specialist. It's not left to so it's left to the operator. And interesting thing, there are 2 patients who are co-applicants on the trial. So the way they look at it is they want to know whether your long-term durability and amputation-free survival is worked. Okay. So it's left to the operator. But if you ask me a general question, it will be mostly IVL.
IVL. And stents, any particular stents they have recommended, means how you can use any stents you want?
What's that?
The stent, if in case it comes to stenting the CFA. So what is the stent recommended in that trial, or that also is up to the...
Stent's not recommended for the trial. Okay. If you ask me for a personal opinion, it's the Supera for the CFA. If you ask the French, they tend to use
Last
the
2
BARD
minutes.
stent. If you listen to the Life Science BARD stent. I have no conflict of interest with BARD. We do use it. You've seen that there are 2 BARD stents that were used in that particular procedure. So that's what the French use. We tend to use the Supera 7.5 for the common femoral.
Thank you.
Dr. Raghuram,
somewhere
over here on the
here.
stage.
Sorry.
A question. In your real life experience, how often or how scary is it, or what's your incidence that you have seen for complications of IVL, especially distal embolization and perforation?
Very low.
Very low. If you have to give a figure, like
I would stick with 0. If you look at that PAD trial that I said, it was both the PAD RCT, and there were more than 1,000 patients, all comers trial. Distal embolization is almost unheard of. I have fractured stents using IVL within stents, but not distal embolization.
Right, very encouraging. Any other question? For
Yeah,
Dr.
question
Raghuram?
there.
1 second.
Bully.
Hi sir, how you do sizing for the IVL?
So the previous speaker said about 20% oversize, that's fine. The IFU is 10% oversize. The point is, IVL is not a balloon. It is a device that allows you to take the shock wave onto the vessel wall. So the balloon is just molding onto the vessel wall. So the oversizing is required so that it kind of molds into the vessel wall and delivers the energy onto the calcium. There are 33 companies which are working on IVL, because the very fact that 33 companies are coming out with it shows that it is a good technology.
Dr. Raghu, I heard you talking and Vinay talking. I'm saying, when you are planning your procedures,
Time is up.
Is it at your discretion? Everything is available in the lab now, whatever you want to use them, because the syrup, you need covered stents. Do you need any kind of clearance, permission from the trust or from the management, or it is just at your discretion that you can use whatever you want?
It's becoming difficult in the NHS. We cannot use whatever we want, in the sense that we do get it stocked up before the case, but you fudge sometimes, you don't have the right stent. But with balloon expandable stents, you can expand it, you can funnel it bigger at the top and smaller at the bottom and all those kind of things. In answer to your question, it's not free for all, no.
Yeah, because we can't justify for unexpected cases.
Yes, that is the biggest problem.
So do you need to get a permission?
We'll have to cut it here because we'll go with the next lecture.
Thank you.
Thanks, Raghu, for that.
Thank you.
Excellent. The next speaker, yeah. So we have Dr. Lijesh from Kochi. He'll be telling us about his way of getting through the lumen or intraluminal passage. So,
yeah. So exactly, actually it's either intraluminal or no lumen for us in majority of the cases. That's how we practice. And so is there any evidence to say that you have to be intraluminal always? No. Means if you look at the data says that the results of intraluminal and subintimal are almost similar. And but if you want to be a bad boy or big boy or rich boy, you want to play with that costly device like IVL, atherectomy, you need to know how to be intraluminal, because those devices cannot be used in subintimal location. And there are few studies, actually, if you ask us, we started being intraluminal only intervention people before the atherectomy devices came around. And what we truly believe is that we have not, if you honestly ask us, there is no data from our side, we have not published anything. But with a proper technique of escalation, de-escalation of the wires, gradual escalation of the balloons, the results of intimal angioplasty, in our hands at least, is what we feel is that much better compared to subintimal, and the chance of putting a stent is much less intimal angioplasty, intraluminal angioplasty, compared to subintimal. And what does the Cochrane library says about atherectomy, because we're talking about atherectomy a lot now, is that the evidence is very uncertain regarding the use of atherectomy for patency, and there is no clear difference in initial technical failure rates of target vessel recanalization, and there may be reduced dissection on bailout stenting with that. And we know that for long SFA occlusions, even now the gold standard is venous graft, bypass with a venous graft. And angioplasty has been able to reach the results of a synthetic graft, but to reach to the level of the venous grafts, I think vessel preparation device is the way forward. So how to go intraluminal? It's by choice and definitely a lot of effort. So these are our strategies. One is wire escalation, de-escalation, rotary access, don't shy away from that. Consult the gains that you have achieved painstakingly, balloon support, use of EVAS, liberally IVAS, and preserving collaterals. So what is the, actually wire escalation, this is not a terminology that we invented, something that has been there for time, long time from the coronary CTOs. And basically what it means is that we always start with the smallest profile wire and smallest profile support catheter first. Our support means how the workhorse system that we use is 014 Rubicon and 014 command wire. If the lesion is very calcified, we start with the 018 system and 018 command wire. And it remains same, not just for SFA and popliteal, but also for aorta and iliac disease. So this angioplasty, this is actually not a long segment SFA occlusion, this is a short segment. And sometimes things that are very short, they also may take a lot of time. In this case, as I said, we have fixed protocol in place. We always start with the 014 system. This is the 014 system, Rubicon. Try to cross with the wire. 014 command is not crossing. Then we escalate with S20. There is again a 014 system. Then, because we are already exhausted 2 wires, then we took the 035 Rubicon, and with the back end of thermo wire, we crossed that. And this is how we did that. This is a pretty long video. Sorry for that. And the moment you cross that, you confirm with the aspirin, the shoot, aspiration, you got blood, and yes. You just confirm your intraluminal. And this is just a protocol we have. We just stick to that, whatever it is, whether it is calcified, means fibrotic, it doesn't change. Only thing that changes is if it is densely calcified, we shift from 014 to 018. So there are a lot of people are actually here who would have directly taken a 035 thermo wire or a backend of thermo wire looking at the lesion. Yes, fair enough. But this is the protocol we follow, because the moment you create a subintimal tract with a 035 wire, then coming back to 014 system is difficult. So we always try to escalate our wire access, then retrograde access. So this is an elderly patient with a severe rest pain, refused surgery, and in this case we directly took a pedal access. You can see the dense calcium here, and this is something that we follow. We use a lot of, you can see ultrasound probe here, right, in the last image. So in densely calcified lesions, what we do is we always use, ultrasound is a given for us, and whatever wire you are crossing with a straight tip, confirm with the ultrasound. If it's intraluminal, what we do is we always go and plasty that area if it's intraluminal. We don't start plastying after you completely cross the lesion. By plastying the lesion, by plastying the gains that you have got intraluminally, you achieve 2 things. Actually, you are consolidating that. In case you require a second access, the antegrade access becomes much easier because you have already plastied half of the lesion already. And second thing, by plastering that area, you create cracks in the plaque so that, and the balloon support is there, and crossing the next set of lesion becomes much easier. So, yes. And here what we have done is, because as I already said, the CFA axis was hostile in this patient. We have not punctured CFA, we have punctured proximal, occluded SFA, come retrograde down, cross the lesion from up, because here the crossing is much easier. The moment you cross the lesion from up, because you have already opened the artery down in intraluminal location, intraluminal fashion, the wire crossing becomes easier. Then snap the wire from down, plasty up to the puncture side, and cross, means crossing into the iliac artery after that becomes much easier because you already have balloon support. And these are final angiograms after that. And again, our angioplasty doesn't end with a good angiogram. We always confirm with the ultrasound of the pedal axis in case it's a critical ischemia. We have just done, we have just opened the femoropopliteal. We do a Doppler of the popliteal artery to confirm good flow is there. Only then does our angioplasty result ends. And this is actually a very tight lesion in which even the back end of the thermo failed. I have not shown that. In this case, we switched over because we started with 014. We had used 018. We have used back end of thermo, it didn't cross. And the patient was a critical limb ischemia patient with single distal runoff. We did not want to puncture that. So we just tried the 018 system. This is the 018 Rubicon catheter, and this is Astro 30. We always use Astro wires with a slight bend. And as I said, we always use under ultrasound guidance. You can easily, in many cases, you can just direct the wire across the plaque, recanalize that, and this recanalize that, and plasty that with, that was good. And consolidation of gains, just like, as I said, we don't wait to do an angioplasty till the wire crosses over the side. The issue with angioplasty means you do angioplasty before you cross out is, what if you are plasting in a wrong tract, subintimal tract? But here we are following the wires with ultrasound, EVAs. So the moment the wire, we see the wire is going intraluminally, and that is confirmed by the ultrasound. Yes, there is a keys. There is short stump, wire is going. We see that in the second case, the wire has gone slightly more. wire is not tracking. Then we dilate that. And again, I'm saying, dilatation of balloon there gives you added advantage of further
Last 2
support.
minutes.
And the plaque is getting ruptured. This is ultrasound EVIS of that. You can see the wire there. The moment we see an appearance like that, we know that it's intraluminal plasty there. And there is no better support than an inflated balloon. Yes, so just rushing through that. This IVIRS, actually this is a complex, this was a case of in which we are using atherectomy. This was a lesion, CFA was very hostile, we did not have access there. So in this case, we came contralaterally. Puncture means the wire was not going distally. We punctured distal occluded SFA again, plastid up to that region. Then using the balloon, inflated balloon, cross down, reach down. And because it was complex recanalization, we needed to know whether we are intraluminal. We use the IVIRS to confirm the wire is intraluminal. Distal filter was placed, atherectomy was done, and this was the result after that. Next, few cap breaking techniques. Use the back end of a thermo wire or even a 018 wire. We use that, break the cap, go distally. Then preserving collateral is something that we means we follow to the T in the sense that there is evidence enough and more to say that post-angioplasty results of the chance of acute limb ischemia is almost 3 times higher than in native vessel. The reason, one of the reasons for that is that you are disturbing a lot of collaterals while doing angioplasty. So in our practice, what we do is we don't puncture the recanalized segment because that's where the collaterals is joining. We puncture the occluded segment just above the recanalized segment, plasty the entire area, and then cross the last segment last. So multiple ways to open that. This is just our technique. These multiple SFA punctures are taken for same manner. We don't puncture the patent SFA. We don't puncture the patent popliteal artery. This puncturing means first distal SFA was punctured, then it was not crossing. Then you puncture the proximal SFA also. Cross that, snare the wire from up, came down, plastic down. So there are multiple ways of being intraluminal. Balloon support is there. Yes. Then, as I said, we use EVIS a lot. This is just one demonstration how we use EVIS for that. So EVIS, if you ask me, EVIS is the one modality that has made us say that you give us any lesion for the last 6 years, we have not failed to cross the SFA occlusion or popliteal occlusion till now. So thank you so much.
I think we do agree when you're crossing these lesions through the lumen definitely helps you a lot in these kind of patients. And as you said rightly, ultrasound is coming out to be a very good modality to direct your wire there. And these stiff rigid wires, stiff wires and your sheath support, catheter support, balloon support is all that helps in these patients. So hard calcified ones that are there, how do you manage it directing your wire? What is your strategy?
Again, sir, as I said, means if you are dealing with the calcium, the most important thing is that you have to cross the wire. If ultrasound, if you are seeing the lesion properly, the visibility is not bad. You can see, you can direct, as I said, we cross these calcified lesions using Astero 20 or 30, always a bent tip. You can direct the tip end of the wire in ultrasound itself, cross the plaque, go to the other side. If your wire is also tracking, best. Otherwise, dilate with the rhyral balloons, the thermo balloons are the CTO coronary, CTO balloons are there. Dilate that. And if still your balloons are not tracking and your, what do you call that, your balloon is gone, then inflate with a slightly bigger balloon. And once the wire goes, means it's very simple. And second thing is inflated balloon. Inflated balloon, if you're inflating a balloon just proximal to that, you have an axis in which the next wire that you place is usually in the center. So there are a lot of techniques for that actually. If still it's not working, Pierce technique is there, you break the calcium, all those things are there.
So one important question, anybody is, if you see these kind of lesion, is just doing a retrograde approach straight away. Straight away going with a retrograde approach. Some people are just talking about it, that retrograde approach, we know that the retrograde access is much easier. So anybody is just starting with that?
Retrograde access.
You want
to? Yes.
Yes.
Retrograde is actually the first access for us if the patient is a claudicant. If the patient is a claudicant, definitely. But if the patient is having a critical limb ischemia, we have to preserve this is a supply. Usually retrograde axis is not the first axis for us. And second thing is, if the patient is having a CFA, we actually had patients in which bilateral CFAs are disease. They are not accessible, or bilateral iliac is disease for means a lot of calcium is there, a lot of ulcerated plaques, and we don't want to touch the iliacs. In those cases, long SFA occlusions, calcio occlusions also we have done only with the pedal axis. But then we choose the pedal axis. We don't choose an artery that's directly supplying the plantar arch. We choose an artery that's not the best artery, because such long procedures, you will take 2-3 hours for that procedure. And any intervention done through a very small artery definitely has a chance of occluding the artery. So be ready for that the artery that you do such a long intervention is going to get occluded. So don't choose the only artery that's supplying the plantar arch in case of critical ischemia for that.
Any comments or suggestions you have anything to? So I think, thank you very much, Lijesh, for this presentation. Definitely a difficult thing to handle. The next is, we have the long SFA occlusion, how I plan my re-entry in subintimal angioplasty. And we have Dr. Anup going to tell us about his experience.
A very good morning to all. I thank the organizers for the opportunity at the outset. Going straight to the topic. So what is the challenge of a long segment CTOs in femoral? Often what you find is there is an absence of SFA stump or a beak to poke into to have a true lumen entry. And often what Dr. Vimal told is the calcification will behave like an ossification and it will be impenetrable. And majority of such patients will have critical limb ischemia, and they mandate a treatment for preserving the limb, and majority of these patients will have significant comorbidities and may not tolerate a bypass surgery also. So it's quite imperative to do an endovascular treatment, and the standard treatment often fails at least in 25% of cases. So subintimal angioplasty is a technique to cross such long segment occlusion, quite calcified, and here what happens is that the wire is made to slip into the subintimal space proximal to occlusion, and somehow the wire has to slip back at the distal end of occlusion. That's the challenging part. The chief advantage is that unlike the intraluminal procedure, this can be done quite faster, tracking, and the only re-entry part may take some time. So there is enough data to compare subintimal versus true luminal. There is superiority of true luminal recanalization, definitely. However, the long-term results are actually comparable by the Cochrane study, and the stent expansion in subintimal space also seems to be great. So what is the basic principle which should be followed is like the re-entry should happen at a place where majority of collaterals are not sacrificed, and we should preserve the healthy outflow for a further intervention or a surgical option, and we should avoid perforation. So how easy it is? It's not very easy. Even with the most expertise person, the manual re-entry chances are only 74 to 91%, and with the help of dedicated re-entry devices, it is far superior because we have an option to have a controlled re-entry at the desired point. So the basic concept is in the subintimal plane, the re-entry devices need to be parked, and using a cannula which is attached to that, a wire is passed and re-entry happens. So this is the armamentarium for the re-entry devices. This one is IVUS based and remaining are fluoroscopy based. In the interest of time I am skipping. So there is superiority for re-entry device based manual in comparison with manual re-entry techniques for the long-term patency with this RCT. So I'll straight away go to cases, I am focusing only on manual techniques and not on re-entry devices because we don't have it. So first case, it is a left SFA occlusion, long, then with a single outflow of anterior tibial artery. So we crossed with a hydrophilic wire and a hydrophilic catheter. Then we switched over to a system which I am going to tell the technique which we tried. Just distal to this collateral vessel, we re-entered and we entered subintimally, and then we re-entered just proximal to this stenosis. Hope it is seen. Yeah. Okay. So we can see that dissection flap and the re-entry site restenosis. So we went ahead with stenting that location. So there is an interesting finding here. So we have covered the distal end very well with the stent. The proximal end also we reached till the entry point, assuming that this was the entry point, but actually the entry happened slightly proximal. So finally we have to extend the stent with a balloon mounted cover, balloon expandable bare metal stent, very short one, and the result seems to be good. So the learning point, not only the re-entry point, the entry point coverage as well as ballooning or addressing is equally important. Second case, so here I will discuss the technique which I used in the previous case as well. So this is again another long segment right SFA occlusion. So this is the distal runoff, and here it's the disease segment. Here also there are a lot of calcium we can see. So once we reach this beyond this calcium, we change the catheter to an angled tip catheter with a bevel. So here as we see that for re-entering, we remove the wire and we make a jerking movement with the catheter, and this bevel will penetrate the intimal flap and will allow the passage of wire. So this is the diagram. Like first we'll cross into the subintimal space with a hydrophilic set of wire and catheter. Then we exchange to this angled catheter. So how we keep this length of the angled catheter is based on the half the diameter of the distal vessel where we want to re-enter, and we make a bevel which is pointed down so that once the penetration of intimal flap happens, the wire can slide down easily. So this is the rough demonstration. Now this is the third case. So this is another 74-year-old lady, right grade 2 gangrene, and she had to undergo a mid-tarsal amputation with poor stump healing. So this is the CT. So as you see, there is complete occlusion from SFA ostium onwards, no stump, and lot of calcification, nosification, all those dense calcium, and even till the adductor canal or the proximal P1, there is significant calcium. So overall, this is a poor re-entry candidate, but still we gave it a try. So this is the total length is 27 centimeter occlusion. Another important finding what we are seeing is that this profunda branch is also having some significant stenosis, and the distal outflow, we are hardly finding any great outflow. So here to enter into the SFA, we used like EVAS guidance and angled catheter, slid a thermo wire. Then the path we dilate with this Bolia loop. This Bolia loop, you should keep it small enough for the vessel size only, not larger than that, and it should be continuously supported by this catheter. Then once the desired location happened, we withdrew the wire because we thought like the vessel had a significant disease. Crossing may be better with a CTO catheter and a CTO wire. Through the vertebral glide, we advanced a CXI 2.6 and a CTO wire Asahi. But even with multiple attempts, we were not able to enter the
Last 2 minutes.
true lumen. So we tried a distal femoral axis again. So this distal femoral axis still tracking. The wire across that calcification was almost impossible. We tried ballooning the profunda vessels just to increase the flow and to have a better visualization whether we can recruit any hibernating segments or something. So we identified that PTA was slightly better opacified. Then we took this retrograde axis, angioplasty is the PTA, took the crossing catheter, CXI and Asahi wire back till the CFA, and then did the rendovo from the CFA. Dilated the entire track with a 3 mm balloon and then with a 5.5 long balloon. Then we did the supera from below using the sugar technique, again with EVAS guidance. So I think this technique will be detailed in the next talk. So I'll just summarize like what are the main re-entry tips what we follow. One is tend to avoid the locations of significant calcification, tend to preserve maximum collaterals, potential bypass sites should be kept intact. We should stop at that point beyond a particular limit. Use orthogonal views whenever possible.
Time is up.
The rule of thumb is to keep the loop as small as possible, and we have to escalate the strategies every 5 minutes. Don't spend too much time with the same false lumen. It will increase in size and you will never regain the true lumen entry. Choose wires with straight tips or more stiffness, or even 1/4 or 0.18 inch CTO wires for getting adequate push. Then use EVAS guidance. So this is one difficult technique described in literature, the snare piercing maneuver, where a snare is kept in the proximal and a percutaneous ultrasound guided needle passage. Then through that a V18 wire is snared and the catheter is tracked into the true lumen. So complications are part of subintimal angioplasty with perforations and aneurysms which need maybe coiling or covered stent placement. So the takeaway points is that this is not an essential technique, but it's not an elective technique, but an essential technique to understand, and re-entry devices helps things happen better. The historical evidence for subintimal techniques are not so great, but still it's an essential armamentarium which every intervention radiologist should know. Thank you for your time.
I think that was quite interesting, your jugaad. I mean, hardly any cost.
Yeah.
So any particular catheter, any French size that you prefer?
We tend to prefer a stiffer 5 French catheter, the JR or Picard.
Okay. And have you found that maybe a reused ETO catheter is a little stiffer and maybe better?
We use ETO catheters alone.
Yeah, right. Okay, thank you.
Sir, I think Anup sir, you are not using too much of pedal. In Lijesh sir presentation also I saw that there are very less use of
No,
pedal,
my topic is
subintimal
crossing only. I think there is a second topic coming for re-entry from pedal.
Okay. First thing is that when whatever the lesion you shown, if you can come from down, it is very easy to cross. You don't have to do this many. Radiation exposure you can prevent at least. Pass the wire, snare from the above.
The first case had a single outflow. Single outflows we usually don't try from pedal. That is our rule.
But sir, if PTA, like suppose single vessel is there, ATA is flowing, if PTA is closed, you can come to the closed vessel also, you can pass wire and do the...
Yeah, we know that technique. It's not new, but since the topic needed highlighting, with the interest of time, I focused on certain reasons.
Thank you Dr. Anup for the excellent presentation. Okay, for the next talk, we invite Dr. Pradeep, who will be discussing about antegrade and retrograde approach in difficult femoropopliteal CTOs. Dr. Pradeep, thank you.
Good morning, everyone. I think my life has been made both easier and tough because of the previous talks. Because some of them will be actually repeating. I think we all have the difficult cases. I personally have moved on slightly away from where the Lijesh is working. We don't use, O14 and O18 wires. I think we just learned over a time of years. So I'll just try to use some words, the safaris, carto, reverse carto. I don't think actually it makes much of a sense because as one of chairpersons was telling, the retrograde axis has made everything so irrelevant nowadays. So explaining everything is beyond the scope of this presentation. So I'll try to kind of list what we do. Simple antegrade interluminal crossing, we all do that. Antegrade crossing subintimally and breaking into the true lumen. Now I think I'll try to show a case how we try to not overcomplicate it, and obviously the card technique, reverse card technique, not to forget the sharp recanalization, which is cheaper, easier with ultrasound, as everybody has been telling. If you are able to see them, then you can target them. And the bidirectional angioplasty technique. I think this is the key part here, the procedure planning. You need to have your imaging in place. We do a lot of MRs, CTAs are less, and of course you have an ultrasound, you can plan everything on that. And access strategies, personally, antegrade is 90% initially, ipsilateral, and crossover we rarely use because it is quite complicated if complications happen. And retrograde, I think it is a very, very low threshold nowadays. You try to do it probably within half an hour or 20 minutes of starting the procedure. And we try to do sheathless if possible, wherever it is needed because the complication rates are less. Equipment selection, I think the go-to wire for us is a straight Terumo 035, antegrade and retrograde. We have learned over the years that expensive wires, with the financial constraints that we work in, adds to the cost. Catheters, standard catheters, or you have support catheters like CSA and Navicross. Re-entry devices, I think after coming back from UK, I think I've never used an Outback. This was almost 20 years ago now. And bailout, always have covered stents and aspiration devices because you can land yourself in trouble. The key point is in the tibial axis and retrograde axis, antegrade axis, if you're not crossing in a couple of hours, I think we should leave it to try another day or another way to deal with it because complication rates become worse, and these are all elderly patients, and we are actually putting them at risk of the comorbidities. I think we are all aware of this slide, the top cap, bottom cap. I think these things have made things easier for the retrograde axis. We all know that A is the easiest one to cross, and the rest all, the wire tends to go subintimal, then we use the different strategies to come back. So we'll straight go into the different cases. Case number one, here there is a flush occlusion of the SFA, reconstitution at the adductor level, and plan was to go for the antegrade axis provided the body habitus is favorable and see how it goes. And as everybody has been telling, ultrasound is there for us to use. Please use it right from the axis. I'll tell you why it is important, because here, as you can see, it's a flush occlusion. So we used the antegrade axis, and we use the ultrasound initial first few centimeters is important that you are intraluminal. You are not subintimal right from the origin of the SFA. Then, because you are at the risk of compromising the profunda. And the angiogram shows recanalization and the distal runoff. And initial straight Terumo, intraluminal at that part, and then obviously it started going subintimal. And that is where it was trying to go back in. Now, previously I would have been very aggressive with subintimal, but here I just step back a little bit, and then try to see whether my wire is going. If it's not going, just very simply do 2 obliques. Then actually you will see that you will find a way through. In the third image, I found there was a way just next to the collateral, so change it to a smaller low profile wire, 014 wire, and I was just able to manipulate using the fluoroscopy roadmap technique, and just you do the angioplasty, and the rest of procedure is easier. You can do whatever you want, depending on IVL, no stent, it's up to you. The second one is cheaper, easier with ultrasound. Again, it is makes things very favorable for us. Short segment occlusion of the SFA here, and as you can see, it is very heavily calcified. So we tried initially antegrade, and the wire was not going intraluminally, and it was actually going subintimally rightly. As somebody said, don't create too big a subintimal track, and you can see the runoff distal axis is difficult because the peroneal is the challenge one here. So what did we do? We have a distal SFA. If you see this, it is patent, and we thought it is better to target that. And here we only have a dilator. We actually don't have any sheath, and I was micropuncture set the 5 French dilator, and then start with a straight Terumo wire, and it was just hitting the calcium. It was a rock hard. So what do we do? With a word of caution, I would say use ultrasound here and see how much length occlusion you have to cross, and then if you are able to see that very nicely in a reasonably thin patient, then I simply use the back end of the Terumo here to just guide it initial little bit to create a path, and throughout the procedure ultrasound was used. And once I am comfortable that I have got enough purchase now, then you just turn the wire over. It's up to you. You can use an 014 wire after that, but our strategy is to use a straight normal Terumo once you create the track, and then we generally don't use snares. We just kind of capture that in a 5 French catheter, and then you finish the procedure with a plain balloon angioplasty, and calcium was quite bad, so we did IVL. It was a on-table decision, and then we got a reasonable result post-procedure. So we just have to be slightly innovative and individualize each case. Try not to sometimes complicate it too much. So this CART word has actually come from the cardiology circles. I think now with retrograde axis, we are probably using it without probably giving much of a name to it. So this is again a complex case where you got an occlusion right from the origin, and there is a distal reformation at the rectal canal and the popliteal artery, and antitibial artery is the runoff, but the origin of the antitibial artery is occluded. So here we tried antegrade, and it was not crossing, so we straight away took the popliteal axis. So we don't turn the patient prone. We usually do it in supine position. If you have to go through popliteal vein, you can, you can just get the hemostasis through the balloons, and then we try to cross from below. Here in this case, we use the sheath. So we took a 4 or 5 millimeter balloon, tried to angioplasty there, and then because we already had an antegrade axis, once the angioplasty was done, the subintimal plane or whatever we were trying to do from above, it gave away, and then we were able to cross from the antegrade into the distal through the into the lumen. And from here, the rest of the procedure was relatively straightforward, and access site issues can be there, especially in the calcified arteries. And here popliteal, you can see the leak is ongoing, but it's not causing too much of trouble to us and to the patient, and we balloon tamponaded it with external compression, and with a bit of an effort it did stop. And you can see the sponge holder, you don't have to get your hands into the fluoroscopy, use the sponge holder to give external compression along with the balloon tamponade from antegrade. And you finish the procedure with stenting. I think it was a prolonged procedure, and do anticipate problems. And in this case, we had a problem at the access site because we used the angioseal for the antegrade puncture. In retrospect, probably it's not a great decision. So we had to use a crossover approach, and with again ultrasound guidance, we plastered the angioseal, the complication there at the CFA, and then we got over it. And distal issue was tackled right at the beginning. So don't forget, prolonged procedures, access site issues, always have in mind. Always have your extra hardwares with you. Then, as some of us were talking about, retrograde pedal access for the long SFA occlusions, and in this case SFA and popliteal occlusion was there. And as you can see, the index limb is the right side, and there is a very, very small stump there, and a small popliteal artery patent, and again the ATA origin was gone, and the TP trunk was not favorable. Again, I reiterate here, ultrasound guidance, antegrade puncture as much as possible, and try to get into the true lumen in the first few centimeters, so you're not compromising the profunda. And long subintimal loop here, unfortunately we couldn't get back in because there is no healthy artery for us to get back in, because there's the whole principle of subintimal is you need to have a healthy artery for it to break back in. If you can see the SFA and popliteal, there is no healthy segment for it to come in. So what did we do here? So we straight away took the pedal axis, ATA, and then we didn't worry too much about having a distal subintimal loop as well. And here we crossed from with a subintimal loop, and we had a balloon from the antegrade because we already did a couple of angioplasties from there, and because we already created a loop there, and luckily the wire simply slipped into the from the subintimal into the true lumen, and we plastered and we got a reasonable result. So don't give up, keep trying, but obviously we need to know where to draw a line. And not just subintimal, always remember a simple luminal crossing also is possible. Here we use a straight termo. Here you can see the SFA and popliteal occlusion which is extending into the ATA origin. Distal ATA is a good target. So we took the distal ATA axis, and the wire simply slipped through from distal ATA across the ATA occlusion into the SFA, and we just captured the wire into the antegrade catheter and finished the procedure. So, and this is the difficult one. You know, you try everything and you don't get much options.
Last 2 minutes.
The occlusion, a long segment SFA again, and here popliteal was patent, ATA was patent. Initially, antegrade approach didn't help, so we straight away took the ATA axis, and distally from retrograde axis also it is not breaking into the true lumen, and this is where we are struggling, you know, that is where we want to come in, but it's not going. So we kind of converted to bidirectional angioplasties. Now you have got two proximal and distal axis. You do one by one antegrade and retrograde balloon angioplasty, and then the wire slips in, and then the rest of the procedure you can complete whichever way you want. And the thing what I tend to do is always tamponade the distal axis, because these are diseased vessels. We don't want any flaps to be raised and compromise the outflow. So we always get our antegrade balloon back, a smaller balloon, and give a tamponade. I think this is just a working algorithm. We always do it. Choose your optional, optimal access site. For us, it is antegrade, and you keep changing between antegrade and retrograde depending on what you are trying to do. Don't forget, we always can come another day and do it. If it is prolonged procedure, try not to make it any further. Key takeaways: keep it simple. Antegrade first approach. Retrograde, don't delay it too much if you think the success rate is going to be high. Ours is always sheathless, And our go-to wire is straight Thermo 035, and don't forget use of ultrasound and avoid prolonged procedure times because complication rates are higher. Thank you very much.
Yeah, any question or comment from the audience for any of the 4 talks? Yes, Dr. Priya.
Never. Yeah,
What is that? IVIRs for difficult crossing.
I think crossing we have not used. We have used in whether to stent or not in some cases, but not for crossing purpose.
I think, Priya, I think in peripheral, I think our regular ultrasound should be good to direct your catheter and wire in the lumen or not. So IVIRs to cross may not be, but once you have crossed and you want to get your results, probably IVIRs would be a good choice. Anybody? Yes, Lijesh?
No, yeah, we are using ultrasound, but I am asking for a very, very difficult crossover vessels. You know, IVIRs also is one way to go about it.
Yes, yes. Yeah, Lijesh, you had some suggestion.
So just adding to that, antegrade CFA access, actually all our cases are angioceal. Means 100% we are angioceal for antegrade CFA access.
My question to all in the audience and in the panel, these re-entry devices came in very strongly at a point of time. How many of us in India are using it, and how many my colleagues from abroad are using this? What is the status now about these re-entry devices? Anybody using in India? Viru? No. What about you, Sura?
So I use it in England, I don't use it here.
So you use it
but
then?
It is like the earlier talk, it is, if you have it, it is incredibly useful to reduce your subintimal distance, increasing the length of subintimal passage. You can decide where you want to go in and you can go in. And based on calcium and disease, you can decide and go in.
Dr. Tay is here, or anybody from abroad who is still using it quite frequently or whenever necessary is available. Yeah. How about it? You are regularly using it? Yeah.
Yes, use it quite regularly because it does shorten the amount of time. You can still accomplish all of this without it, but I would say us with trainees and everything, it reduces by 50% of time with different B-back, Outback, Pioneer, whichever one. It's not absolutely necessary, but neither is a seatbelt. Some things help you. Sometimes it may shorten the effort it takes.
Yeah, so I strongly feel it is worth, but somehow we have not used it. So the various companies have withdrawn it. Most of them, I think, none of these Boston or anyone is supplying us these material. But okay, so. Yes. Yes. So definitely it has a use, but unfortunately even we are not using it. And so any other questions or any other from the audience? Otherwise, yeah.
Dr. Anup, in how many percentage of cases you saw distal emboli while doing subintimal angioplasty?
Subintimal, actually, the chances are extremely low. If you go, distal embolization will be extremely low. The only indication for stenting is to seal the re-entry and entry points. But with true luminal, we have found significant distal embolization and often resulting in acute limb ischemia as well. But the distal tracking, if it doesn't happen correctly, maybe some acute limb ischemia might happen.
Thank you. Thank you, Dr. Pradeep.
No, I think that's it. Yeah. So thank you everyone. Rajesh?
You are likely to cause a perforation. So you do a small amount of angioplasty with a small balloon, and can you still use it in such patients? Anybody? You won't?
Oh, sorry. Sorry. You could do it, but it's with high risk. Once you do the barotrauma with ballooning, depending on which atherectomy, rotarex, jet stream especially blades down, you have a high risk of perforation. So I would recommend, if you can avoid ballooning first, don't. If you have to, IVL, laser, other ones may be safe. Jet stream, I worry a little bit. Rotarex, you may get away with it.
With the directional atherectomies, if you do balloon plasty first, there will be more chances of throwing emboli.
Mainly I was asking, I wanted to know about rotarex, use of rotarex.
Actually, if you see, the way the rotarex works is you need to have some antegrade flow for the lubrication. And for tracking, if the device is not tracking, then they do recommend go with a smaller balloon because it doesn't have blades. So you just have to be careful, that's all. You can use it.
His concern is in subinterval.
No.
No.
It is through the lumen, right? So in such situation we use it with a 3 mm balloon or so, a small lumen is created. Can we use a rotarex in such system?
So when not sure, the answer is no.
With the directional, you can definitely use it when you are subintimal. You can cut it on this side.
I had perforated. I had perforated with a directional.
No, so with so many cases, what we have done, in fact, Murli, in your lecture, you have one point where you go subintimally and then enter into the lumen. So if you see that, you just have to cut it on the opposite side. You don't have to cut on the side of where you have gone subintimal. So that one pass will give you a good amount of lumen, and then you can balloon plasty it. It's like a subintimal entire balloon plasty then. Exactly. No, but on that we have done a thickness. If you see it on CT, the thickness of the adventitia on a SFA, that will be somewhere around 1 or 2 mm. And what you are cutting with the directional atherectomy is just 0.3 millimeter. That is the thickness of the blade. So unless you intentionally, repeatedly do in the same pass, you will not perforate the artery. No, but sir, if the wire is not crossed, there is no point of using any of the atherectomy device.
Thank you. Thank you, dear chairpersons and speakers. Just stay on stage for a photo, sir. The speakers, please. Anup, sir. I think Dr. Raghuram is in the global IR. Thank you all. We move on to a session that requires your rapt attention. An expert lecture on atherectomy, directional, rotational, orbital and laser by Dr. Kumar Madasiri. The chairpersons for this lecture will be Dr. Atul Revatkar sir, Professor Dr. Vivek Ukirde sir, Dr. Naveen Mulimani sir, Professor Sanjay Sharma sir, and Dr. Vikas Rastogi sir. Thank you.
Good morning. I think we're done talking about atherectomy after that last debate just now, so I'll just walk off the stage now. But thank you so much for the invitation. I enjoy coming every time so far. This is wonderful. Introduction slide. This is my disclosures, my conflicts. I have so many conflicts, I think I'm unbiased, so that should be fair. I work with everybody pretty much. Coming from the West, this is where I work. You'll see me here, but I also come from another West, right across from here on the west side of India, so it's great being close back to home again. What are the objectives here? Atherectomy is a very difficult topic, even in America, even though we throw a lot of tools around, money around, we waste a lot. It's also cause of the most amount of lawsuits. And if you've seen the New York Times and all that from 2-3 years back, this created severe problems for us. So atherectomy is not an easy topic. Especially here, I know cost here in other countries is very prohibitive. But that doesn't mean it's not a good tool, and maybe you can fight for it or need it in specific circumstances. So I'm going to talk about where atherectomy and IVL, which we've talked about already, is beneficial, why there's disagreement, and where it's used. So why do we need it? Do we absolutely need it? The answer is no. I don't use it for every single case, but I'll tell you, plain balloon angioplasty has abysmal patency rates beyond 1 year. Even at 1 year, unless you have a wonderful soft plaque lesion disease, you have a 5-centimeter lesion, we don't get patency rates that are 80, 90% at 1 year. I think if you look at studies, you always get good results with POBA, because if you do a study, you're part of a PI, you do everything to the perfect level. You have great follow-up, you have great patients, great medications. In reality, patency rates are very terrible, especially below the knee. If you do a CTO below the knee and just balloon angioplasty, half the time I'd like you to take a picture at 15 minutes, you'll be surprised that the vessel may have shut down. That's not only because of atherectomy, but because of what the vessel has in the disease process. Calcium makes it even worse. And you know, you got the patency is little. And we hear this comment, you know, patient is too risk for surgery, go ahead and do endo. Let's see how it goes, you know, let's just try it. To me, that's a garbage answer. We have to do better at endo, so we're not saying we'll do endo because surgery is not possible. We'll do endo because that's the best option. Now, we're not there yet even with atherectomy, but I'll talk about maybe how we can make it better or when and right it may be helping us. So specialty balloons are also there. We have, I don't know what the availability is, but we have the scoring balloons, the sculpting balloons, serenator balloons, and focal force balloons. There's no head-to-head data saying that compared to plain balloon angioplasty, they are necessarily better. There are small studies, and every company has wonderful data because everything works great when a company sponsors it. That's just how we know it. Whenever you do angioplasty, you'll 100% create dissection, but they're probably going to be micro dissections. You may not see it. Macro dissections are the ones we have to worry about. In reality, when we look at an angiogram on a fluoroscopy, we will miss a lot of dissections because we think it looks good. Our eyes are attuned to watching the contrast. We look at the flow. I guarantee you'll miss some dissections. Now, whether it's important or not, we don't know. Everybody doesn't use IVUS, which I think is a detriment as we get more and more understanding of IVUS. Again, cost prohibitive, but it teaches us what we're missing. But if we have to use more forced open vessels without atherectomy, using high focus force balloons, you create more dissections. You decrease the ability to avoid stenting. And, you know, 10, 12 years ago, I did a complex calcified case, and I was told aggressive balloon angioplasty will take care of it, and this is what I did, which was not good. Horrible subintimal calcified tract, ballooned the heck out of it, didn't help, and this is my terrible stenting afterwards. I didn't have access to IVL 10, 12 years ago, nobody did. Didn't have any other atherectomy. I didn't do anything else. I was always taught under just balloon it, balloon it, balloon it, and stent it. This stent never expanded well, and it's never going to expand well no matter what I did. I tried to get him a bypass, took several reinterventions. So knowing that, this is not a good result. Even though I can make this look better on angio, I can make it look dark. People will say, looks great, you restored flow, it's good enough for now. If that's you or my leg or your mother's leg, that would not be satisfactory. So what's the goals of atherectomy and IVL? We want to try to get ways to reduce the plaque to have low pressure angioplasty so that you get less dissection, less plaque shift, less stent bailouts. And for heavy calcium with IVL, which we've shown in several different vascular territories today, you get better full stent expansion. And maybe there's an argument about better drug uptake when you're using drug-coated devices and balloons. Types of vessel prep. The ones I'll try to cover are the ones I've used: directional, rotational, orbital, laser, and IVL. And what about calcium? We're not necessarily trying to debulk a lot of calcium. That's not the goal with atherectomy, because you're not going to be able to do it successfully. With calcium, all we're trying to do is increase the compliance, as was described before. You're trying to make your next balloon, your definitive treatment, go at low pressure to reduce the recoil, to reduce the perforation, reduce the need for stenting. So with directional, the one most commonly for the last 10, 15 years for us has been the TurboHawk. This one has a angulated cutting head, which as you shave it, the plaque goes into the front of the nose cone. It's 6 French, it's disposable, so no capital equipment. I know it's still expensive. It collects most of it. However, I will say that I will use a filter every single time I do directional atherectomy, and almost any atherectomy in the FemPop. It's a patient, you can see that there's disease at the proximal SFA and the profunda, distal SFA, proximal popliteal disease as well. And putting a filter, if you look in the middle image, you'll see the filter down in the popliteal segment. Did atherectomy with the directional of the SFA as well as the profunda. On the right you see after the SFA, treating it, and then did just drug-coated balloon. And I think the profunda, we have to be careful. You should never disrespect it. You should treat it very carefully, because the profunda is a lifeline, but sometimes you can do it if you feel that's the best for a patient, especially with wounds or you worry about recurrence. And this patient did the directional, did plain balloon, and then drug-coated balloon after that. I know it's an expensive process, but if I can limit this patient from coming back for 2 years, that's a success. And there's data for directional atherectomy. The definitive LE had almost 800 subjects. Claudicans and CLI, you can see that they had up to 80% at 12 months, which I guarantee you, just with the plain 5-6 millimeter balloon, I don't know if we can consistently get that in heavily diseased, multifocal stenotic patients in most of our patient population. I don't think that's what we're seeing. Where do I use it? Non-calcified plaque that are not long lengths, because you repetitively take out the plaque from the nose cone. And also where I can put a filter, because every rep will tell you, you don't need a filter, my doctors don't use filter. 100% of the time you should use a filter. That's the one that's going to bite you. So be careful with those. Rotational, Phoenix. This is a front-cutting Archimedes screw. Archimedes, that was developed for water delivery, has been used in several atherectomy devices. It's a disposable unit again. EASE study, of course, every study is wonderful. It had 0.8% embolization, which is incredible. I don't know if that's reality, because when I talk to friends who use this, it's more than 0.8%. So be careful with all of these devices. But it is a front end. It is an Archimedes screw. Here's a case example. It's a friend of mine, of course, because I would never show such a simple case. Looks so straightforward. I don't know why he did it, but he did it mostly for the AT. You can see that it does this cutting, and the plaque goes backwards into its own little collection area. And of course, you get a beautiful picture. You don't show the foot because it's probably gone. But it works well. It's great for outpatient centers, labs. It's a very small device. Rotarex, which was talked about. I mean, there's 20 years of data with Rotarex, heavily used in Europe, Germany, and everywhere else. Again, Archimedes screw pattern. It goes from 3 to 8 millimeters. It has a negative pressure from that aspiration. You can see how wonderfully it works in cartoons. I've used this quite a bit in the past. You can use it for ISR as well. The one issue I'll tell you is that there's a lot of separation that happens in that front end. You have to be careful with that and use it appropriately, but everything looks great. This is the whole setup. It's not cheap, but it's better than some of the other devices in terms of its comprehensive approach. The picture on the left is the main handle that drives it. You have a collection bag where the material gets collected to. There was a retrospective French study looking at ISR and CLI patients. You can see that 6% embolization is not good. That's too high in my mind, but I think filter usage should be used in all of these things. You can see a case here, SFA occluded, distal reconstitution, antegrade access, Rotarex 6 French. And there's a filter here because I think that's just how you should be careful with these. And you do very carefully, go slow, and you're able to collect the debris, you're able to do the balloon angioplasty. Honestly, DCB for most of these, stenting if you have to. We're not against stenting at all in many locations because I try to do whatever it takes and not have them come back because I wanted to give balloon angioplasty a trial. I think IVUS would help you decide that. Sometimes IVUS may mislead you into maybe doing too much, and that's where you learn how to use it judiciously. It's also used for native and prosthetic bypasses, stent grafts, ISR, and thrombectomy. So there are places that are using this as a thrombectomy device. I don't use it in that manner, but you can use it. Again, be careful with that front end of it. It does tend to spring and separate. Somebody had brought up Jetstream. There's two different devices for Jetstream. It's also rotational, has blades up and blades down on the larger device. Be very careful. People use the blades up in ISR, and let's be very careful. It can snag on stents. I wouldn't recommend it. However, it also has this thrombectomy part of it. Again, this Archimedes screw pattern. You can see it's a disposable system. And again, slow motion through different plaque morphologies. So you can use it with acute, subacute, chronic lesions. I wouldn't use this as a long thrombectomy device again, but there it is, you can use it. It's a patient here, you can see a P3 occlusion with a high takeoff of a tibial. Initially had 2-vessel runoff after reconstitution. The Jetstream was used across into the AT. Looks great on that high takeoff. However, if you look at it, lost a vessel. So that's the thing you gotta be careful. We don't have filters for tibial vessels. There are newer systems coming out where you can have perfusion arrest, which may help with this. So I had to use aspiration to get that clot out, the plaque shift. So where do I use it? I don't use a ton of it, I gotta be honest. It's good if you can use it. If you need to have something that has multiple uses, it's kind of like a Swiss Army knife. Orbital atherectomy. So this is now something it's been around for many years. Abbott now recently bought it in the US. It's a diamond tip device. It has low embolic rate, however, it's not zero. And if you're aggressive with it, especially above the knee, you will cause significant embolism. You do not use it for ISR. It has 3 speeds, and you basically decide how to do it. It has its own proprietary wire and solution. What we know is that calcium reduces patency of everything. It's been shown enough times, so calcium is the biggest problem you have to deal with. There is capital investment in this system. You have to have the pump, you have to make that solution, you get the proprietary solution, you add some local pharmacy components to it. You have 3 different crowns, and you have to decide where you're gonna use what. I'll tell you, when I use this, it's mostly the micro crown and the tibial vessels. That's where I mostly use this. This is what it's doing. It's increasing the compliance of the vessel by sanding the vessel. It is not debulking unless you do it the wrong way. So you're creating tiny, tiny sand particles that are smaller than a red blood cell, allegedly. What you may run into is that sometimes you get a blue toe syndrome which resolves, so be careful with that. Here's a patient you can see, similar to one I showed you where I failed before. Heavy, heavy calcium throughout, and distal reconstitution, has a decent runoff. For this one, I would choose a solid crown, probably a 2.0, and then basically do slow orbital atherectomy at low speeds, and you can use high speeds, but I prefer low and medium speeds, and I use different filters. You should consider using a filter because the calcium above the knee is different than below the knee. So you have to be very careful about what kind of complications you may run into. This is the one you have to use for CSI. You can't use a spider for CSI. And this is what I caught in one of them. So this is the kind of stuff when they tell you don't worry about embolization. If this went down to the tibials, you'll turn a claudicant into a claudicant. So be careful with those kind of things. And this is the end result to get result. And just remember, this is what my other patient looked like. So had I had different tools, maybe I could have avoided some of that. This is the kind of blue toe syndrome flex you might have to worry about. And so just be cautious of that. Another situation where orbital can be very helpful is you'll do this complex tibial revasc, and the problem is nothing will pass. You only have a wire, nothing will pass. In those rare circumstances, if you're comfortable with it, you can take the micro at low speed and use it to create a channel and get through it. I'll use it for diffuse calcified disease. Above the knees, I use a filter. Laser, there's 2 types, Excimer and RU1, 2 different wavelengths. It's nice because it can debulk, it can penetrate CTO caps, and use it for ISR, it has data. This is the system. The middle one was the horrible system they used to have. On the right, they have the newer one, which is a 110 volt, which is much better. And it basically pulverizes anything in its front of it. With the Philips, you do not use it with contrast. It creates a heat reaction. With the RU1 laser, you can. So this is a laser system. You go very slow, 1 millimeter a second. This is an ISR case. Again, 1 millimeter a second. Now, if you just balloon angioplasty ISR, I question it because all you're doing is smashing that hyperplastic material. So I don't know what everybody's using for ISR here when you don't have atherectomy, but I don't understand how you can just smash plaque against the wall and leave it there. So I think you have to debulk it, in my mind. There is data showing why it's beneficial. It has data behind it. And you can see the difference between laser with DCB and balloon angioplasty and DCB, you can see what happens inside the vessel itself. This is what the hyperplasia looks like on IVUS, which I recommend. That's a filter. You go very slow and you're able to get a good result. Be careful with CTOs. I like laser in some of these because you'll find that a CTO actually had thrombus in there. So I'll aspirate first, I'll find that there was a focal lesion and clot, and then I'll actually use laser after that. And sometimes you might turn something that you thought was a CTO into an acute case, so be careful with those kind of things. This is the other laser device. They say it's better for calcium because its wavelength is different. I have both. I have not seen that benefit just yet for severe calcium, but it is something to consider. I'll use it as my multimodality tool most often. Above the knee, I use a filter. IVL, I'm not going to go into too much. You guys already heard a lot about it. It is the tool of choice now, and again, as Dr. Raghu said, there's about 33 companies coming out with different versions of IVL. It creates this wave, just like in kidney stones, of different magnitudes. It is capital equipment. You can see it can help you. You have to know what's inside the vessel when you're using these things.
Time is up.
Here's a circumferential calcium. You use the IVUS. It'll show you what it is, and you get a good result. There is data supporting it. I use it in the common femoral arteries a lot. It's already been discussed, so I'm not going to belabor that point. And then this is the Javelin, which is the new shockwave version of a low-profile front-end IVL. This helps maybe crossing some of those hard lesions, and that's kind of the use of it. Where do I use it? Most any circumferentially calcified device that's not long. The issues with atherectomy, I think we talked about: cost, time, complications, no good data. I won't talk about those. I think you will. There is actually data. They did a 322 meta-analysis research paper recently published where they looked at every single available evidence. And I know that's not a randomized control trial, but that's pretty good. They found that there was actually no difference with the studies that looked at plain balloon angioplasty and DCB when it came to TLR, lumen loss, amputation, Bayloss stenting, or mortality. So there is data. We'll never catch up with enough data with technology, but there is data, and I think you have to do patient selection at the end of the day. It's not a 100% used tool. I think when you think you're gonna have a tough time getting good expansion, you need to use it. I think ISR, you should use it because it doesn't make sense to me otherwise. But I do think cost and time and everything is very important, so I won't argue with it. I think Dr. Verinder will take care of that for us. But thank you very much. Just don't do this. Thank you.
Thank you, Mr. Kumar. I just want to know, like, straight away whether it is a CTO or it's a very serious stenosis. CTO, even you go for atherectomy or the severe, because you need to pass guide wire, you need to pass the filter. So we need to have some kind of lumen over there. Yeah. If it is a CTO, which device, and if it is a very stenosis versus atherus and thrombus, how you choose your device?
Yeah, I think number one, you have to know what kind of plaque morphology you're dealing with. Every CTO is not the same. Is it hard plaque? Is it calcium? So it makes a difference as to, am I going to use a certain device? I don't use atherectomy in every single case. If I feel it's a difficult crossing, if I use IVUS, if I have a CT, I would need vessel prep in those cases. So in those cases, I will determine laser versus shockwave if it's calcium. I don't have to use a filter for every single device. If I'm using IVL, I do not need a filter. So it really depends on which device I'm doing. You can do it, like was asked, if you're luminal, you can do a pre-balloon, small balloon, and then decide. You don't have to do it just to do it, only if you feel you're not going to get the luminal gain. So I think you have to decide what the plaque morphology is first.
So basic purpose of doing atherectomy is like you are increasing the compliance of the vessel wall. So it has been also mentioned that it's not with the intimal, the medial calcification is also there, especially in the tibial, but in SFA also you have some kind of medial calcification. Yep. Just debulking this will help you out, or you have to give a bigger debulking and then balloon will have a lower pressure inflation.
Yeah, so it depends again on the plaque morphology. If you're talking calcium, absolutely. I think you have to do some kind of cracking, whether it's IVL, to get good response. I don't think if you do IVUS after your plain balloon, you're going to get as good of expansion as you see on the 2D image on your face. None of us do 3 orthogonal views on every single angiogram, and I think we'll be surprised as to what we leave behind. So I think you don't have to debulk. You should vessel prep in some way or the other. And I think some of these new focal balloons may help us avoid atherectomy cost, like the Serenator and these other balloons that have blades, to get a better vessel expansion. It doesn't matter to me which device or how you do it, but I think just going across a 30 centimeter CTO, taking a 5 millimeter balloon, seeing a nice picture and walking away, I think that's why everybody thinks endo is not great. There's more to it, there's a science to it, and we have to be more deliberate with endo than we have been historically everywhere in the world.
Any more questions?
Yeah.
you have got below knee PVD, which is very much more common in India now. Okay, so what is your choice for an atherectomy device below knee?
Time is up.
Is it Rotarex?
Yeah.
Is it smaller caliber
Yeah.
Jetstream? Or you want to do excimer laser?
Below the knee is also very prevalent in US. 99% of my practice is below the knee limb salvage. So my primary go-tos for my practice is IVL, laser, and orbital. Those are three that I use. Lowest profile devices, least amount of damage. You can use any which one of them, doesn't matter. But I think you have to figure out what you can and can't have. We get to have a lot, but I'll still only use 1 or 2 or 3 at most.
And to what level do you go?
Typically not below the ankle, but sometimes every now and then I've had to take something in the pedal arch. That's, I'd say, less than 1% of the cases, but never beyond the distal third of the tibial vessels for most of my patients.
Thank you.
Dr. Kumar, that was a wonderful lecture with a summary of all these devices. What we have to understand that these devices are very useful, and these are this will really change the scenario the way we treat the PADs. But it is very important that we have to understand each and every device when we are using it. It is not going to be as simple as a balloon or a stent what we are using, and there is definitely be a learning curve so that we can use it optimally. Thank you.
Yeah, thank you very much.
Now that we have heard from the west, we'll hear from the north. I invite Dr. Virender sir to speak on Indian context atherectomy.
So I think most of my job to decide the rational use has been done by previous lot of talks, but still I'll share our experience. We are still into, I would say, that stage that none of our device we have used, not more than 20, and most of the lesions are not similar. But as we know, we can see the Roman roads and the newer ones. So there is a need for better pathway for the patency of the SFA. And the first slide itself tells that the rational use means which device to use when. Risk of overuse and misuse definitely exists, and we will have our own learning curve. We do learn and look forward to the operators at the West because they have a better experience compared to us when not to use devices, and the focus is always an outcome and not the technology hype. So initially, as Dr. Kumar told, most of the devices which came, they said like there is no need for filter, and we started and we landed up with occlusions, even all the devices, and then now we have learned our own way. So I won't go over the devices, but now we do have an excimer which was launched, so we do have an experience with most of the devices, and the answer is, it's not a simple answer to choose which atherectomy device when, but yes, there is an algorithm on how the device works and what to choose when. So atherectomy devices or the debulking devices are most of the devices which will pull the mug out. So those are aspirations such as Rotarex or Jetstream which we have, and then there is an orbital which basically rubs the calcium and causes micro particles. Now we have a laser which is photochemical and photothermal ablation, and shock wave. So shock wave is, so there is always a confusion. Since the time we have all the devices, a lot of people ask when to use IVL and when to use atherectomy. The mechanism is totally different. So IVL is not a debulking device, but it definitely cracks the subintimal and the deeper calcium, and the company or the, I would say the mechanism is, it changes the compliance, and then it causes less dissection. So I don't know, we are comparing apple to apple or apple to oranges, the mechanism is different. And now we have excimer, which is kind of different mechanism. So I would say lot of our decision depends on the calcium load and then single vessel runoff or not, because the risk of distal embolization is least on lithotripsy. That is why I think most of us love IVL whenever there is a high risk of distal embolization, or if I am not able to put a filter, I would definitely go with a lithotripsy because the risk of embolization is less. So in a nutshell, it depends on lesion type, vessel size, above knee, below knee, presence of stent, whether you're doing an ISR, and then balancing plaque removal with embolic risk. So there are few factors which you will have to consider case-wise and decide your device, and there will be an overlap. You will see a lesion where you will think like I can use both. So as the question was there, can you do an atherectomy and there is a medial calcification? Yes, I can do an IVL as well, but the cost goes really high. So as in India, we have similar kind of prevalence and similar disease. So when the devices came, long lesion, we started with, so as the chronology of devices which were launched is Rotarex came first, and then the Jetstream and the orbital. Lithotripsy was always there for last 5 years, and then the excimer. So I'll just share, so this is a long lesion, intraluminal passage, and then we went with a rotational atherectomy. The amount of calcium is less. So definitely we can go ahead with any rotational, either I would say a Rotarex or a Jetstream. There was a question like, can you pre-dilate? Yes, if I am an intraluminal, I won't afraid pre-dilating with 2 mm, 3 mm, and then debulk it. Filter, as Dr. Kumar told, if you can put a filter, please go ahead and do it, or you have your penumbra device with you, or aspiration device post-procedure. So maybe 1 in 10 cases, 1 in 20 cases, you land up. So this is the device, you go slow. Every device recommends goes really, really slow to get the maximum benefit. So it has, so this is a Jetstream. And then finally, you won't get a picture perfect. So it's a debulking device. You look on ultrasound, you look on your angio, you'll get some debulking. It won't be really great, and most of the images which we see on social media is after balloonplasty. So if there is no dissection or limiting flap, then you can leave it that, or you can do a spot stenting. Similar lesion, ideally, I don't know whether it's required or not, but a new toy had come, we were playing. So this is a popliteal lesion, did a good debulking, and then post-plasty, it was, I would say, a decent result. Coming to this heavily calcified lesion, at that time we had both lithotripsy and rotational atherectomy. So in calcium, you cannot use Rotarex, but Jetstream can be used. So integrate, the wire didn't cross. Retrogradely, there was a good DPA, I would say. So the wire went bang in spite of a lot of calcification. It was snared, and then we went ahead and used a Jetstream. So a single device was used. At the ATA was a big size ATA. We knew there could have been a risk for distal embolization, but this was the lesion which was not even crossing. So slowly with burr hole we went in, and then we were able to use the same device which we used for SFIT in the ATA as well. And finally we could manage to get, I would say, a decent result. A single vessel runoff, but it was a good size ATA. So the question is, can I use an IVL here? Yes, definitely. Even after debulking I can use, or I could have gone, but I would have needed at least 2 different sizes lithotripsy balloon. So there will be an overlap. Regarding orbital, yes, a great device, and you can use in calcified lesion, but be careful. As you increase the speed of the rotation, the chances of distal embolization or the minute particles or the blow-to syndrome increases. We had our share with that, and it's a troublesome thing. So again, filter is recommended. It does good, I would say, cleaning of the calcified stuff. And now this is another case. I mean, this is always there, I would say. If there is an eccentric lesion, Hawk 1 is a great device, and it comes half the price of the other atherectomy devices. So don't shy whenever required with an eccentric plus, we do use that. Now coming to the chance of distal embolization. So again, this was a CTO. We crossed intraluminally, we were over enthusiastic, and we used a blade out technique here. So we were happy with blade in, and we thought, let's try with the blade out. We were getting a good result. So that's an ultrasound image. And then finally, this is what happened. So there was some flap, and then when you take a run below knee, so it has gone down. So we didn't use the filter here, and finally we had to aspirate with aspiration device. So now even we have shifted to distal protection. Either use a filter, or if you have a good distal vessel, we go ahead and put a balloon in the distal popliteal and then do your atherectomy. So this is for instant restenosis. Yes, Rotarex and Jetstream both can be used, but be careful, as Dr. Kumar told, when you open the blade up and if there is a laser cut stent and if it gets entangled, then the entire stent can wrap up over the device. So go slow. This is a fast video. And what we have started now doing, if you have a good distal, if you don't want to put a filter, now we have used in almost 8-10 cases, we just place a small balloon from below. We do our aspiration as close to the inflated balloon as possible, so that this saves your distal embolus if you don't want to use a filter. So that's one way of preventing it. And then the routine DCB and if required stent. So coming to use of lithotripsy, whenever there is a high calcification and a single vessel runoff, if you're worried about the trash, this was a single vessel runoff, all other vessels were heavily calcified. We thought, okay, there was a small wound, second toe, we'll go ahead and do plan was to cross the lesion first. It looked okay, and then when you see on fluoro, even the wire was not crossing. So command, and then we finally took a esteto and managed the wire to cross. Now that's the calcium. Yes, you can use an orbital if you want. We had a plan to go with lithotripsy here, single vessel runoff. I didn't want it to trash, so that is one thing you should be keeping in mind. So I had to really do a pierce technique. We don't have a javelin here. At that time I didn't have an excimer, so no balloon was going. Even the coronary 1 mm balloon was not crossing. So after the pierce, finally we could manage to cross the lesion with the balloon. And after pre-dilatation, went ahead with lithotripsy. So the lithotripsy balloon is so safe because it's not a balloon, it's a technology. We had no, honestly, we didn't even had a 3 mm balloon, so I took a 4 mm and just inflated it with a minimal pressure of 1.5, but the result it came was really good. And still, I would say this patient is being treated. It's a month old, and DP is well palpable. So, I mean, this was the case. Another indications for lithotripsy is heavily calcified concentric lesion. So, aorto iliac, we all know we are not using any atherectomy, rotational or orbital. So, IVL is the way to go ahead. Now, there are multiple studies, mostly the Italian groups have published that they are not putting stents even in aorto iliac segment if you do a good oversized lithotripsy. Initially when it came, they used to tell us 1:1. Now it's like 20% oversize, and that is very true. If you are using in a 6 mm vessel, so the balloon has to really oppose with the ball, and you can use a buddy technique because we don't have balloon which is bigger than 8 mm in India as of now, but they are coming with I think 10 or 12 which will be available. So great device, I would say. You get good luminal gain, but again the decision is as of now aorto iliac, because we have burned our fingers. We have done a good lithotripsy, and after a week we have seen the vessel going down. So the decision is still, I would say, if required, go ahead, open it nicely and put a stent, because we know in AIODs the stent patency is not bad. Similarly, femoral discussion, common femoral discussion was there. So there will be lesions and patients where even to open a groin would be hostile and high risk patients, I would say. So you'll have to go with endovascular first approach. So this was the patient who had multiple comorbidities and really didn't wanted an open one. So we went ahead, came through, I guess, femoral axillary because, or brachial, because the other side was similar pattern. Antegrade, no wire was going. So in such situation, I think again I would prefer an intravascular lithotripsy compared to atherectomy like an orbital. Once the wire is crossed, making a space for IVL to cross, the balloon is little bulky, and then go ahead and do a good lithotripsy. Again, I would say at that time we didn't had a bigger size balloon on shelf, so we used 6 or 7 which was undersized, and whenever a balloon is undersized, remember the results are not great. Dr. Raghuram had showed in his images So this is something which we were doing wrong, and now we really oversize it. So there is no harm in oversizing an IVL, but keep your pressure low. Now they don't even recommend to go up to a 4 pressure, even 2 pressure is good. So here we were not happy with the result, and we placed a Supera, and it's working fine. So this is a bailout where if you think the lesion is collapsing, you can use a mimetic stent across the joint
2 minutes.
if you have to. So I think I'm almost done. Coming to ISR, atherectomy like Rotarex and Jetstream both can be used, and be careful where the stent is fractured. You can see those segments you cannot do a rotational one. I mean, you have to really fluoro your stent and see. Avoid that segment if you are using a rotational atherectomy. So recently Excimer was launched, and we had used it for in-stent stenosis occlusions. So it has its own mechanism, but we don't have the turbo tandem one. So we have the routine, which will gain 2 to 3 mm max, and at least it debulks or pulverizes and this is how it looks on the ultrasound. So it is a great device, and I think FDA approved for in-stent restenosis. So that's one thing. And the other thing is when nothing crosses a calcified lesion, so you can use your Excimer, even the 0.9 m, which is used for coronary with the highest joule and pulse. So and just bang it across the calcium, it crosses. So that is a great device. I would say wherever there is a good amount of calcification below knee and you're not able to cross even with wire, so that's the situation where Excimer is very useful. So I would like to end my talk by saying choose atherectomy when, yes, calcified eccentric lesion, heavily fibrotic plaque, needs luminal gain, plaque is protruding or bulky, but use distal protection, I would say always. Shockwave, easiest to use, no distal trash, heavily calcified concentric lesion, acts on superficial as well as deep calcium. Risk of dissection is, whenever you think is high, go for it. Aortoiliac lesion, so great device till I would say the pedal or the ankle vessel. And the last slide is Excimer, instant restenosis, mixed plaque and thrombus, and CTOs where you are not able to cross, you can use that. So failure of conventional crossing. So this is my last slide. Again, as I told, there will be an overlap. There will be a situation where we'll be not able to choose which one is the best, but just follow the algorithm. Concentric calcified lesion, IVL works well. Eccentric bulky lesion, go for an atherectomy. ISR, unexpanded stent, Excimer is the way. Wherever there is a thrombotic burden, laser atherectomy, both works. And CTO with resistant plaque, again, laser crosses it very well. Thank you.
Thank you, Viru. It was an excellent talk. I just wanted to know 2 things. First is like the IVL. So once you cross the wire through that calcium, you have to dilate it.
Yes.
So that is the minimal dilatation you achieve 2 or 3 mm balloon, yes. And then you put a IVL balloon.
Yeah.
Because IVL balloon is not for dilatation. It is just, it has to approach, it has to exactly catch the wall.
Yes.
And then you have to deliver the shock. Thereafter you do DCB.
Yeah, yeah. So
you
can
in every case?
So there are 2 schools of thought. In aortoiliacs, people are not even doing DCBs. If you ask some people, it's again, I think it's 50-50, Kumar. How do you guys do? Like SFA below knee, always DCB? Because in aortoiliacs, there is still a debate like.
We don't have below the knee DCB, only above the knee. So we'll use DCB unless you need a stent. Yeah.
Okay. So it's a vessel preparation device basically. So there's no harm in using a DCB.
Okay, okay. Thank you. Thank you very much, Viru, for your excellent talk. And we'll end the session here. Thank you, both Kumar and Viru, for a lovely talk. Thank you.
I thank the chairpersons and the speakers for their expert talks. It was an amazing session. And next up, we'll have a panel discussion on the same, the Bessel 3 trial. And for the panelists, for choosing the right strategy for the SFA, we have Dr. Raguraman sir, Dr. Vimal Someshwar sir, Dr. Shuvro sir, Dr. Sanjeev Sarma sir, Professor Tae Kiang Hyong, and for the session, the moderator will be Dr. Preetham Chatterjee from Apollo Main Hospital, Chennai. Already projected, I think so. Already projected. That's it.
All the panelists are not here. We have 3 here. Vimal sir called. So good afternoon, everyone. So we move to the next topic, that is decoding Basel III, which is an important trial that has come. And the discussion is about end of the road versus new direction for drug-eluting technology, choosing the right strategy for SFA. So the esteemed panel today is Dr. Raghuram L, who is one of the principal investigators for the Basel III trial, Dr. Vimal Someshwar, Dr. Subra Roy Chaudhary, Dr. Sanjeev Sharma, and Professor Tae Kiang Hyong. I am just told that other 2 members will be joining us in a while. So Vimal sir is here. Vimal sir will join us. So I'll just give you a little brief about these Basel trials. So Basel trial, the Basel word means bypass versus angioplasty in severe ischemia of the leg. So it went through different trials. The Basel 1 trial, which looked into surgery versus PTA. Basel 2 looked into bypass versus endovascular group. And Basel 3 is plain balloon angioplasty with or without balloon mounted stent versus drug-coated balloon angioplasty plus minus balloon mounted stent versus drug-eluting stents in the femoral popliteal segment. So it is basically, if you look at the trials, it evolved from the surgery versus PTA to an endovascular strategy optimization trial. So Basel III participants were basically patients with chronic limb-threatening ischemia who required endovascular femoropopliteal or infrapopliteal revascularization. Basel III trial design and treatment arms, if you discuss, it is mainly open label, pragmatic, multi-center trial. Most of the NHS vascular units, prominent vascular units involved in the trial, and it was publicly funded by the NIHR, and randomized trial, which is a phase 3 trial. So 1:1 randomization as first revascular strategy was done. Fempoplin balloon angioplasty with or without base stenting, drug-coated balloon angioplasty with or without balloon mounted stent, and drug-eluting stenting. These groups were evaluated. So primary endpoints were amputation-free survival and all-cause mortality. Secondary endpoints, the list is long, it's overall survival, any major adverse limb events, re-intervention rates, major adverse cardiovascular events, relief of ischemic pain, which is a quality of life indicator for these patients, cost effectiveness analysis, clinical healing of tissue loss, and changes in ABI or TBI. The conclusion was that neither DCBA or nor DES confers significant clinical benefit over a plain balloon angioplasty in the femoropopliteal segment in patients with chronic limb-threatening ischemia undergoing endovascular femoropopliteal with or without infrapopliteal revascularization. So my first question is to one of the principal investigators, Dr. Raghuram. So what clinical gap was Basel III designed to address, and why was a comparison of plain balloon angioplasty, drug-coated balloon and drug-eluting stent important in CLTI? We would like to have your thoughts on this.
Yeah, thank you. Key thing is re-intervention. So what we were trying to do was, durability you do an angioplasty, how durable it is over a period of time. And the question that was being asked was, would drug coating, drug delivery into the intimal wall create this durability? And there are two ways of delivering this drug, through either a balloon or through a stent. And so which device is better? So it was a very simple and pragmatic start to it, where we said, okay, you wish to do the angiogram and then say, yes, this patient is suitable, has a suitable lesion. Then you do a randomization, you pick something, and then you just go ahead and treat that patient and then follow that patient up over a period of time. So that was the thinking behind it. Before we get to just looking at the result, I'll just add one more point. The trial started at 2017 or somewhere around that period. Then we had the Katsonis pause, where he came and said, look, paclitaxel has a death signal. And then came COVID. So it took a pretty long time. And, if you look at it, 10,000 angioplasties, roughly any study shouldn't be taking 6 years or something. The NVR quotes that there are about 10,000 FemPop angioplasties performed in the country. Still, for 250 patients, they took almost 6 years. So you can take the results with a little bit of a pinch of salt, but that's where we are, and that was the reason.
But on that note, just credit must be given for the fact that study was completed.
Right.
In spite of those impediments, the study was completed. Yes.
Yes, that's great. So the next question is to Dr. Vimal Somashu sir. So should plain balloon angioplasty be default first-line therapy, and when would you still choose a drug-coated balloon or drug-eluting stent despite Basel III results? And what do you think is the role of angiographic versus clinical endpoints in decision making?
So should plain balloon angioplasty be a default first-line therapy? I think that has always been a baseline for any of the study that we have already done. We also know the limitation of plain balloon angioplasty with the presence of recoil and dissections that happen. So, but all the studies compare that. I don't know whether it is valid or not. I think ideally I would probably prefer to do the best line as of today and compare it with any of the new therapies that come into play. But that is not what happening. We are just continuing to do with the plain balloon there. When would you still choose DCB or DES despite Basel III trial? I think what is important that we have to understand the final results that have been quoted and whether they are valid. And as Raghu just said, that we have to take it with a pinch of salt. Couple of things that happened, it got extended, study got extended. Number two was, all that was used was paclitaxel. And we know there are problems with paclitaxel related drugs. It's not one of the choicest drug compared to when you have sirolimus and everolimus that are already available. And now there are balloons also available, and there are obviously drugs. We have all seen the coronary data with paclitaxel versus sirolimus, and we know sirolimus is a preferred drug, being more cytostatic compared to cytotoxic, which is paclitaxel. So that's where one of the things come in. Role of angiography as a clinical endpoint, well, it's ideal situation, but I don't think so it's valid in all the cases to do that. But when you're doing a study, I think if you can show it on an angiography that this is what the final conclusion is, I think that would be valid at that point of time. But in a routine work, day-to-day, daily work, I don't think so that would be the right way to go. A good Doppler would be a good way to confirm our clinical endpoints in those patients.
Thank you, sir. So the next question is to Dr. Subro Roy Chaudhary, sir. No difference in amputation-free survival. Is it expected or surprising? And is amputation-free survival the best endpoint for CLTI trials?
So that is a major criticism of the trial, is that what are we looking at when we are trying to salvage a CLTI patient? What are we looking at? We know that these patients carry a high cardiovascular risk. So, if you look at any of our own data, 40% of the patients would be dead at 3 years from other causes, from the cardiovascular risk. So should you have like a disease specific endpoint rather than an overall survival endpoint? Because how much would a heart attack or a stroke mar the potential advantage of a drug-eluting stent or a drug-eluting balloon? Because there was some key, this is a highly statistical study, and there was some, even from the statisticians themselves, and I know this unit very well, I worked in this unit, and the statistical service is super. And you know, even from their admission, you will see that there were a couple of key points that they said that maybe that there is a message here that there is some tendency towards improvement which we have not unmasked. And the major reason for that unmask is how much of that potential benefit of DES or DEB was marred by the additional death related to cardiovascular mortality and not limb specific markers. But just one thing I wanted to say before this point is that the background to this is Basel II, and this is something we, as a group of people, we have to understand, that Basel II, quite contrary to age-old traditional thinking, did say that best endovascular approach is better than conventional surgical bypass for limb salvage. Then comes the next question, then what endovascular strategy? And then that is Basel III. And yes, you know, and we have a huge amount of respect for the NHS data. And pardon me for saying this, but there are many countries where you will have data coming out, but I would rather take those with a pinch of salt than the data that comes out of the NHS. Not money driven, not industry driven, state funded. Yes, limitations of course, but we can't ignore the fact that good quality POVA, and that comes in the point, I think Raghu has mentioned it before. I mean, you know, you do a POVA with a 2 millimeter balloon all the way to, you know, BTK vessels and say POVA doesn't work. I mean, that's not true. I mean, you don't have to do IVUS, just do an outside ultrasound, and ATA up here is 3.2, 3.4. So, you know, you need to do the right size POVA and you need to do it for the right amount of time. And yes, even after all of this, I think personally DES and DEB has some advantages. We haven't unmasked it, but there probably is.
Thank you. I think I'll just add a little, Shubhro here. I mean, when you look at amputation-free survival was the end point here. There's no mention of major amputation or minor amputation. It's all major?
Major.
Okay. Number two was there an advantage of using this drug-coated balloon in delaying the amputation? The time frame was not mentioned, or what you call a clinical-driven TLR could have been a good endpoint rather than just keeping it as an amputation-free survival.
See, amputation-free survival is a standard endpoint which has been used over the decade, not for this trial, but for all trials. And it makes a lot of sense because at the end of the day, what are you doing? You are trying to salvage the limb.
Yes.
So there is no ambiguity that the endpoint is okay. But there are other issues and challenges with Basel III. But anyway, we will discuss that by and by.
Sure. So next case is to Dr. Sanjeev Sharma, sir. So did lesion complexity influence Basel III outcomes? Could specific subgroups benefit more from DCB or DES?
See, there lies the heart of the issue. Basel III was, this information, anatomic information, has not been shared as yet. That probably will come in the next publication, hopefully this year or later. Both the economics as well as the anatomic factors which may have influenced the outcome have not been shared. So at this time, what we know is that lesion morphology was not a study point. So this question becomes slightly redundant there. But you see, you must understand, Basel III was very well designed. Unfortunately, what happened, which has not been widely talked about, is that it started as a trial per protocol. Right. Unfortunately, ended up as a trial with intention to treat analysis. There lies the catch actually. So the number of patients which were to be recruited was 809. But the number of patients which they ended up analyzing was 425. Now when you divide these into 3 subgroups, and then God forbid if you divide them based on the image morphology or the comorbidities, more specifically diabetes and smoking, you will realize that the sample sizes in the subgroups will be statistically not significant to answer the questions that you are wanting answered now. That is, whether the complexity of the lesion influences the outcome. So, honestly speaking, I think for the real world consumption, our decision making will remain pretty much the same, which will not be influenced by the outcome of this trial. This trial does not say that drug-coated balloons or drug-coated stents in specific angiographic morphologies are inferior
Last
or
2
superior.
minutes.
It has not tested that, actually.
Right. Thank you, sir. So I think Professor Tay Kiang Hong is not there. So I'll just ask this question, Raghuram sir. Does Basel III settle concerns regarding paclitaxel mortality? So what is your approach to DEB usage?
Okay, this is a difficult question. So you have to go to the SweetPack trial that has just come out. And even in that trial, there is a signal towards mortality. So I feel, and I echo the words that sirolimus probably lies a better solution. I'll leave it at that, and you can move on. But I think there is a signal which we cannot ignore.
Right.
So the idea behind all this is that with paclitaxel being either amorphous or crystalline in nature, the loss is quite significant, especially during transfer of the balloon towards the lesion. And to compensate for that, what is happening is they are increasing the dose. They are giving it, instead of 1 milligram per square millimeter, they are going up to 3 or 4, and therefore the dose is high. If the lesions are long, if multiple balloons are being used, the diameters are big, the dosage is definitely much higher.
Right.
So that's where all these issues come in. As compared to that, the sirolimus is probably the choice that we have here, where the loss is not so much and the dosage is very controlled in these patients. Yeah.
They couldn't capture the sirolimus onto a balloon like the cardiologists in the past, but now some technologies are arriving. Yeah.
Right.
But having said this, we must admit actually, that the usage of paclitaxel only was not done in Basel trial. Basel III actually spread over 7 years, and all the advances in balloon and stent technology which happened were absorbed into the trial, and they did not limit use only to paclitaxel. The large number are paclitaxel, but they have used patients, they have included patients with sirolimus as well. Unfortunately, the numbers are very different. Yes, that is true.
So organizers, we have extra time. Can we carry on with a few more questions? Or okay. So next question is to Dr. Vimal sir. So what are your thoughts on Supera versus drug-eluting stent versus PBA in femoropopliteal disease?
I think I look at the lesion primarily, and when I've done a primary balloon dilatation, which is necessary both for Supera and DES and PBA, all three things will require that. So based on what I see on that segment, then I decide on that. As of today, my choice is Supera, but I'm tending to go towards drug balloon, mainly if it is sirolimus. So that's how I'm looking at it. Drug-eluting stents, I think I'm still little more concerned, not too happy to just do it. Cost is one factor, and obviously the outcomes have to be evaluated. So if Supera with a drug coated, I think I will probably plan it out more.
That will be great. So organizers, are you ending the discussion or any? We can, okay. So I think with the want of time, we have to finish the discussion here. Thank you very much.
I was talking to the Supera guys that why aren't you getting it drug coated, but they have a technical problem because their placement, it's not, it's possible to put it there.
So thank you very much to the esteemed panelists.
thank you so much for the esteemed panelists, the moderator, for their excellent discussion on the Basel III. So for the next discussion on acute limb ischemia, this is a panel headed by the chairperson, Dr. Mohammed Badran sir. Our moderator will be Dr. Lennon D'Souza. And how to decide on the best strategy in advances in surgical and endovascular techniques for acute limb ischemia. I invite our esteemed panelists, Dr. Rajesh Mundara sir, Dr. Priya Jagya ma'am, Dr. N. Shekhar sir, and Dr. Shabnam Fatima ma'am.
Thank you very much, and thank you for being here. It's a very exciting session. As you know, acute limb ischemia is quite different and more dangerous than dealing with chronic ischemia. The chances of complications are really higher. It's a more dangerous subject, and for this, we will be starting our session.
We are here for a very, very interesting session on acute limb ischemia. I know the last session on Basel III was a little theoretical, and since we do have some guidelines with regard to acute limb ischemia, but I thought let's make this a case-based approach. In our panel, we not only have interventional radiologists, but we also have vascular surgeons who perform both open vascular as well as endovascular therapy. So I think this should be a very, very balanced and open discussion. And I would like to direct questions to all of you, and all of you can feel free to step in when you have a differing opinion or when you want to concur with somebody else's opinion as well. So to begin with, I'm going with a case scenario. A 51-year-old female has sudden right lower limb pain from 12 hours. She's a known case of dilated cardiomyopathy. She's diabetic, hypertensive, chronic kidney disease, but there was no prior history of claudication. So I'd like to start with our chairperson, Dr. Mohammed Badran. So how would you clinically assess this patient, and what are the clinically relevant investigations that you'd like to perform?
I think first of all we have to look at how acute the clinical presentation and the clinical, the 5 P's of acute limb ischemia: pallor, pain, pulseless, and so on. And 15 hours presentation in the sense of acute limb ischemia, as you know, it's really, really late. Unless you have good collaterals allowing for this patient to survive those 15 hours, because usually within 3 to 6 hours, if you don't fix it, it's gone. So I suspect the patient has that. The patient has dilated cardiomyopathy. You have to go through the risk factors. He has dilated cardiomyopathy, he has diabetes, hypertension. All these are really bad for this patient. Probably he's a bit lucky being young. That may have helped him. So you need to do clinical examination. You need to check the power, you need to check the sensation. Go back not only to being a proceduralist, you have to be a clinician, especially in the acute scenario. So if the patient has a limb that can be survived, then this is the time to think about whether you do recanalization versus amputation, because 15 hours is really, really, really late.
Dr. Shabnam, would you like to add something?
The first thing is going to be assessing the class of ischemia in this patient. So whether it's a class 1, 2A, 2B or 3 ischemia. Following that only, the next step is going to be planned in this patient.
Correct.
So clinically,
what about the investigations? What would you like to investigate the patient with? So given the history that the patient has diabetes, hypertension, chronic kidney disease, dilated cardiomyopathy with acute limb ischemia.
So if the patient is a CKD patient, if still the patient is on dialysis, then it is not a contraindication to do a CT angio. So we can do a CT angio. If it is a patient who is not on that, then we can do an MR and first get a basic picture on the anatomy of what is happening. More than that, the clinical picture is going to determine what we are going to do next. The pulse examination, the power, the sense, the movement, in the foot and the leg is going to determine the next step.
So I'll go to my next slide, which is, it is a pale, cold right lower limb, absent distal pulses. There's some amount of sensory loss in the toes. The motor power is 4/5. So Dr. Sekhar, what is your opinion about the immediate medical management and how you would investigate this patient in this acute setting?
See, we always advise everyone, the moment you diagnose an acute lower limb ischemia, the first thing that you should do is to give a shot of heparin. So that is the delay, whatever you do, you are going to take some time to do investigations. All these delays will matter. So you must immediately give, nothing will be lost by giving 5,000 units of IV heparin. So as you progress with the rest of the investigations for these patients. So this patient is already going on to a 2B ischemia, and any delay he will slip into 3, and when the limb salvage becomes very, very difficult. So this is an important step, everybody should do that. And second thing is hydration. And this patient has a cardiomyopathy, so you have to be very careful. So we always prefer a little bit of hemodilution so that the thrombosis does not extend any further. So these are two things we should look at.
So absolutely. So in this case, of course, the immediate management, as you can see in the slides, is IV unfractionated heparin as per body weight. So generally, the first shot of heparin is, considering that almost everybody is at least 60 kgs, we give them 5,000 units of heparin, or otherwise we can roughly translate it as 80 international units per kg. Giving, of course, very good hydration, analgesia and limb protection, and of course rapid imaging and team activation based on the urgent lab. So these are the initial investigations of the patient. Despite having dilated cardiomyopathy, there was no atrial fibrillation. The blood pressure was 190/100. Labs show that total count is about 13,800. As a routine, we always ask for a CPK and LDH in all these patients. So very mildly elevated LDH, CPK was normal. HbA1c 9, creatinine 3, serum uric acid. The Doppler which we screen shows a thrombus in the external iliac artery, common femoral artery, monophasic flow below, and as we trace, there's a thrombus in the popliteal artery as well. So my next question to Dr. Priya, what are the imaging prerequisites before taking up a case of acute limb ischemia? Especially in a case like this, would you think that a Doppler is sufficient, or would you still want a CT, MRI, or a DSA, or any other imaging you would like?
Yeah.
Doppler is a very good investigation for below the inguinal ligament, but for iliac arteries and for aorta. For iliac arteries and aorta, obviously one would need a CT angiography or an MR angiography. We usually do Doppler, and which is always succeeded by either a CT angiogram or MR angiography, as the case may be depending on the availability in your institute. We are using a lot of MR angiography. DSA only for diagnostic we are no longer doing. We do that whenever we take the patient up for a concomitant intervention only. But before doing all these things, I would like to know why this lady developed this. So I think etiology is very important. So in your investigations, I would also want a echo to be there.
Absolutely. So she's a case of dilated cardiomyopathy. So I think.
So echo always should be done whenever you have an acute limb ischemia and you are not able to find out the source of your embolus. You need to go and find that out. The coagulation profile, whether the patient has any hypercoagulable state. So those things I would like to rule out before I plan intervention in my patient. And that's a way we would, based on the CT and MR findings, then we would decide.
Dr. Mohammad Badran, you want to say?
This patient has high risks for developing bad disease. First of all, he has cardiomyopathy, which means the ejection fraction is not going to be good. It means the flow within the artery is slow. He has diabetes. I presume if he's got this and that, and this ischemia, I presume this diabetes has been going on for a long time. Hypertension, so he's really got bad risk factors for developing peripheral vascular disease.
So I'd like to add that, of course, the echo was done. It's a known case of cardiomyopathy, which is hypercoagulable because of poor ejection fraction. The ejection fraction was about 35%.
If I may add, irrespective of history of cardiac illness, every patient who presents with an acute ischemia must have an echo. Because we don't know, he may still be there. Okay. So same way, imaging nowadays we are not, we are getting de novo thrombosis, many cases now. Olden days it used to be rheumatic heart disease, then it shifted to myocardial infarction being the source. Now we are getting a lot of cases of de novo thrombosis where there is a coagulopathy, hypercoagulopathy is there. But only thing is hypercoagulable investigations can be done, but we are not going to wait for the results to come. The treatment has to be started earlier than that.
So I'd like to run everybody through the Rutherford classification of acute limb ischemia. So the class 1, class 2A, 2B, 3. So in this case, there was some amount of sensory disturbance in the toes. So since it's minimal, currently it falls under class 2A, as Dr. Shabnam rightly pointed out. As soon as there is mild to moderate motor impairment, it goes to 2B. And class 3, when there's loss of sensation and there's severe basically motor impairment. So in this case, it's a 2A classification. It's a marginally threatened limb. It's salvageable with prompt revascularization. So the question now is surgical versus endovascular. Now we know that the thrombus is extending from external iliac and is sitting at the bifurcation, as well as there's a thrombus in popliteal as well. So Dr. Rajesh Mundada, being an interventional radiologist, I think it's a biased question to you, but what would you choose in this case?
In such cases, the most important thing is whether there is again a reformation of the vessels which we see, which we obviously see it on CT or any other thing. But then before I really take this patient for endovascular, I would always activate my ICU team as well as my anesthesiologist, because these are the patients who would land up with a massive reperfusion, because a huge bulk of muscle which is ischemic. A patient can have hyperkalemia immediately post-procedure. So even death can happen following such patients. These are difficult patients to be taken in. But after seeing an angio, I would not shy away taking it from doing an endovascular treatment.
Asking Dr. Shekhar, yes.
I would differ. In this patient, I would take up for surgery. The reason being, he is already having renal failure, and it's a 2A going on to 2B, and he's got external iliac itself thrombosed. So we need a quick revascularization, which can be easily done under local anesthesia by exposing the common femoral artery. Even if need be, we don't have to give major anesthesia. We can also do it under block if need be, but if the patient is thin, we can just simply do it under local anesthesia. It is easily accessible. We can clear the top proximal one as well as the distal one. If at all needed, we can give a small dose of intraoperative thrombolytic therapy distally so that we can clear it off. Whereas if you're going to use completely endovascular, it's a large volume thrombus. You're going to take a longer time unless you're going to go for an aspiration and stuff like that.
Yeah, Dr. Shabnam had something to say?
We are not going to do for this thrombolytic therapy.
Yes, Dr. Shabnam, yes. So what everyone needs to remember is that this patient's creatinine was 3, her blood pressure was 190 by 110. So things are not so simple with giving thrombolytic. So it's about options right now. So in Sir's case, he says he's going to do surgery. Madam, what about you?
Still, I would also go for surgery only. Under local anesthesia, it would be quite very well possible to expose the femoral artery and quickly do an embolectomy. I would like to add that by doing open procedure in such patient, we can also offer them fasciotomy, because in all such patients who have got long period of ischemia, that too an acute limb ischemia, opening up the fascia, doing a fasciotomy is also an important part of treatment.
Truly. In this case, of course, there was no swelling of the lower limb. The limb still looked relatively okay.
Still, there is no harm in doing a fasciotomy. We shouldn't wait
CT or MR
if
of
it
this
is a
patient? CT or
No,
MR?
so since the Doppler was very, so I'll be a little biased here. I was the operator, so I'm running through what I did finally in this case.
Yes.
Yeah. So
this is interventional radiology meeting. So he must have done a thrombectomy. So I'm going to cheat, although I don't know. The treatment is thrombectomy.
I mean, the IRs will know that I'm cheating here. But yeah, so in this case, of course, this is the angiogram. If everyone can look through it. So we took a crossover sheath, and you can see very, very large burden of thrombus sitting right at the bifurcation there. You can see below there is some amount of reformation of the distal SFA and popliteal with again a popliteal occlusion, and then reformation of anterior tibial artery. Lower down below, anterior tibial artery again faintly seen, peroneal artery faintly seen, no foot blush at all. So I think our vascular surgeons are very particular that they are going to do it open surgery and endovascular options, of course.
This does look like a good surgical case.
I'm sorry?
Actually, lot of thrombus load, and this does look like a good surgical case.
Okay, so since the CPK was normal, the LDH is very, very mildly elevated. Patient's creatinine was 3, considered slightly obese patient, slightly difficult surgical candidate, as per my surgeon as well. We decided that we would do an aspiration or mechanical thrombectomy in this case. So the limb is viable in this case. It's only Rutherford 2A. I think once it moves towards 2B, of course there are more cases that I'd like to show. We prefer open surgical more, but when it's 2A, all the guidelines say that when it's 2A, endovascular should be preferred first. I would still call this a short symptom duration because sometimes we get acute limbs who still come at 2 or 3 days and it's still provided the parameters are normal, they're still salvageable. Endovascular also has lower morbidity, it's a little more precise, but that's my bias. Surgical perspective, of course, I think the Fogarty embolectomy is still very, very relevant. Do any of you all would you all perform an endarterectomy or a bypass in these cases if required, based on the Doppler flow? Dr. Shekhar?
That is if the presentation is late. So if they come after 2 weeks, so they have been lingering on with class 1 to class 2 ischemia, where the limb is still preserved. So you don't expect an aspiration or the lysis to be complete. In fact, it's better not to disturb them. So we don't even attempt. We just straight away go. It is good for, even for embolectomy, when you extract those embolus, you actually also cause damage to the intima. So they rethrombose.
Dr. Rajesh Mundara, I think you would like to differ. So what is your opinion on the timing of doing endovascular therapy?
It totally depends upon how the clinical presentation is. If the clinical presentation gives me some time to do intervention, again, here the tibials were good, so I would take up with an endovascular approach here. If the tibials are bad, then it becomes tricky because you really don't know, because a microvascular injury has already happened and the chances of rethrombosis will be high.
So we also touched upon these topics as Dr. Shabnam already pointed out, that often there is a need for fasciotomy as well, and of course there may be a role of a surgery in case of failed endovascular therapy. So of course choosing the right technique depends on the thrombus burden, the bleeding risk, time since onset, availability of devices, and of course operator expertise. In this case, of course, I performed aspiration thrombectomy. This is after the first pass. You can see there's a fair good amount of clearance from the proximal CFA, SFA and the profunda. We continued with further passes here. After clearing of some of the proximal, of course we had to clear the popliteal clot as well. We cleared the popliteal, and then there was a peroneal, tibioperoneal clot. And then of course we cleared that as well. So this was the runoff below. I will need more time. And
Last
then
2 minutes.
This is the perfusion below. And this is the proximal clearance. So I can tell you that we completed this case in 35 minutes. So it really depends. I agree that surgery can be a very quick option, but I think endovascular also can be very, very quick, provided you have a good team and everybody assisting you rather quickly. So my question to Dr. Rajesh Mundada, when would you prefer an atherectomy device in acute limb ischemia?
See, the thing is that if you have a short segment, good lesion where you can pass in a wire very easily, we have beautiful devices which can be used. I won't shy away using Rotarex or even Jetstream. If the lesion is long and if there is an underlying disease, I would use it. But in short segment, Rotarex works very well. Even in this patient, Rotarex would have worked.
Yeah, so I mean, probably it's my opinion and we'll leave it to the house, but probably if you assume that it's a mixed thrombus or if there's underlying atherosclerosis, maybe atherectomy can be an excellent option in this as well. Always, my first go-to is always aspiration thrombectomy in these cases and try to avoid lytics as much as possible, especially in a high-risk patient like this, but of course there's no harm in lytics in, of course, lesser risk patients. So this is a companion case, a 40-year-old young male with rest pain. I'm going to play the angiographic stills here. Non-diabetic, non-hypertensive, but a smoker, occasional alcohol, early signs of neurological deficit, early signs of foot drop. So Dr. Shekhar, what would you do in this case?
Yeah, let me just read that. Yeah. Oh, in this patient, we'll try a lytic therapy, ipsilateral puncture, antegrade, lytic therapy, and wait for the. One thing in our setup is we are bothered so much about economics, the financial strain on the patient. So if they can afford it, you can try all these.
So in this case, of course, it's a 2-day-old. So will that influence your decision? Because sometimes lytics may not be as easy and may not work as effectively.
2 days old.
2 days.
Yeah.
2 days. Whatever sentence.
Yeah, that is okay. Yeah. You can use the lysis, and I'm sure it'll expose the underlying lesion that is there. Then you treat it later. So you have to give a continuous this thing. So what I was saying is, we don't use those aspiration devices so much because of the cost factor. We go with traditional lysis here.
Okay, so this, of course, this case I was not the operator. The operator is one of our panelists, Dr. Rajesh Mundada. So I'll also, he ended up crossing the lesion and took an angio. And as you can see that there's some amount of faint filling of the peroneal. As you go below, you can see the peroneal there. And of course, in the third image, you can see that there's some amount of stasis in the posterior division of the peroneal artery. So I think Dr. Rajesh Mundara decided to do a Rotarex in this case. And these are the post-Rotarex angiograms. And I think in this case, it's well established that at least the patient has a single vessel runoff in this case with Rotarex. So I mean, I think Rotarex is good for all sorts of thrombus, and especially if you are considering that there could be mixed thrombus, acute, subacute, chronic. Rotarex probably is a very good option. And this is the perfusion to the foot, and you can see relatively good perfusion to the foot as well. So. So since you use Rotarex in this case, Dr. Rajesh, how do you prevent distal embolization? So I think we had an extensive discussion, but did you end up using a filter?
Honestly speaking, I didn't have, there was a single vessel runoff which was also showing this sluggish flow. So I really didn't bother much to go across that thrombus maybe and to put in a small filter in a peroneal. But I just used the Rotarex and I was happy with the result, to be very honest.
Okay.
So probably, I would rather say, even if you don't have atherectomy devices, so there are so many institutes who don't have simple aspiration, simple maceration with multiple passages of your guide wires across, and simple aspiration with any large bore catheter can also help. This is very acute thrombus,
yes.
So should produce. And you could add little bit of thrombolysis. I mean, you can give some, and this will take care of the
Right. So I think generally in my practice, I try to do mechanical thrombectomy first, try to clear off as much clot as possible, and then sometimes we do keep CDT, and especially in a young patient like this, probably CDT would be beneficial as well. What about the risk of perforation in this case, Dr. Mohammad Badran? Do you have good experience with atherectomy and the risk of vessel perforations?
I try not to go too much below the knee because the risk is high.
Yeah. So I'm going to show another companion case now. This is a 38-year-old male diabetic with a HbA1c of 13. He has peripheral neuropathy, acute left leg pain since 3 days, and he has a history of pulmonary embolism in 2013. These are the CT scans. So I'll run you through. The history is of course of 3 days, no sensory or motor involvement. You can see a good amount of thrombus in the popliteal artery there, in the left popliteal artery. So take the opinion of the panel, what would you do in this case? So this case of course was performed by me, so I'll tell you what I did. But what would you do in this case, Dr. Shekhar?
It's almost similar to the previous one. It's almost similar to the previous one. Why there is no change of plan in this? So, yeah.
So since the patient had absolutely no sensory and motor involvement, even though the history was only 3 days old, he has an old history of pulmonary embolism. So I felt it probably is not completely acute, but might be acute on subacute to acute to chronic. So I decided to do an atherectomy in this case. And when I taken up an angiogram, this was the angiographic findings. Excellent SFA, and you can see just a popliteal occlusion and fairly good distal runoff in this case. I decided to do an atherectomy. Of course, we did the atherectomy. We used one of the atherectomy systems, and we did it up to the proximal tibials as well. And after that, whatever the residual lesion, we also decided to do a drug-coated balloon. And this was basically the post-atherectomy angiogram. We of course performed balloon angioplasty as well for this. On extravascular ultrasound, of course, this was an eccentric plaque in the popliteal artery, and with a small possible pseudoaneurysm. That's why I asked about the risk of perforation in these cases where it can be tricky. But of course, on Doppler, it did not look like a pseudoaneurysm that was worrisome in this case, and with good flows on the Doppler. So another companion case. Now this is a 40-year-old male with severe rest pains in 12 hours, no type 2 or diabetes or hypertension. This patient was basically COVID-19 positive, and Doppler suggests of occluded popliteal artery. I'm going to run you through the angiographic images. It's an acute popliteal occlusion and almost no runoff below. So Dr. Shabnam, what would you do in these cases?
So if he is going to be class 2A, 2B, I will still first go for lysis in this patient and then take a shoot in 12 hours and see what is the outflow down. He has rest pain. If he has still preserved motor and sensory, it makes sense to still do lysis.
Yeah, it's rest pain, preserved sensory and motor. So
do CDT.
So again, you would prefer probably endovascular in this case. What do you think about maybe a rheolytic pharmacomechanical thrombectomy, like an angiojet?
I would first prefer to do CDT. Because I do face patients who have a lot of economic constraints, so definitely CDT and then take the shot. And
this is very recent, 12 hours. So
still
should
CDT,
work,
sir.
Should work.
Still CDT.
I also would
I should tell that patient was rich.
Even if it is
Okay,
rich,
so
I'm going to go
Dr.
for
Rajesh
CDT.
comes from Pulse Clinic in Nagpur. He gets the richest patients of Nagpur. Yeah,
Stella
the poorer patients go
should try,
elsewhere.
thrombolysis first.
We are not seeing the tibials.
Yeah, there's absolutely no runoff.
So the angiojet is a difficult problem in tibials.
Okay.
So it's okay for a bigger vessel, not for the small one.
So what I would like to tell everybody is Dr. Rajesh Mundra decided to do an angiojet in this case. So these are the angiojet images, and he's gone all the way up to the pedal plantar arch with the angiojet. So you can see angiojet done here, and this is the post-angiojet thrombectomy angiogram. And I think this image can make anybody a believer, a non-believer a believer, that angiojet really works. And with very, very beautiful perfusion. So when would you avoid thrombolysis in these cases? So I think, of course, if there's an active bleeding, recent surgery, stroke, severe uncontrolled hypertension, or 2B with some amount of motor deficit, we would try to avoid thrombolysis. Sorry, my last 2-3 slides. And so remember, I think for the panel as well, that we always monitor for reperfusion injury. If there's atrial fibrillation, we'd always want to keep on long-term anticoagulation, statin risk factor modification, search for the embolic source. In the acute setting, of course, we want to treat first and then search for it. And of course, we run through our ABGs, make sure you rule out metabolic lactic acidosis, acute kidney injury, if required, dialysis. Sometimes they say there's a role of allopurinol as well to reduce free radical oxidative damage, and often there may be a need for fasciotomy as well. So I think the key guidelines for our audience here is it's very useful to go through the ISVIR 2020 acute limb ischemia guidelines, SVS, AHA, ACC, and I think in viable limbs, endovascular should be preferred first, unless of course the patient goes to a surgeon. So acute limb ischemia is a time critical emergency. The Rutherford class should ideally drive therapy, and endovascular and surgery are of course complementary. And of course intervention radiology and endovascular therapy can play a very, very central role in modern acute limb ischemia care. And I always believe that if the vascular surgeon and the intervention radiologist can work together, then it's always going to drive even better results to the patients. Any closing remarks from our panel?
No, all these popliteal cases which you showed, they are clearly embolic. So once you handle this, the source should be looked for. The another patient you talked about, pulmonary thromboembolism, the patient had, and again another
in 2013, yes. So that was
was venous area. Now
correct.
This is arterial area. There is a cause for his.
Absolutely.
So those etiologies should be looked for.
Just I wanted to highlight, because time is crucial in ALI. We have, we always keep on saying that embolectomy can be done. I agree with surgeons, they do embolectomy, but even with new devices, it can be very, very fast. So we can't shy away from using new devices. I believe we have shown all devices, and we have saved all limbs.
Yeah, and we have also done it at all possible costs. So a small disclosure, the mechanical thrombectomy that I performed was performed with a neuro guiding sheath called a ballast. Yeah. And the tibial thrombectomy I performed using a Cook shuttle sheath, a 5-French sheath, which cost 8,000 rupees. So it need not be cost intensive, it can be very cost effective as well, and we can drive therapy which is cost effective. Thank you everybody, I hope you all enjoyed this session.
No, I just wanted to just reiterate that if the limb is 2B, then you have to be very careful.
Absolutely.
You have no time.
Yes.
It has to be extremely fast. So you can't be giving slow lysis and stuff like that.
All right, thank you everybody. Thank you. I'll invite everybody to come forward to take a picture.
Good afternoon all. I think we'll start off with the session on biliary transplant interventions. I invite the chairpersons for today's session, Dr. Vishal Bakre, and Dr. Madhusudan KS. I invite Dr. Anubhav Khandelwal onto the stage to talk on retrievable and biodegradable biliary stents, how, why and when, a case-based discussion. Over to you, sir. I also invite Dr. Ravi onto the stage, who is a chairperson for this session.
I'm going to discuss very briefly on retrievable and biodegradable stents, focusing mainly on biodegradable stents and exploring how, why and when can be used in managing benign biliary strictures. So I think everybody would agree that benign biliary strictures present complex therapeutic challenges, and for the simple reason that they have high recurrence risk. Often patient presents with recurrent cholangitis, need multiple readmissions, more often unplanned than planned, and there does not exist any standardized protocol for managing benign biliary strictures. So definitely we need a stent solution which is very durable and also self-resolving, which would reduce the number of procedures these patients have to undergo. So the current treatment options, when we look at the non-surgical options for benign biliary strictures, it's primarily managing endoscopically with multiple plastic stents, or in situations where endoscopic procedures are not possible, then percutaneous biliary drainage catheters, which are internal and external drainage catheters, which have to be maintained for a while, and multiple exchanges are done for these. We saw in 2008 introduction of fully covered metallic stents which were retrievable, and they somehow reduced the number of multiple exchanges and multiple procedures these patients had to undergo, and these could be placed both endoscopically as well as percutaneously. However, in percutaneous method, the PTBD catheters had to be maintained and had to be exchanged. So it just reduced the number of endoscopic procedures. And talking about their efficacy, there's been randomized controlled trial which actually showed that they had similar efficacy for the management with multiple plastic stents, which was the conventional method. Talking about their long-term outcomes, fully covered SEMs have a very robust data in terms of endoscopic management, but however the follow-ups in all these studies have been around 5 years, follow-ups showing their good patency rate almost up to 70 to 80%. But recently we saw a Korean study coming with their 10-year follow-up data. This is the only 10-year follow-up data with retrievable stents, and what it showed was that the 5-year patency rate was somewhere around 60 to 70% in these patients. However, at 10-year, the patency rate was only 54%. So that's about the fully covered metallic stents. Now, the issues with the conventional biliary catheters which we place for these patients is that patient requires multiple exchanges, there are multiple procedures, often unplanned because of the displacement of the catheters, or there is bile leak. So these patients have to undergo several times on the procedure list. Again, with endoscopic stents, again you need multiple procedures. All these have to be done under sedation, and patient has to be admitted for that. And obviously for these reasons there may be reduced compliance, and there are problems managing that. Retrievable SEMs reduce the number of endoscopic procedures, but then there was always a risk for displacement of these or migration of these stents, and also the patient had to come back for retrieval of these stents, and if these patients didn't come on time, then delayed removal was kind of complicated and becomes a troublesome procedure. So obviously there is a need for a similar stent solution which would resolve on its own and would not require retrieval or not require a very meticulous follow-up for these patients. And biodegradable seems to be a logical answer to that. So these are actually a self-expanding stents. They are made up of polydioxanone material, and they usually degrades in 6 months. The degradation process starts in about 3 months' time. So there's a gradual hydrolysis of these stents once placed. For 3 months at least, they maintain their good radial force, and after which they starts degrading. and obviously no removal procedure is required for these. So the key mechanism remains the same what is there with the multiple plastic stents, that you have they offer a temporary scaffolding around which the tissue remodeling happens, which results in the stricture resolution. The placement of these stents can be again percutaneous or endoscopic. The stent diameters usually range from 6 to 10 millimeters, so you can choose what size of stent is needed, and degradation usually starts after 3 months. If we look at the data behind use of these stents, so there is definitely paucity of data. There are no randomized controlled trials and there are no large studies. However, there are 9 major studies which have been published in last 10 years, and if I was to present the cumulative effects of it, then almost these studies cover placement of 323 stents. The technical success across the studies have been almost 100%, and the patency in all these studies are equivalent to what we see with the fully covered metallic stents. So the patency at 60 months, that is 5 years, is almost 70 to 72%. If we want to compare biodegradable stents with the conventional treatment, then in terms of number of procedures, you do not require multiple procedures. It's just one procedure. You do the plasty and you place the biodegradable stents. That's about it. If we compare it with external drainage catheters, there are no external drainage catheters which need to be maintained even if you put in percutaneously. If put in endoscopically, there's no need for multiple sessions, and if we compare it with the fully covered metallic stems, obviously there's no need for a repeat procedure for removal. So that's how it compares. Coming with the case example, so this is a 35-year-old female who had cholecystectomy, had bile duct injury after that, and was managed with Roux-en-Y in 2016. However, patient continued to have multiple episodes of recurrent cholangitis, and then there was hepatolithiasis as well. A year later, she came for management, and a PTBD was planned for this patient. Obviously, as you can see in these images, there was some sludge and calculi load in the left as well as right hepatic ducts. So the stricture was negotiated, plasty was done for the stricture, and 3 months later, the stone removal was also done for the ducts, right and left hepatic ducts. Once the stone removal was done, patient was again maintained on multiple PTBD catheters. Again, the concept being that they form the scaffolding around which the tissue remodeling had to happen. So this patient had maintained these catheters for a year, and after a year, and every 3 months the catheter was exchanged. At the end of year, we did cholangiogram, showed that there were no calculi. The stricture was remodeled, there was no hold-up of contrast, and the catheters were removed. 5 years later, in 2023, patient came back with stricture. She had cholangitis, she was also having calculi in the right hepatic duct, and a PTBD was offered, a repeat PTBD was offered for this patient. However, patient did not want to keep catheter this time for so long, and she wanted a solution. So we offered both the solutions, like one was the placement of fully covered SEMS, and the other one was retrievable, the biodegradable stent. The problem with fully covered SEMS was we were not very sure that if we would need to retain the other catheters along with it, so that to prevent jailing of the other ducts. But on cholangiogram, it seemed that the left hepatic duct and the right posterior ducts were clean of calculi and they were draining well. However, it was the right anterior. So patient opted to take for the biodegradable stent. We placed a biodegradable stent, and this was done in 2024 April, that is last year. And now it's been more than a year follow-up, and patient is free of any symptoms. Her GGT and alkaline phosphatase are all good. Patient does not have any cholangitis. Though she's from Kashmir, she hasn't come back to us for ultrasound, but I'm hopeful that she's doing well. So just to summarize, if we have to say when do we actually consider biodegradable stents. Obviously, patients not wanting to retain PTBD catheters or not wanting to undergo repeat ERCP procedures, we can offer them. And biliary strictures which are refractory to the conventional treatment. Also in post-transplant patients, and specifically pediatric patients, it's very difficult to, most of the pediatric post-transplant patients have hepatic jejunostomy. It's very difficult to have small babies maintained on multiple catheters. Most of the times they remove the tubes by themselves. So these are the candidates where we can actually consider biodegradable stents. Thank you so much.
Excellent talk. One of the, I've used biodegradable on transplant recipients. The difference between biodegradable and fully covered stent is, you mentioned most of it, biodegradable have side openings. So whereas fully covered is covered, so if you place it across branches, it will occlude the side branches. You need to train that also.
Yeah.
So this as an advantage, you can even deploy it in the intrahepatic positions.
Absolutely. Thank you. So that's what, we haven't had those patients yet. It's been just a year since we've been placing. We've placed it in 7 patients. So far, so good. The results have been good. But obviously, I mean, these patients, other than, suppose it's post-transplant patients or one segment which is getting strictured, you can talk about, the other only option is surgical. You have to do hepatectomy and you have to do, segmentectomy for that segment. Other than that, they have to undergo a repeat PTBD. That's what has been happening for all the PTBD procedures. When they come back for recurrence, it's again a PTBD or again a ERCP. Covered, yeah, so that's what. So covered stent is, but it has to be again maintained with the PTBD catheter because we have to retrieve it. If it's being done PTBD or ERCP, then they have to go in and remove it. Again, the jailing of the duct, as sir said. So we have to maintain another catheter in the other duct and the plastic stents in endoscopic methods.
This company is recommended for only under 3 to 6 months. So we delay removal for more than a year sometime, but then the sheath goes away. If the sheath goes away, then you can't remove it. In a benign disease, many of them develop stent-related complications after 1 year.
Right.
So I invite Dr. Parul Gak, the next speaker, to talk about rendezvous procedures in biliary disease.
So, good evening everyone, and I will be talking about rendezvous techniques for biliary diseases. So what do we exactly mean by rendezvous? Rendezvous means meeting at one point. Now this meeting at one point can be through 2 different routes, which can be both percutaneous endoscopic, or maybe EUS guided also. So the target is to reach and cross the point of concern, which is uncrossable, or in biliary diseases like we have certain bile leaks. So in failed ERCP or PTBD alone, post-surgical complications like bile leaks to re-establish flow across the bile duct injury, and in uncrossable complex strictures, whether malignant or benign, we can use rendezvous techniques. So the general steps are, of course, when we require a PTBD access. If we are doing it combined with a gastroenterologist, we need an endoscopist along with us. And then we perform the rendezvous, and the wire, the trailing end of the wire is caught by either route, by either endoscopic or the percutaneous routes. So the simplest form of rendezvous is when we give wire to the endoscopist and they catch hold of it by the endoscope, and use it as a method to put a plastic stent or any other intervention. So variations are that it can be PTBD assisted by IRs only, like percutaneous, endoscopic, and then it can be done by gastro people like EUS guided. So I will be showing you one example of a totally percutaneous rendezvous technique for a malignant biliary stricture. This patient was a type 4 hilar stricture. The image is not that good showing the stricture, but from right side I was not able to cross, it was very tight, and to the left I was able to go down into the duodenum. The wire from the right side was going again and again into the left sides, as we can see here. So what we did was that through the sheath we snared this right sided wire and took it outside the sheath and looped it back again into the sheath on the left side. So as we can see here, the right sided wire is taken out through the sheath, looped back and into the duodenum and parked it a long length. Now if we pull it from this side, from the right side, it will straighten. So we are pulling this and we could straighten the wire and cross this tight stricture, and then 2 metal stents were placed. So this method allowed us to do primary stenting in the single sitting, otherwise we would have to place an external catheter on the right side. Now I would be showing you few techniques of combined percutaneous endoscopic methods for bile leaks and duct transections. This is the lasso technique. Lasso means a hook through which we can catch anything like a loop. So this is an animation where we show the bile duct transection, and as we could see that the loop was snared from this gap of transection. So this is the patient, like from the endoscopist gives us the wire at the site of the transection or the biloma at the bile leak site, and we can snare it from the percutaneous route and gain through and through wire. So this was a patient, 35 years old male, 2 weeks post lap chole. We can see that there are multiple clips at the site of injury with a leak of bile. So in this, similarly, we passed percutaneous wire which went out into the peritoneal cavity. Through the endoscope, another wire was passed and then it was snared through the percutaneous route. This is the video of the wire which we are snaring from the percutaneous route. Through and through wire and catheter could be placed, and then a plastic stent was placed through endoscopic route. We can also place it by the percutaneous route. Another similar case, bile leak, then it was snared from the percutaneous route, and so this technique enables us to cross the transections which are otherwise uncrossable by either endoscopic or percutaneous route. So this patient had multiple plastic stentings, and at the end of 8 months, these plastic stents were retrieved, and we see that the CBD continuity was restored. Now another technique is the drain loop technique, where again the wire from the percutaneous route, whenever a surgical drain is placed, we did 6 cases and we found that whenever a surgical drain is placed, the wire goes into the surgical drain, and there is usually a fistulous communication from the drain into the distal CBD. So we utilize this, and through the drain outside the body, we looped it back. Like in this case, we see that the contrast is going into the drain and also into the distal CBD across the gap. So this wire was passed outside the body through the surgical drain, looped back and then into the distal CBD. We parked it a long length into the duodenum and pulled it by the percutaneous end and placed plastic stents. Sometimes only percutaneous pulling may not help because the wire can be pulled out, so we may require endoscopic tug also at the end of the duodenum. This was a similar technique where the right posterior duct was injured. Similar approach we did, percutaneous wire looped into the drain tract, passed into the distal CBD. We can see that there is a curved track into the distal CBD. And we could place a plastic stent, but we see that endoscopic tug had to be given to the wire at the duodenal end because the tract was very curved of the right posterior duct injury. Magnetic compression anastomosis is another example for a rendezvous because two routes are required, a daughter magnet from the percutaneous route and a parent magnet from the endoscopic route. This is one example where we had a tight stricture post-cholecystectomy. Two magnets were placed from either end and they united and we could go across the site of stricture, which was not crossable. And at 8 months, all the plastic stents were taken out and the CBD was restored. So rendezvous techniques play a great role in maintaining the continuity of the bile ducts whenever we fail through either route. Now there have been other certain examples of rendezvous techniques for the management of bile duct injuries. This is a similar example like we used in a drain loop technique. Instead of the surgical drain, they did a rendezvous through the biloma. There was a biloma and they placed a sheath in the biloma and again did the same technique by going through the percutaneous route, snaring the endoscopic wire from the biloma cavity and then making it through and through. Similarly, cholangioscopes can also be used for rendezvous techniques. In this diagrammatic representation from a paper, a cholangioscope was passed from the percutaneous end and sharp needle recanalization was done at the site of stricture by the illumination of light and by passage of the hard end of the wire in methylene blue. Similarly, in this paper, this was the injury to the right posterior duct, which there was a hepaticojejunostomy, and these people also did a sharp needle puncture of the jejunum. They did a puncture of the jejunum and then through the jejunum into the biloma cavity they did a sharp needle puncture and through the PTBD tract they pulled out from the biloma cavity. So there are a lot of techniques which we can apply whenever there is failure of passage of wire across a site of stricture, across a leak, hepaticojejunostomy, and we can help the patients by restoring the continuity and at least we can buy out time till final surgery is done. So rendezvous procedures help in difficult biliary strictures or bile duct injuries. The patients, we can help them by tiding over the crisis of sepsis whenever there is non-availability of immediate surgical expertise, prevent morbidity and mortality, and bridge over as a route to surgery. Thank you so much.
Thank you, Dr. Parul. That was nice spectrum of cases which you did. So just one question. So where were you doing all this? In their endoscopic suite or were you getting the endoscopist to your IR
So
suite?
it is a gastro center in Meerut. So we had a very good, coordination with each other.
Okay.
Because that is a must for doing such procedures. Right. Otherwise it is very difficult.
Yeah. So because the problem is you having a comfort in doing in their machine, doing PTBDs in their machine.
No, this was done in cath lab only and sometimes yes in the CM.
Yeah, that's right. So any questions? There is time for one question from the audience if it is there. So just one more question. How about the magnets? So how did you take the magnets off? Did you push it into the bowel or?
We can have many methods. We can push it into the bowel by either balloons, the ERCP balloon extraction. Otherwise, there are rat tooth forceps. We can pass it through the percutaneous sheath and through the endoscope. So there are.
Thank you. Thanks.
Time is up.
So for the next topic, I call upon Dr. Divya Mohan Hazarika, who will be speaking on extra anatomical biliary stenting case-based discussion.
A very good afternoon. My heartiest congratulations to the organizing team for the impeccable arrangement and gracious hospitality. I will be speaking on extra anatomic biliary stenting. First, background. Internal biliary drainage is the aim of all palliative procedures for unresectable malignancies and in some cases even in chronic benign conditions causing symptomatic biliary obstruction. To improve quality of life, we put internal stents so that patient remains free of tubes. However, in spite of advances in catheter guidewire technology, large tumors, very serous tumors, and long strictures may prove difficult to cross. Hence, alternative methods to assist internal drainage may be required. So here comes the role of extra-anatomic biliary stenting. What exactly is extra-anatomic biliary stenting? It's a rarely used technique. Basic purpose is to provide internal biliary drainage. We can use a track whether it's a intrahepatic or extrahepatic, and obviously we are not going through the normal colorectal route. It can be done with radiologically or with the help of endoscopic ultrasound. We can divide them into percutaneous hepatogastrostomy, percutaneous hepatoduodenostomy, or percutaneous hepatojejunostomy, as well as transparenchymal bridging or intrahepatic tract from a segment of liver, one duct system to another duct system. So, what are the scenarios where we can do it? In chronic benign and malignant biliary obstructions? Obviously, they are inoperable lesions. There is failure to internalize by anatomical route. And ideally, patients of CA gallbladder are not candidates. Patients having a relatively longer life expectancy like cholangiocarcinoma are ideal. First, percutaneous hepatogastrostomy. This involves creation of a communication between the biliary ducts on the left lobe of liver and the gastric lumen, which is followed by placement of metallic stent to enable drainage of the biliary system into the stomach. Because this approach avoids the tumor-related complications, there is no stent ingrowth. There is a long-term patency, and we can expect lesser complications. This can be done by endoscopic ultrasound route as well as by radiologically with IR methods. First case, percutaneous hepatogastrostomy. This 68-year lady, she is diabetic on insulin with deranged renal function. She underwent multiple previous ERCP guided metallic stenting outside for lower end CVD stricture. She had received chemotherapy for some duration. Surprisingly, she was not operated, and at that time, the records showed there was a proven malignancy in the lower CVD. At present, there is no disease on PET, and she actually had taken chemotherapy almost 2 years back. So now she is presenting with recurrent cholangitis with jaundice and slash-packed CVD. The surgeon was not willing for a bypass procedure. Because of chronic cholestasis, she developed complications of chronic liver disease with low albumin, and overall GC was 4. So this is the pre-procedure plain CT, axial NCCT. Here we can see she has already developed chronic liver disease. There is bilateral biliary ductal dilatation. The CVD is distended with sludge. You can see distended gallbladder, spleen is enlarged. So, and lower down we can see there are 2 metallic stents. They were placed by the endoscopist previously, and there is one broken fragment of a plastic biliary stent also inside. The endoscopists, they didn't want to do anything, so ultimately patient landed up with us. So initially what I did, I placed the external biliary. So initially external drain was placed, but the patient didn't want to keep external drains, and so basically what we did, we placed a metallic stent from the left ductal system into the stomach. First we punctured the segment 6 duct, we crossed to the opposite side, and we selected the segment 2 duct because this is in line with the stomach and there is less chance of injury to the spleen. So once the guide wire in the segment 3 duct, we exchange it to a M-Plus ultra stiff guide wire, and over that 10 French flexor sheet was advanced, and through that we did a puncture from the stomach, from the left ductal system into the stomach. This is once the procedure is completed, there is a metal stand from the left ductal system into the stomach, and basically this completes percutaneous, what we call hepatogastrostomy. Second case, this is an intraparenchymal. This is a parenchymal bridging where we received intrahepatic extraanatomic stenting. This is a 70-year male. It's a biliary obstruction due to unresectable hilar cholangiocarcinoma. Patient had, we placed multiple percutaneous external drains via third, sixth, and seventh segments. Subsequently, internalization of the external catheters were tried. However, internalization of the right-sided system was possible. We could not do from the left-sided system. So we reviewed the CT and basically we tried to make a communication between the right and the left ductal system. The basic purpose was to make the patient catheter free. This is the pre-procedure scan. We can see in front of the portal vein bifurcation there is this is the right hepatic duct and the segment 8 duct. This is the segment 4 duct. This area is avascular. Even the artery is lying quite far away. So the decision was taken to place a stent from the segment 4 to segment 8 intrahepatic. This is the bench-work profile. This is showing, this is the tips cannula in segment 8. This is an profile view, and this is gooseneck snare in the segment 4. And this is end phase. So under USG as well as fluoroscopy guidance, puncture was done from segment 8 into the segment 4, and the metallic biliary stent was placed. This is a smaller stent, around 6 mm stent was placed from the segment 4 into segment 8. From rest of the bile ducts on the right side, ring biliary catheters were crossed into the duodenum, and later on they were replaced by metallic biliary stents. This is completion CT showing stent from segment 8 to segment 4. Patient remained free of catheters for 6.5 months. Sorry.
Time is up.
I will have a quick review of literature. The first attempt at percutaneous hepatogastrostomy was done by Stules, who reported this technique of peripheral biliary decompression by means of anastomosis of a bile duct from segment 2 with liver. Triple D, he initially placed a COPS anchor system under CT guidance, and he performed the second step a few days later using fluoroscopy. In terms of long-term follow-up, Gilles, he performed around 35 cases with mean patency of 234 days plus minus 50 days. There is no report of creation of an intrahepatic breach for setting up a communication between the right and left-sided bile ducts in English literature. Recently, we published in our own JCIR one case series of 3 cases where in all the cases their conventional percutaneous and endoscopy methods had failed, and we could achieve technical success in all cases. This image actually I have borrowed from Dr. Rajesh from Rajagiri Hospital. You can see there is excellent demonstration of the stent inside the stomach with fluid distance in the stomach. This is an ultrasound image, corresponding CT image showing the stent in situ. In all patients, it was done in cholangiocarcinoma type 1 block. It was stated that we can do it in type 2 and higher blocks also. Contraindications is obviously inability to pass guide wire from right to left, multifocal strictures, tumors intervening the tract, ascites, large varices, and uncorrectable coagulopathy. This is the patient profile. We can see all the patients. In 3 patients, the follow-up was available from 5 to 14 months, and stent was patent till the last follow-up. I will just skip these things. So basically this approach is particularly suitable for patients with hilar tumors and patients with relatively longer expected survival. So my take-home points, this approach
Time is
enables
up.
one to successfully place biliary endoprosthesis across obstruction previously considered not amenable for internal biliary drainage. This is an innovative technique. It may be an addition to the IR armamentarium for optimizing palliation in patients with unresectable biliary malignancy and chronic obstructions. Technical success is achievable with acceptable stent patency rates without significant complications, and obviously further studies are needed to confirm its broader utility and long-term outcome. Thank you.
Any questions? No questions. Thank you, Dr. Divya Maman, for the talk. So I call upon the next speaker, Dr. Kranti Kumar Rathod, on biliary calculi, the IR perspective and lithotripsy review and application for biliary calculi. Kranti Kumar. So sir is unfortunately not here. So the session thus gets concluded. Thank you, speakers.
For those enlightening talks. So we'll move on to the next session. I invite Dr. Tegbir Singh Sidhu, the chairperson of the next session, and Dr. Pradeep Hatimota and Dr. Lieutenant Colonel Sachin Girdar. Dr. Pradeep and Dr. Sachin. All right. So I think we can start off with the next talk. I invite Dr. Santosh P. onto the stage to speak on safety and efficacy of primary stent placement for hepatic artery kinks in liver transplant recipients, a case-based discussion. Thank you.
So good afternoon, one and all. Thank you. So it's a simple topic. We'll see what is the role of stenting in hepatic artery kinks post liver transplant. Traditionally, it was a domain of surgery. So to know the importance of hepatic artery, we should understand what happens during the liver transplant. In the native liver, the biliary tree is having a well collateralized supply from the hepatic artery, the GDA and the portal venous circulation, but in a transplanted liver, the hepatic artery is the sole supply for the biliary tree, and any compromise of the hepatic artery in the form of a stenosis or thrombosis or a kink, whatever it is, it will lead on to disastrous biliary complications like ischemic cholangiopathy, biliary necrosis, sepsis, and even graft loss. And this incidence of hepatic artery issues are in close to 4 to 11%, and they are more common in the pediatric population because of the mismatch of the arteries between the donor and the recipient. A kink is slightly different from traditional stenosis because kink is just an acute angulation that happens because of a redundant artery. It results in an angulation more than 60 to 90 degrees, and the artery basically coapts, and because of which there is a hemodynamic obstruction. It usually occurs due to a vascular redundancy because of a longer than required donor hepatic artery anastomose to the recipient hepatic artery, and as the graft settles in the right hypochondrium, the hepatic artery, the longer hepatic artery results in a kink, and it transforms to a very sharp flow limiting angle. The other issue is in conduits. Long aortohepatic conduits are also susceptible to kinking because of this anatomic changes post liver transplant. Does SPOBA help here? It doesn't help because the mechanism of a kink is ingrained in the vessel memory. The longitudinal memory brings back the vessel after the angioplasty is done, because once the balloon is inflated, the vessel straightens, the vessel appears to straighten, but once the balloon is deflated, the vessel immediately recoils and takes its original configuration, and there's loss of around 35 to 50% of the luminal gain that we have achieved immediately after angioplasty. So historically, if we see, there was a major study by Saad published in JBR 2005, which showed that in hepatic artery kinks, the success rate of plain balloon angioplasty was just 14%, whereas the success rate in a traditional stenosis was 94%. So this was a prime reason why an endovascular procedure was not performed for a hepatic artery kink. Also thinking that if we put a stent, the kink may propagate either proximally or distally rather than get resolved. So that was the understanding behind recommending surgery for these patients for the past 2 decades. And the complication rate was also unacceptably high, around 30% for kinks treated with percutaneous angioplasty alone. So that's why the traditional recommendation of surgical revision was given. But however, everything changed by 2025. I'm sorry, why there is loss of... Yeah, we got it. So by 2025, there was a landmark study published in CVIR, where it was an American center study published by Vijay Ramalingam et al., which examined the safety and efficacy of using primary stent placement for hepatic artery kinks after liver transplant. And they found a remarkably high success rate of 92% at 1, 3 and 5 years, which was primary patency, and primary assisted patency was 100%. So this was a very landmark finding, because of which the whole understanding of the kinks have changed. And now they say that the stenting a longer segment of the artery, proximal and distal to the kink, provides a rigid mechanical scaffold, and that actually permanently neutralizes the elastic recoil, restoring the laminar flow. And if there is any need for reintervention, then the assisted patency is nearly 100%. So this was a single center retrospective review, which was done for a period of around 24 years in a single center, and 15 liver transplant patients who received stenting for hepatic artery kinks were analyzed, and the technical success was achieved in 14 out of these 15 patients. There were 0 complications. That was the main point to note in this study. Only 1 patient required a reintervention, which was for a mid-stent kinking. So this was, though the sample size is small, this is a rare phenomenon that occurs. So in a very high volume transplant center, they could get only 15 patients of the, for a period of around 25 years. So how do we come to the diagnosis? Obviously, we do the Doppler in a patient who is symptomatic or asymptomatic. We routinely follow them up with a hepatic artery Doppler, in fact Doppler for analyzing all the 3 anastomosis. And in a hepatic artery Doppler, if you see the Tardas Powers waveform or a focal increase in PSV of more than 200 with an intrahepatic resistive index of less than 0.5, then we have to diagnose that there is a hepatic artery issue, and all these patients have to undergo a cross-sectional imaging modality, preferably a multi-director CT angiogram. So in the MDCTA, we can actually detect what kind of lesion the patient has, obstructive lesion the patient has, and if it qualifies for a kink, then we have to go ahead with a further angiographic procedure. So deciphering from this study, the recent study, we should convince our liver transplant teams to send these patients more and more for endovascular treatment. And DSA is the gold standard to diagnose the kink. And one thing they have given in the study is you should analyze the kink prior to passing the wire, or the wire should have the soft part across the kink rather than having the stiff part, because once you cross distally and the stiff part goes across, the kink gets straightens artificially, and we may not have the right idea of how much of stenosis the patient has because of the kink. So that is one of the pearls they have given. And we have to choose the right stent for the right vessel. So we size 1:1 a balloon expandable stent, and for the hepatic artery post transplant, the right stent should come from the coronary system, because less than 5 mm is the size of most of these vessels, and if it is less than 5 mm, go with a drug-eluting coronary stent, balloon expandable stent. And if the patient has a very tortuous kink, which you fear the coronary stent may not take, then you can go ahead with a self-expanding neurovascular stent if you have one. And you should always have a stent graft on the shelf for salvage in case the patient goes for a rupture after the angioplasty or the stent placement. So what we have to do is the traditional axis, the femoral or radial, depending on the angle of the celiac axis. We should have a 6 French guiding at least to take a good support for our wire and the stents to go across. And then we cross the lesion usually with a 0.14 wire, which takes coronary hardware. And we size the stent 1:1 with the vessel, and we cover the entire kink segment with liberal sizing to cover the proximal and distal zones. Spot stenting displaces the kink, and that should be avoided. So this was one of our cases which presented to us with a normal LFT, just a routine 1 month follow-up post live donor liver transplant. And you can see that definitely there is a parva status waveform, although the patient was asymptomatic for it. We proceeded with a CT which showed an anatomy where the donor hepatic artery was anastomosed to the recipient left hepatic artery. There was a tight kink at the anastomotic site. So initially we thought it was just a stenosis, so we proceeded with the endovascular
Last 2 minutes.
as advised by the liver transplant team. So here we can see that the anastomotic stenosis looks like a kink because of the redundancy. So this was in 2024, so we didn't have an idea of going ahead with primary stenting, so we just thought we'll do an angioplasty and observe. So we did the angioplasty. This is again with the coronary balloon, sized according to the vessel. We achieved a very good satisfactory result, and immediately post procedure we got a very good hepatic artery waveform with normalized RI and velocities. So we were very happy. This was the pre-angioplasty picture, so definitely it improved. And but 2 months later, the patient again on a follow-up was again detected to have a restenosis because of the recurrence of the parva status waveform. The CT confirmed the restenosis. This was the immediate post-angioplasty picture. You can see it has again recoiled to the pre-procedure picture. So we did an angiogram. We found the kink has reappeared. The stenosis was more pronounced this time, so we placed a stent. So this is a post-stenting picture. You can see it has definitely improved the flow. It has straightened the whole vessel and has not propagated the kink proximally or distally. So this hepatic artery was patent at 1 year. This the next 2 cases are from the article, and they have similarly placed hepatic artery coronary stents for both the cases where this is a 7-day post-transplant case, and again a folded kinked proper hepatic artery in the cone beam CT, and this is a coronary stent placed across the kink, and it worked very well without propagating the kink proximally or distally. Again a similar case at the apex of the proper hepatic artery, and then this is the wire across. You can see that sometimes the stiff part of the wire, when it is across, it may pseudo straighten the vessel. You may not judge the kink very well, but in these cases you have to pull back and see the soft part across, with the soft spot across to find out how much the kink is, or you have to assess it prior to passing the wire. So whenever we land with a trouble, the most common problem or the most dangerous problem is an arterial rupture after the stenting, because it's an anastomotic site. So you have to be prepared to immediately reinflate the balloon, resuscitate the patient, call for the liver transplant surgeon if he's not already there, and also you have to prepare for the stent grafting. If you should be ready with the graft master. And if it's a flow limiting dissection, usually it can be treated with a tack stent. And if there is an acute instant thrombosis, you should have prepared these patients with dual antiplatelets. If not, you can give GP2B3 inhibitor on table and then continue the dual antiplatelets. So if in spite of all this, if this is an unstentable anatomy because of extreme tortuosity, you can use of augmentation techniques like splenic artery embolization, or if still the patient is not a candidate for failed or the patient has failed an endovascular therapy, patient can go for a surgical revision. So that's it. So stenting is a very good tool for hepatic artery kinks based on the only study that we have got, and it has got a very good primary and primary assisted patency of nearly 100% in 5 years. So it's a very doable treatment for hepatic artery kinks. Thank you.
Thank you, Dr. Santosh. A very enlightening and a very informative talk. Thanks a lot.
Thank you.
And of course, problems with the course and caliber of the graft arteries in a post-liver transplant patient are one of the very few panic buttons that we get, and these patients require immediate and very aggressive intervention, as rightly pointed out. And of course, and nicely pointed out that we can go ahead with a balloonplasty, but then never restrict yourself, go ahead and place a stent. I would totally agree with you, sir, here. The audience, the podium is open for questions. In case anybody has one, the panel is open. Or we could push the questions back to the end of the session if you feel like. Yeah, we could do that. Thank you.
Thank you.
So moving on to Dr. Amar Mukund sir for the next talk. Hepatic venous outflow complications in a post-transplant case. It's a case-based discussion and looking forward to a very, very informative session out here.
So good afternoon all, and I'm thankful for the scientific committee for having me here. So being a case-based study, I'll quickly move to the case, but having said that, we need to understand whether hepatic venous outflow complications are common or uncommon. So if you ask me, these are uncommon, but you know, even diagnosis is difficult. So that is one of the takeaway, because most of the cases would be lingering on different kind of diagnosis, which will be made on different kind of imaging as well as histopathology, and I'll show you how it happens. So let us see this case. Case 1, that is a 4-year female child, underwent liver transplantation for PFIC type 1, and on POD 4 she developed sepsis and was treated for that, was in ICU. On POD day, post-op day 14, there was persistently elevated lactate with transaminitis. Then immediately there was some suspicion whether the patient has hepatic artery thrombosis or anything else, maybe with portal vein, but everything was normal. So this is how the patients are evaluated in a post-op period, just to tell. And this is the Doppler finding, and I'm just showing you because this is a case for hepatic vein. So the hepatic vein was looking normal on imaging, and if you see the waveform, not very good, but if you see the color pattern, more or less, yes, you can say this is patent. This is so maybe nothing wrong with it on POD 14. So on POD 16, again CCT was done in view of the high lactate, which came out to be normal, and hepatic veins were normally seen, and therefore a biopsy was done, and that showed acute cellular rejection. So this is how the patient was diagnosed, that probably after the sepsis the patient has acute cellular rejection, was being treated, and she was shifted to ward on POD 32. So she kept being in ICU or high dependency unit HDU for all these 1 month, and now in 32. But suddenly in the ward on POD 34, she developed severe transaminitis in thousands, and that is how she underwent a CCT again. And this is the CCT. If you see here, this particular part of the liver, one part is showing hypoperfused area, whereas the other one is normally perfused. So two different patterns. And then we carefully evaluated the complete CT and went back and did an ultrasound again, that because the ultrasound was being done by the diagnostic group and the interventional group was roped in once this CT was seen. Then we went inside and we saw that the Doppler didn't had any flow. So immediately hepatic venous thrombosis diagnosis was made, and then this is the angiogram. So we see that there is a opacification, but if you see carefully, you can see intrahepatic veno-venous collateral. So there is a common ostium for segment 4 as well as segment 2, and both are communicating through intercommunicating branches. But the common ostium is showing some stenosis towards the middle hepatic vein, whereas the left proper hepatic vein seems to have a normal flow. So this is a very unusual kind of a picture where one part of the liver is showing obstruction, whereas the other part of the liver is more or less normal. So we went ahead, we did a balloon angioplasty, and after the sizing of balloon, we found that it has opened up, but still there is some residual stenosis. And then again, we went up with a 10 mm balloon, which is pretty large for this pediatric age group of patient. But again, you can see now it has opened up. And immediately the patient was absolutely fine. The next day, all the transaminitis started settling, and the patient was out of ICU. So this was just a month back, and patient is discharged. So what is the understanding? So that many times there may be some undulating kind of a thing. So the patient already had a stenosis on the initial Doppler, which was reported normal. Then again, there was some flow seen which was reported normal, and finally on biopsy it was acute cellular rejection. But having said that, when we went back and talked with the histopathologist, they said ki, wow, there was some perisinusoidal hemorrhage, but it was an overlapping picture. Acute cellular rejection was more prominent and hence was reported, which is more common. So many times this is mixed on histopathology as well. So that is the point which we need to understand. Now moving to another scenario, 55-year-old female underwent diseased donor liver transplant, NASH-related CLD, and the liver function test never settled after transplant, and this is how the Doppler was. If you see the color flow, there is some problem over here near the anastomosis. However, if you see the spectral pattern, absolutely beautiful, looking a triphasic pattern, and as we all will interpret, and seems to be normal, and this is how it was. On liver biopsy, again, mild chronic rejection and mild sinusoidal dilatation. So if you see here, again, there is no evidence of venous outflow obstruction. Then the MR was done, and if you see here the MR, more or less it seems normal, but if you see carefully, the same area on Doppler which was seen not picking up the color, the same area is a bit narrowed, though it is patent. If you see here, again, it is narrowed. And if you see the Doppler, again in Doppler it's a biphasic pattern. So the learning point is a biphasic pattern doesn't mean anything. Why we need to understand? Because a normal normal liver where the hepatic vein meets with the IVC, the confluence is a pliable which have a different phasicity where the part of the hepatic vein moves with every pulsations, whereas when it is anastomosed, there is a fibrosis and secondary intention healing at that point where there is a anastomosis, and that becomes a sore point, a point where there is some limiting of flow and hence the outflow obstruction. We did an HVPG for this because again diagnosis was not clear. We did a HVPG. While doing HVPG, we noticed that there is some holding up of contrast. Immediately we did a balloon angioplasty, and this is how it is. Now coming to the role of HVPG, because this is important. So which is understudied. Nobody talks about HVPG in a post-transplant setting. Very rarely some of the centers are doing. In US it is picking up, but still in most of the centers it is not being done. But here I would say if there is any such kind of patient who is not responding and probably you are having a problem, then HVPG is one thing which should be done. And what is the rationale? The recipient portal hemodynamics is influenced by pre-operative thing, so that definitely the post-operative flow would be high. So you will get to know many things, only not about hepatic veins, but you will also not get to know about the portal venous thing. So it will ascertain that about the portal pressure and the gradients, and simultaneously HV and IVC gradient, IVC-RA gradient. So you will get to know what is the gradient across different kind of stenosis, different kind of anastomotic areas. So when to consider HVPG? So current imaging including USG and Doppler is absolutely perfect. If you are absolutely clear on the imaging, probably you won't require. But if there is a deteriorating graft function, then you need to carefully see the evaluation to rule out mechanical causes. But if there is any suspicion or a doubt, then HVPG should be done. Though it is invasive, it is a problem solving tool. It should be reserved, but not as reserved as it is today. You should be more liberal in doing HVPG. HVPG
last 2 minutes.
In post-transplant ascites, it is critical to rule out portal vein stenosis and hepatic vein outflow obstruction. These are the two things which we need to rule out in ascites. Therefore, wherever a patient is having high drain output, you should definitely do and try to rule out all these things. And finally, all these PVP and hepatic venous pressure gradient can help in making confirming diagnosis. And these are certain articles which you can go, how ascites after liver transplantation was done and wedged hepatic pressure has certain role to play. People at initial days of transplant, people were doing it, but this was a forgotten science after 2008. Again, we have come back after a decade back, again we are moving towards HVPG. So probably HVPG is one of the modality which should be taken. So again another article showing similar kind of thing, HVOTO, how you, hepatic venous outflow, how it should be evaluated. With this, I come to the concluding slide, that there is a limited but important role of HVPG in early post-op period. Most important role includes confirmation of diagnosis of hepatic venous outflow, and role of HVPG in small for graft is and other mechanical causes of graft dysfunction may also be there. So HVPG is not only helping in hepatic venous outflow, but small for graft syndrome and other things that may be also helpful, and that may come in guidelines in near future. Thank you so much for your attention and being here.
Thank you, sir. An excellent talk. So, my query, a personal query, sir. Do we have any clinical indications when we should be suspecting a graft hepatic vein issue with the patient? Or do we have timelines for, say, a month or 2 weeks or something like that?
So, in hepatic venous, mostly it is very clear. Like if there is a no flow seen, that means it's obstruction and you have to. Like in the first case, we found that there was a no flow. So then there is no, but there are certain patients where diagnosis cannot be made. So that's important. You will have certain things, and of which most important would be increased drain output. If you see that ascites is not settling the way it should settle in most of the cases, then this should be one of the primary thing when you should look for the hepatic vein, even if it is normal. So biphasic may not be normal, that is what the take home is. If it is triphasic, it's good. Mostly no symptom biphasic is good, but symptomatic biphasic is not good. So let us understand, if a patient is symptomatic, biphasic waveform may not be the absolute thing. Please rule it out on hepatic venogram as well as HVPG. But in case patient has no symptom, biphasic is okay. This is the take home thing.
Thank you. That's the pearl here that we get.
Contrast CT, like in general for evaluation as a battery of test, most of the surgeons before asking you, they will definitely send the patient for CT. So that is not under your control. It's mostly ordered from a ICU. So CT would be done. So if you want to say, I'll say okay, fine. If you are doing the Doppler yourself, you can suggest venogram and HVPG, but many times surgeons may not agree, that's why it is done. But if you ask me, I'll say okay, fine, let me do a venogram, but they say that's invasive versus non-invasive is the kind of discussion what will happen between surgeons and the interventional radiologist. So many times we say, oh, okay, that's non-invasive, go do it. It may be multiphasic, maybe 4 phases, 5 phases, that is all. Yeah, so yeah, that's what I said. Even the MR was reported normal, the second case which I show. It was continuously, every time, Doppler, MR, everything was normal. We suggested HVPG should be done. So that is what, when everything is normal and you feel that there may be a hepatic venous outflow obstruction, yes, that should be done.
Next one.
So maybe femoral is a better way. If you ask me, in my practice, I am totally against putting any kind of foreign body, so I would give it a trial of POBA first. If it recurs very early, probably I'll put a stent. Otherwise, I'll just keep watching unless until patient is symptomatic again. If he comes back in 3 months, maybe he's a good candidate for stenting. But if he comes after 3 years, maybe I'll do another plasty and send him back.
But of course, this gives us a very important thing. Graft dysfunction, no known cause, think of a hepatic vein obstruction and probably evaluate it further with HVPG. And we should not restrict ourselves by not doing an HVPG this thing. So this is basically the take home that we get, sir.
Yeah, at least venogram. If nothing, venogram. HVPG, if, whether they agree or not, you can say, okay, let me do a venogram and a pressure study across the anastomosis, your anastomosis. That's it.
So then we can. Thank you, sir. That's a very enlightening talk and will definitely help us a lot in the okay, sir. The next topic today is portal venous complications in pediatric liver transplant. And Dr. Deepashri ma'am is probably not here. Going down to the next topic, IR in post liver transplant biliary complications. Dr. Madhu Prasad.
just an announcement, whoever have registered for the hepatobiliary workshop can start now. It starts at 4:30.
Good afternoon. So this is again a case-based discussion. So we will just not have a lot of theory. So biliary complications are not very uncommon. You can see it's almost up to 30%. It all depends on whether it's a living donor or a deceased donor transplant. So there are multiple types of complications: strictures, leaks, calculi, or sphincter dysfunction, or there is also a rare chance of secondary cholangitis. So two types of anastomosis, either it's end-to-end or it's jejunal anastomosis. Based on that, our approach also may change, because most of the time an end-to-end anastomosis can be managed endovascularly. This is a very well commonly seen this one. We'll go to the cases. And I just wanted to mention there is one very good article of around more than 3,000 patients of a multicenter trial all over the world, and our Rela Institute is one of the major contributors for this, especially for biliary complications. And these are their key risk factors for bile complications. And whenever there are like multiple bile duct anastomosis, it's ruined by hepaticojejunostomy, and if there is a major abdominal surgery, and for anastomotic strictures, ABO incompatibility, blood loss during the high blood loss during the surgery, and again previous abdominal surgery. So this is a study done by I think this is the highest number, where I think some 3,600 candidates are there, 3,600, and major contributor is our own organizing committee, hospital. So we'll just skip this. We'll go to the case 1. So this is the first patient, post liver transplant, altered liver function test. On ultrasound there was a clear-cut subhepatic collection which was assumed a bilioma, and on MRCP there is a clear-cut. I cannot see this. Okay. So there is a subhepatic collection, and there is a clear-cut stricture or an interruption. So this is the most commonly anticipated complications when there is a collection. So the simplest thing is to put a drain, and once you put a drain, whether there is a requirement for a biliary entry or not, it all depends on what is the post-drain picture. So post-drain, either you can go percutaneous or endoscopy. At least our approach is, my approach is, whenever it is possible, it's always better to do endoscopy, because that is the primary, the hepatologist is already part of the transplant team, and we don't have to puncture the liver. So this patient, we just punctured the liver and gave an access, and post-access patient initially got a plastic stent and later exchanged to a Cuffy stent. That is a retrievable covered stent, and which can be retrieved later. So I think that's the easy option, though it is not done by our people. I think it is a very commonly done procedure. So the take-home message is drain early, don't wait for it to get infected, and whenever you feel endoscopy is better, it is always better. It's a simple, very simple approach additional to your procedure. And retrievable stents can be used very often. I think now many people have started using it rather than putting multiple drains, exchanging the drains, and calling the patient multiple times. Retrievable stents are very simple and patient-friendly approach. So this is the second patient. Post-transplant, persistently elevated SAP, weekly monitoring was done, and suddenly got a deranged RFT. So MRCP was done. You can see on MRCP there is a focal interruption. Again, there is always a question to go endovascular first, or to go percutaneous first, or to go endoscopy first. But I think there is no option for endoscopy here. So pre-procedure MRCP and post-transplant, whenever there is obstruction or something, post-transplant MRCP or would make a very big difference, because that is where you plan your access site, because the where to puncture, because this is a post-transplant picture. So this is the access site, and you can see there is a tortuous course. Probably that's why the endoscopy couldn't negotiate it. So the cholangiogram showing complete interruption, then the tortuous course of the access, and crossing over, and then percutaneous drain. Again, stenting, I don't do primary, at least I am not primary stenting, but I think the secondary stenting is always an option is there. So this case was again given by our ILBS, Dr. Amar, thanks for it. This is the 22-month-old female child, 6 weeks post-transplant. There is persistent elevated SAP, SAP and hypoalbuminuria. On Doppler there is clear-cut gross dilatation of the bile duct. So there is an obstruction, and this was aptly taken up for percutaneous access and recanalization. So this is the cholangiogram picture. You can see there is a dilated system, but on multiple attempts there is no possibility to cross the occlusion. So of course we know that many times there will be some amount of granulation formation around the access site. We may have to do reverse wire and all those things, but of course here I think none of them were feasible. And on close follow-up, close view, you can see that there is a clear-cut staple in line with the obstruction site. So of course it cannot be crossed percutaneously. And this is a plane of resection, so there is a separation of the segment 3 to duct. So this was taken up for a hybrid approach where percutaneous access was taken and a sharp recanalization was done of the occlusion, and then went ahead for a surgical reanastomosis. So this is Dr. Amar's case. Thanks for that. And take home message is always have a multi-hybrid approach if possible. There is always a need for hybrid approach. Many times there may be a need for a reanastomosis. Pre-procedure imaging is the only thing which makes a difference, because we all do day in and day out PTBD is the very commonly done procedure, but planning is the only key. Thank you very much, and thanks Dr. Amar for the case also.
Thank you, Dr. Madhu. Nice set of cases that you put across with the biliary obstructions post-transplant. I guess this is the most common set of complications or repercussions that we get post-transplant. And nice way to put it across that multidisciplinary teams do help, and they should be kind of promoted in a way that we can get in, probably get the percutaneous approach on the second step and do an endoscopic thing first. You are right in a way, and I would kind of second you on that as well. Questions to the podium, please, if at all. Rather, in the same subset, I would, since we have around 2 minutes of time available, anybody who has a question for Dr. Santosh or Dr. Amar, please. I mean, we could take all sessions and all questions in the same set. Since I guess for a yes, sir, please.
Last 2 minutes.
So I'll just repeat your question so that I get clearly.
Beyond the first 1 week, when you're doing regular Dopplers, and say that even if the patient is discharged, how do you suspect that a kink is developing? Based purely on LFT, because then the patient comes for imaging at very monthly or 3 monthly intervals.
So you're asking how can you suspect an early recurrence of the kinking? So unless the patient comes for a follow-up, we can't definitely identify.
Or probably the question is, do you have an imaging protocol to rule out a kink, or to how to follow up a kink by Doppler in a post-transplant follow-up patient? Do you have an imaging protocol that's set in?
No, the imaging follow-up is just requested by the liver transplant team. They usually call for a monthly follow-up initial period. So up to at least 6 months, and then they follow up with bi-monthly or a 3-monthly Doppler. Yes. That is a problem. So if it was asymptomatic and the patient doesn't have any blood investigations in between, we lose it.
So we call it. So we call the session off, please. Thanks a lot. Thank you, the entire audience for this. Thank you. And we call it a day. Thank you.
Thank you all. The session has now concluded. The next we'll be having a session by Dr. Chandramohan sir. He's here already, so we'll be starting that shortly.
Okay. Good evening, friends. I think we'll start. There are so many parallel sessions going on, and I don't expect more people to join. Actually, this topic of discussion today was meant for the younger generation, and it's surprising that I had PPT sent by almost 27 people to me on this topic. They wanted to share their opinion. They wanted few things to be conveyed for discussion, and not any of them who sent me the topic is here today among the younger generation. So this is little not unusual for me, because whenever you start something new, people are not sure, but I am very certain next conference we will have packed hall if we have a topic of this nature. So let's start, and I thank the organizers for at least keeping this session, though they failed to inform me, so I came to know only 3 days ago. And I'll request some of my senior members of the society to be on the stage for very fruitful and meaningful discussions to whosoever is present here. So I'll request Dr. Girish, can I have you on the stage, please? We have not set any agenda for this because it is supposed to be an interactive session. And Anish, you please come. Okay, Dr. Khandelwal, you want to also. Dr. Swati, you have been integral part of the DRNB program, so I request you to be on the stage. Rest all can participate. Please be free. It is an interactive session. I don't have an agenda actually. So we will go along and see how you people want to discuss this topic. Anyway, I am very sure that what we are doing today, we are a procedure-based specialty and we are a subspecialty. So the challenges which our generation never faced, which are being faced by mid and young people, is the identity crisis. And unless and until we move towards the clinical specialty, this problem is not going to get solved. So this is for our access to patient, access to the policy makers, and access to the colleagues who will refer cases to us. And I am very sure this will help us in the survival if as far as IR is concerned. Dr. Ashu, can I have you on the stage, please? Why this topic is important? We are saying कि हमारे को case नहीं मिल रहा. Look at the disease burden we are having in India at present. There is an epidemic of non-communicable diseases which is actually happening. Look at the stats of various non-communicable diseases. The data which I have compiled is up to 2024. I couldn't get the stats for 2025 from various sources. And this is a government data, authentic data. Look at the number of patients which will require interventional procedures. I am not saying by interventional radiologist, but by interventionist, which will include other people also performing interventions. So there is a huge need, and look at the availability of trained people as far as we are concerned. We are only having 1/4 of the people who can perform intervention. That includes cardiologists, that includes some of the neuro people, vascular surgeons and interventional radiologists. Look at the demand. When I look at the stats as far as IR is concerned, today our strength in society is 1710 as of yesterday. But this includes many people who are not performing intervention, and some of them are very young. But the demand, currently we have only 1200 to 1500, and in due course we expect it will multiply many times. Already we are 1/4 of the requirement. This is going to get doubled. So why this session? When there is so much of need, there is acute shortage, still we want to discuss this topic. So can we have opinion from the panels? Do we need to discuss this topic? Why future of IR in India?
Of course, yes, sir, because as you were showing the statistics also, and we are also seeing in the day-to-day life also, except for some metro cities or maybe nowadays to tier 2 cities and all, where are the interventional radiologists? And even in Chennai, which is supposed to be the Makkah of health, after 30 years of practicing here also, still in those IMA meetings, what they ask me to talk on is overview of interventional radiology. Last 30 years I'm talking this, and when you talk this, all the doctors keep on, oh, you can do this also, oh, you can do this also. That means the awareness, forget about in general public, in medical professionals itself is so less. So we need to do something really about it, not only to increase our number, but increase our visibility also.
Okay, thank you. So let's go on to the requirement. Why I thought I have jotted down some of the points for you. One is, we already discussed the huge non-communicable disease burden. Then definitely we are acutely short already, so India needs intervention radiologists. But the interventional radiology needs a system which we are partially lacking. It also needs identity. There is a challenge as far as identity of interventional radiologist is concerned. We need to have a clear strategy how our younger generation is going to practice this specialty. The problem is we are growing in numbers. I told you we are already 1,710 membership as of yesterday. But this growth, if I look at real numbers, how many are actually performing, is very low. And whatever growth we are taking place, we are recruiting new members because of these politics, elections. We are recruiting them just before the conference. I think we need to stop all this. So the growth is fragile and uneven, and we are being viewed today by the other colleagues as a technical service and not as a clinical specialty. So this is a big challenge. Unless and until we take action now, our future generation are not going to excuse the present generation, because we will become procedure dependent and peripheral specialty. We will never come into the clinical mainstream. So Dr. Ashu, what you have been at the most premier institute of the country, and you have been doing very high quality work there. What is your idea why we should discuss these topics, why they are so important for our next generation?
So 2-3 points I'm going to bring out. One is always controversial in that you are not always at battle with your referring colleagues. In the sense that what I could make out from Dr. Ellen also, for instance, yesterday, people who thrive the most, who have no issue in a referral base, is when they are part of a community. Like eventually, you know, when people moved, like when Vipul started his neuro service, if you recall that time, when they left from AIMS, there was, before its time, but one neurosurgeon, one neurophysician, and Vipul left. And that time he said, I'm not going to be working in the radiology, I'm going with the neuro team. That time it was very naive. It's about 2 decades back, and I wasn't sure what he's getting into. And as a group practice, they are huge now. They are, you know, several crore turnover, giving coverage to several hospitals in Delhi, NCR and outside. So what I mean is that eventually if you're, I mean that's how it's working with us. in the institute. Suppose I am part of the head and neck community, then I sit in that clinic. So one is standalone clinics and the other is part of the main clinics. You know, those also work. Like whatever you may say, the liver transplant people are moving with their own DR, with their own IR, that gives assured jobs. And so we don't always in conflict with them, but one thing which will, I'm sure, come up subsequently is that training of non-radiologists has to stop. We have suffered a lot in DR already. We have seen so much erosion, and I know how much we are fighting to get that. My colleagues are fighting to get the OBS referral back. So let that not happen. You have to have penal measures on that. Referral base both ways, through clinician and independent. Third thing, I have been planning to have, for example, a patient support group of vascular anomalies. We don't have sufficient patient support groups like transplant people have, no, where we get them together, hold sports events, annual events, so our engagement with patients in form of support groups, wherein you are giving them psychological surveys. Like, you know, when the AVMs think they are a freak, they have a cauliflower ear. Every time I think that if I call 10 of them and they see 10 others, but most of oncology runs these breast cancer survival groups, these survivor groups. If we become drivers of forming these patient groups, then that is a huge advertisement also.
Thank you. So, Dr. Shyam, this we have been debating off the podium. What is your opinion on this? Dr. Ashu has highlighted very important issues of collaboration, what she was talking, with clinical colleagues. We'll discuss this issue in detail, the so-called turf. There is no turf actually. We have artificially created a turf. We'll discuss this issue at length. And Dr. Shyam, any other comments you want?
So my suggestion is we need to have...
Please keep the mic close.
If it is an institutional practice, MDTs play a major role. And we should have a clear definition regarding who is supposed to do what at the end of the MDT. And our role should be well defined. So this is a simple suggestion what I have.
Okay.
But in private practice, I do not have much idea how to draw this kind of lines.
See, having worked in both government sector, 32 years and 18 years in private sector, I understand the dynamics of both the sides. So I can share with you, and what panel has already highlighted important issues. We'll discuss every point in detail. Why? Look at the interest we fight, you know, the day starts with one episode, whole day on WhatsApp is devoted to discussion. And we are WhatsApp warriors. We are not fighting battle in the battlefield. I am a soldier. I spent 32 years in army. Battles are not fought on WhatsApp. You have to get down to the battlefield, and once you get into the battlefield, either you get killed or you kill the enemy. It is a question of survival. What I am trying to tell you is, I was bombarded with so much of queries when this topic was announced. 27 presentations I have from different people of various seniorities for today's lecture. I hardly find 9 or 8 of them who have sent me presentation who are present in this session. So what I am trying to tell you is, we can only help the younger generation if they are genuinely interested. If they are not interested, you cannot drive the horse and make him drink the water. You can take him near the water. So this is a sad scenario, Dr. Shyam, that people who were so enthusiastic have chosen to miss this session. And I'm sure the loss is going to be theirs, and we'll move forward with that. Look at why I'm making this comment. I sent a Google form on the society. It was circulated to all the members because I got 3-4 days notice myself for this talk. I didn't know that I'm supposed to conduct it. There was a communication gap. But I made a Google form. Look at the number of responses I got. 24 responses came within 2 hours. And after that, total 36 or 37 responses in last 3 days. So what I'm trying to tell you, that form was designed in such a way to structure this talk so that we understand their challenges. we have experts with us and we will try and come to some possible agreement how to deal with them. So when I evaluated the Google form, look at the training. Now everybody is talking of training. So we try to decode, see what is the problem in India. One is 60% of the IRs, they are not trained in the institution. They have got institutional fellowship which is not accredited. So this is the main problem in India. Only 40% of them have accredited degree. When I talk of degree, it is DM or DRNB. Because we started practice, I don't have a DM degree myself because there was no degree at that point of time. So same applies to many senior people. But they have become teachers by virtue of starting it, and it happens to every new clinical specialty. For few years, they give you your experience criteria guide and make you teacher. Subsequently, they put a cut line. Now, do you all know what is the cut-off line to become a IR without a degree? And that is 2027. After that, that window is going to close. So, this is very important for everybody who's present here, especially the younger people. Is our qualification recognized? When we get State Medical Council registration, we apply for registration. I have spent 2 years in AIMS. I have spent 2 years in the top of the line national importance hospital for training. They don't recognize that as an additional qualification. So when it comes to legal issues in the court of law, we don't have that additional qualification endorsed in our state registration. Now here is a problem. So this is what 42% of IR training is not registered. Another issue, no institution can provide you comprehensive IR training. They will be very good in few areas, they will be lacking in some other areas. So when I take a fellow, it's my responsibility to ensure that we give them comprehensive training. If we are calling it a IR, interventional radiology training, if we are calling it a hepatobiliary training, fair enough, he goes to a hepatobiliary institute and gets it. He goes to a oncology institute and gets a training in oncology, onco-intervention. It's fine. But when I label him as an intervention radiologist, he is expected to do head-to-toe interventions. He goes to market. He is not exposed because his institution was doing only limited IR work. So 36% of them are trained at the same institution, in one institution. So many people were deprived of this comprehensive training. So we asked them, what are the challenges now when they are practicing, they are facing? Can you believe it? 47.2% they said, hospital administration is not very cooperative. Why? Because they don't consider it as a separate clinical specialty. Now scenario is different when I am talking. Government sector is one sector, public sector, and then the private sector. Scenarios and the challenges are quite different. We will try and cover one by one quickly these areas. Diagnostic colleagues, 19.4% out of the responses, though it's not a very big number, they felt they are facing challenge from their own colleagues. This is one of the bottlenecks why intervention radiology has not grown, because there is hardly any encouragement for few of the diagnostic heads. Dr. Meenal here is, she is an exception, I must admit, that she is encouraging intervention radiology. Abhishek, where is he? He is very lucky to work under you, and she has been promoting it, that this should be promoted in a very big way. Since the time he has joined, I've seen his rapid growth. So I'm very happy. I hope all HODs start behaving like that. Awareness. This is what I asked you some time back. Are we aware that we don't have a degree of IR, but can we still get a registered as an additional qualification? Yes, there is a government notification, gazette notification, which laid down the criteria, and I'll show you the gazette notification abstract short. It is open up to 2027 only. So what are the gaps in training? we don't have a national accreditation for most of the IR fellowships. So here comes the role of ISVR. At least it is high time ISVR should have taken this lead. Unfortunately, Indian College of Radiology and Imaging has taken that lead. They are giving intervention radiology fellowships, chest fellowships, so many fellowships. We have all worked for them, and I've been telling them that module is also not acceptable because they are giving ICRI intervention radiology fellowship at X institution, Y institution, which does only very limited work. So I said change the terminology, make it hepatobiliary intervention, make it onco intervention. That will be a better terminology to, and I hope this year they are planning to change it. Next is variable fellowships. Somebody says I am trained in very reputed institute for 6 months. Somebody says I spent 1 year. Somebody says 2 years. There is no structured duration of the fellowships. I got trained at Tata Memorial in 1991, 6 months. I was very happy. It was a PDCC course, but it is not recognized. Though it gave me clinically tremendous exposure. For 6 months I stayed in Tata hostel, and I was provided accommodation, food, everything free by the army to get trained. It was a life-changing experience. But when I came back, it is not accepted as an additional qualification. So we don't have uniform exams, exits, logbooks. We don't have benchmark. Who should be given this or who should not be? Because we are not recognized as a clinical specialty. We are recognized as a subspecialty of radiology. So who can perform IR? This is the Dr. Jignesh. Thank you very much. He has sent me this. I told him, please send me the gadget notification of MCI that which authorizes people who do not have DM degree at present but can become teachers in an academic institution. So this is the notification, and this says, it lays down the criteria. But very important, that red thing which he has highlighted is, even if you don't join an academic institution and you are practicing IR, you will continue to practice as IR. So this is the implication. Don't get discouraged. I'm doing private practice for last 10 years. I'm practicing as a IR. Suddenly I cannot stop. You don't have to worry. So long your hospital accepts it, continue doing IR work. So what are the solutions? We need a unified strategy. So Dr. Girish, can you please tell me something about what do you feel so far? We have just touched the tip of the iceberg as far as the problems are concerned. So any other problems which you can highlight for us?
I've had the privilege of working in private sector as well as I'm visiting in a government sector hospital, which is a pediatric hospital at Wadia Pediatric. I see the difference. There is a much better, what do you call it, planned teaching program in Wadia vis-a-vis in private. However, I do not find any animosity with any branch because I work with everyone. So I have no problem about getting references. But what I think we have to think about deeply is you can't make enemies from other specialties and then expect to get patients.
Okay.
You have to work in cohesion with them, and then automatically your work will improve. Not only that, I see in the WhatsApp groups the animosity that the younger generation feels, especially with vascular surgeon, interventional cardiologists. The point is the only way to negate that is you excel in what you are doing.
Very true, very true.
And if you do a better job than the vascular surgeon or the interventional cardiologist, automatically the patients are going to land up with you.
Thank you, Dr. Girish. Excellent feedback. We'll discuss this also. Any points from the audience so far? Any queries you have in mind before we go further? Anything important which I missed out, which you are facing the challenge, you feel that's a bottleneck for us? please do get up and tell us. Be free, yes, please. Take the mic. I want it to be interactive. It is for their benefit actually. Yes.
So I think it's a very, very important discussion. I think every intervention radiologist has been thinking.
We can't hear you, sorry.
Yeah,
Very close.
I think every intervention radiologist has been thinking in their back of their mind. It is always going around everybody's brain. One point I always have felt is the word interventional radiology itself is not a very widely accepted word. I told before in previous meeting also that this is not a word which resonates with the public, resonates with the clinical background for anybody. So I think that is the first change we have to make. Beyond that, I think other discussions are there. This is one thing which always has been in my mind.
We'll come to solutions.
Please.
Just give me the problems which I missed out.
This itself is one big problem.
I will come to this specific point of naming the specialty.
Yes, sir.
Okay.
Thank you.
So, what is this possible solutions? This is what I perceive. Yes, please. Please introduce yourself. And
I'm Dr. David, working in CMC as a consultant. Sir, I totally agree with you that we need to join hands with the other specialities. But frankly speaking, at what level you are looking and what level we are, the situation has changed. It is not the same. You have been practicing at a time when most vascular surgeons were not actually doing these endovascular interventions, and you have established yourself. And now everyone knows that you are a prominent figure, and you get the referrals. Sir, let me finish.
Okay.
But now the vascular surgery means I'm just not like I'm pointing fingers at the other things, but I know how things are, like especially in Bangalore, Chennai, and even in Delhi. The vascular surgery has started their curriculum includes endovascular interventions, and that is part of the curriculum, and they are encouraged to learn. So they are doing in a good number. So most of the referrals what we get, any peripheral vascular intervention.
I'll address this. I have this point in my slide. So we'll come to this vascular surgeon thing in detail, because that is one area which is affecting us gravely. So what I thought was, unless until we move from procedure based specialty to a clinical specialty recognized by NMC, it is not going to work. So we have to come out from that tag of subspecialty to a separate clinical specialty like cardiology, like nephrology, neurology, neurosurgery. So that is my first step, which is possible. That I think ISVIR, I am going to request them, the new committee, they should take over only if they are able to fulfill the aspirations of our younger generation. Please vote for only those people who will work for you, will produce results in a time-bound manner. Dr. Sanjeev, it will be a pleasure to have you on the stage. Please join us. Yes, yes. Can we have one more chair? Okay, please come. So here is another stalwart joining us, so we will hear from him also. Secondly, I thought we actually our younger generation, I feel very upset. They are not happy to come for emergencies. They want to call themselves as intervention radiologists, and they are so scared. You know, I got a radiologist who has practiced for 10 years. He said, sir, मैं 9 से 5 आऊँगा सिर्फ इंटरवेंशन रेडियोलॉजी करने. तो आई सेड रात को कौन करेगा? बोला वो आप किसी के जूनियर को रख लीजिए. That's not the way we should work. And younger people, more I go down the ladder, they are reluctant to come in the emergency. So this, unless and until we take the clinical ownership, this is not going to happen. Now, lot of debate I hear, sir, मुझे OPD right नहीं मिलता है, मुझे admission. I will show you a document which I got approved from government in 2012. We demanded beds for intervention radiology. We demanded OPD rights, and that document is approved. It is on the website. But we have not looked at. I did this homework in 2012. So I'll share that document with you just now. And secondly, name issue. This also issue we'll discuss subsequently. Should we change it or not? There is a 2-3 slides. This is the document I am mentioning. I was invited in 2011 by Ministry of Health to make few guidelines for interventional procedures. We made committee of very senior people, I think 10 or 12 of them. We gave them topics and we were given 10 topics. We were given a specific format. I said this format is applicable to clinicians, not to intervention community. They were not ready to change it. They were very adamant. So we had to restrict ourselves to the time frame. This document is available on the website. So we went and selected 10 interventional procedures and we have made the guidelines. There we wrote, we took opinion of ISVIR president and secretary. We got endorsed, this document endorsed by them as ISVIR society. And then with a covering note we sent it to ministry. We need beds, we need OPD rights, everything was accepted in toto. So this document they have uploaded, so you can visit this document. But how many of us are aware of it? Then strengthen our DM, DRNB and IR fellowship program. When I say DM program strengthening, DRNB program, I am very, very upset. Institutions, I visit for inspections, we apply, we go there, there is only one IR fellow, one diagnostic person doing non-vascular, he wants to associate him, make him a IR faculty to start a DM program or a DRNB program. People are visiting faculty and they are showing themselves as full-time faculty, they are starting DM programs. Who is going to conduct training for them? That is why people will join such institutions, but they will leave the institution after some time frustrated. So I think we need to look at the criteria very carefully. We need to see whether we have adequate workload. Can we run this program successfully? And then we should start and implement it very seriously. That is how we are going to strengthen this program. Same problem is existing in both DM as well as DRNB. Fellowships, I think we need to review. Should we have institutional fellowships? Should we have university fellowships? Or should we stop all these fellowships? Let's go with the society at least to begin with, that ISVIR accredited fellowships. At least there will be some sanctity. Without having these, I don't think medico-legally we will be able to defend ourselves. Dr. Sanjeev, can I have your comments on this strengthening of the programs?
Absolutely, that is the need of the hour. We should have a uniform syllabus for everything. All these degrees and fellowships that you mentioned here, unfortunately, they are so institutionalized that there is no uniformity in them. That's one problem. Second problem is that training levels are very widely different. I have been, the last few years, I have been taking a lot of these exams actually. And I find that it's not the candidate's fault. Their training levels are abysmal, unfortunately. But the problem is, it is a reflection of us. They are a reflection of us because they don't have trainers, so how will they get trained?
So thank you.
Interventional radiology is not doing procedures. I mean, that's the base level skill. Even a technologist can be trained to do these procedures. That's not a very big deal. How you handle the patient, how you select the patient, when not to do, how to manage when things go wrong, these are things that cannot be taught. They have to be learnt through
very true. So
structured training program.
Thank you, Dr. Sanjeev. So we should have a uniform curriculum. For your information, there is a curriculum available on the NMC website, curriculum made for IR also, DRNB program. There is a difference between the two, but basic crux is same. And they are competency, skill-based curriculum. If you actually look at the structure of DRNB curriculum, which I was part of the curriculum when we made it, and we structured it pretty well to make sure that reasonable skills are acquired by the time they finish their training. Now the advantage is common entrance exam, common exit exam. So when they go abroad for fellowships, at least now there is a sanctity. Earlier, selection process was biased and people were not happy to have people from certain institutions except from reputed institutions. So this OPD I have already discussed. We need, Dr. Sanjeev has highlighted clinical involvement. pre-procedure. You manage your own patients. You need help from a clinical colleague, refer it, take the opinion, manage it, there is no problem. Except for serious cases, which you need a joint management with clinical colleagues. It can be a joint decision, joint admission. Then we have to behave like, how many of us send our trainees to clinical postings? 3 years DM program, we never send them to emergency, we never send them to ICU, we don't allow them to work in medicine, we don't allow them to work in surgery. If you send them for 3 months in these areas, at the beginning of the training, I am sure there is going to be a tremendous impact on their clinical skills. They will know how to interpret ABG, they will start the IV line, how to manage the emergencies, and all these issues will get resolved, which we are facing now. In my hospital, I made it mandatory now, and we do a 3-day induction program when they come. We tell them what exactly is expected. Everybody from the hospital comes and takes lecture. They undergo BLS. I make sure critical people joining our hospital, clinical specialties, they undergo ACLS course also in the beginning of the joining the program. It's a 3-day structured program. If you want, I can share it with you. Please look at it and improve it further and give us suggestion how to improve it. Clinical competency based criteria, whether we are doing a fellowship or these programs, we should have a very structured exit exam which is competency based. So what is the unfortunate scenario I've already discussed? We need a uniform curriculum and implementation. The problem is not the curriculum, it is the implementation which we are finding. I've been hearing a lot in the discussion, we should start IR training, radiology training in the first year of MBBS, catch hold of them when they are very young, generate interest. Dr. Sanjeev, you will remember how much discussion we have had in the years, go to medical colleges, take lectures and motivate the students. I was member of this committee in 2012. For 1 year and 7 months, all weekends were spent in the MCI office with my interventional practice. I used to leave home at 6, go to hospital, do my cases, go to MCI, spend whole day there, and then come back to hospital, finish my cases, and then go home with lot of homework on Saturdays and Sundays. And we used to interact, 13 committees were made. We look at basic education, MBBS, MD, MS, super speciality, lateral shifting, dual degree, PhD pathways, NEET exam, next exam. So there we revised the curriculum of MBBS. The radiology training has been made mandatory from first year onwards. We have introduced lectures. How many of us are aware? It is compulsory now. They have to take X number of lectures in radiology from first year. Clinical posting, like abroad, they have to go to the hospital from first year. This is clerkship, we call it, which is a foreign model. For your information, Nepal Kathmandu model is the best model of education in the world. This is better than US, Canada, Australia, UK, New Zealand. I am not joking. Please go through this model. It is one of the fantastic models of medical education. So we deliberated for so long and we came out with a huge document. All these exams and policy changes are coming slowly from that document, which was known as Vision 2015 document. Another area I think we need to educate our crowd is colleagues, AI. Let's not run away from this. It is a reality. It's going to be with us very soon. Diagnostic, of course, in a very big way. Intervention is not far off. There is a video system, Philips system developed 2022, augmented reality. You will not have screens in the lab. There will be virtual screens and every operator will have a virtual screen. We will not have radiation. We will have fiber optic technology showing us the catheter movement. Please visit the website today. You will find that video freely available, and Dr. Amit Gupta from Philips has already put excellent video on the website. So this is going to come. Let's embrace it and move forward. Now this comes the main worry for all of us. Turf. What is a turf? Unfortunately, currently IR is just like a hospital gown. We think that we are well covered, we are well established, and then the new bombshell starts. And the new sub-speciality comes and we say he is also encroaching into our area. So let's do it well. Look at the example of vascular surgery. Somebody was saying, vascular surgeons were trying to include endovascular in their curriculum. For many years they were not successful. But we got it introduced in the DRNB as endovascular and interventional radiology DRNB. Then there was a lot of hue and cry from the other societies. When we are clinicians and we are not having, I said you don't have it in your MCH or DM curriculum. But look at the efforts. As a society, they have really worked very hard. They have put documents in place, they have convinced the government, and they have got their curriculum amended. Now, for MCH, neurology and vascular surgery, endovascular is part of their curriculum. We have slept over this, and what has happened is recently, it's a very sad thing, endovascular and intervention radiology, DRNB, I am told the certificates which people have passed out is given as DRNB interventional radiology only, because nobody has raised a voice till now. They were registered as DRNB endovascular and IR, but degree says DRNB IR. Unfortunately, not a single voice from our people who got affected. This is not the way to move forward. If we really want to take care of our specialty, there is a process where these things can be rectified before it becomes too late. So, the Vascular Society, I give them a credit. They have really worked very hard to get endovascular included in their curriculum, and now they are taking this. But as Dr. Girish was suggesting, there is no point in fighting with clinical colleagues. Let's make ourselves better clinicians, better skills, and we ultimately what is going to drive? It is the clinical outcome of patients. Private sector, in my hospital recently, new hospital, state of the art has opened. We had a neurosurgeon who said, I am going to do neuro IR. And I have already hired a neuro IR DM, qualified. And this fellow was very upset. He said, sir, usko aap kaise allow kar denge? मैंने कहा देखो उसका मैं तब लड़ूंगा उससे जब क्लिनिकल आउटकम खराब हो. Otherwise you wait, 4 cases you wait, then we'll take a call. 5th case, the hospital called him, you will not touch any patient for neuro intervention. Why? Because outcomes were very poor. Only 5 cases. So sometimes you have to strategize and keep quiet and wait for the opportunity. Now they called my neuro IR and told him, you will take care of all intervention, you will lead the program. See, within 5 cases, the scenario has changed. If I had gone and fought with him, there would have been lot of ill feelings. Ultimately, no neuro intervention can take place without neurosurgeon, neurology team. And now there is no issue. So this is a small step which we thought. So what is our strategy? So Dr. Ashu, would you like to tell us something about how you want us to go forward?
Yeah, so listening to all young people, especially who are in the private sector, and I have in recent times, sorry for talking about myself, gone into an auntie mode, means whoever comes to me, I sit them down, ki beta, where are you practicing now, what are you facing, because to introspect what we need to change. From all this conversation, what I can draw conclusions, some things which are low-hanging fruit and are achievable on an immediate basis, some things which are not. Dr. Khandelwal is here, Dr. Sanjeev is here, you know how it is with the government. We were trying to get our name changed only to radiology, okay, we were called radio diagnosis, and to just call ourselves radiology or diagnostic and interventional radiology. And we were not permitted. Some twice or thrice when I went through those 5-6 committees, at the end I was told the word radio diagnosis will not go away because your MD reads radio diagnosis, whatever you want to add to it, you add. We said it sounds like wrong English, whatever it is, Dr. Saab, take it or leave it. And finally, we were called and are called radio diagnosis and interventional radiology. So It's not an easy path to take. Sir, you are trained in that, and we can, use your, not trained formally means experience. What is easy is what, the first time when Dr. Shah mooted the idea to me, what is easier done if we put in only like 6 months, 1 year of effort is to wherever you are sitting, whatever your level of training is, give us an exit exam and clear as a society. The first thing is whether you did 3-year senior residency plus 1 year fellowship, you did 2 plus 1, whatever you did. And that exam has to be very comprehensive, very strict. You may plug it once, twice, but if you clear that exam, then it will have a component of neuroperipheral everywhere. Whether you're trained, the curriculum and instructional videos for it, we will have to put out. 6 months, we have to make the syllabus, put teaching material out there, learn this teaching material, come and take our exam, and we certify you. That is achievable within a year. I promise you we can do it. Second thing, I don't know how this works, but I have, again, drawing from obstetrics because I always see my colleagues weeping. What I understand is that SFM, the Society of Fetal Medicine, if I want to buy certain softwares on my ultrasound machine today to do in obstetrics, unless I am SFM certified, the vendor is not allowed to sell it to me. How did SFM get there? That's my question. A radiologist today cannot use that software unless the SFM certifies you. A little bit tightening of these vendors has to happen. They are the limit. I've seen it with diagnostic radiology. They only want to sell sonocyte, 50 in one hospital. They know radiology department will buy only 5. If they can sell 2 to every floor in the hospital, that's 50. So they will go and train each one of these guys. They will get people from outside to train. They are doing the same with IR now. Just because, they come and sponsor this, and it doesn't mean that they will do whatever and get away with it. Somewhere they have to be controlled. SFM does it. I'm telling you, they are not even allowed to sell measurement softwares.
Excellent, Dr. Ashu. Actually, I was coming to this, that we have a window for people who do not have DM. Create a curriculum, 6 months, give them to pass this exam, certify from the society, and then get it approved from the government beforehand. This process should start after your curriculum is made. Go to the government because they will take their own time. And then we will have to pursue with the government. And believe me, I have also worked with the government. Things are not impossible, Dr. Ashu. They are difficult. You need persuasion, repeated persuasions, and your contacts. Let me tell you, without contacts,
like I'm here also only for the next 6 years in a government position. So, sir is still in a position to help. You are saying another 5 years, this whole generation is not going to be able to influence anything.
See, so for ultrasound, that 6 months thing came, same thing we need to do as a stopgap measurement till we have more accredited programs. So at least they will have the sanctity. They are practicing for so many years. At least they will have some sanctity. Dr. Khandelwal, would you like to contribute on this? Mike, please.
Thank you. I think most of the thing has been covered, and what we need is, when you talk of intervention radiology, and what I feel from the heart is, you have to be the best of diagnostic radiology, then you can probably practice the best of intervention radiology. What I see is that there is a component of, you can say, divergent view on these. People do not want to practice the subspecialty of radiology, diagnostic radiology, and then do the intervention radiology. So this component need to be also highlighted.
Okay. Dr. Anish, can we have you are from the forces. Before I invite him, I'll just give you a background. When I was in Army Hospital, RNR, I had some say in policy making. So they were giving us steadily for 2 years. I told them, now DM courses are starting. I spoke to Dr. Gupta, he was in Shri Chitra. I said, can our students come to you? He said, there is a laid down process. They have to appear in the competition. And we do have a sponsored seat. And I met the director, I went, my director general, we got it converted to 3 years. And the 3 year was given to them for doing DM. And they started with one seat very reluctantly. And see how program has developed. Dr. Anish, can you just brief us how it has evolved in last few years?
Thank you. The DM program, the first Brigadier Atul Mishra sir is not here right now. He was the first DM who joined Shri Chitra under Dr. Gupta and Dr. Kapilamurthy. Then subsequently many people, at that time the only DM program that was available was DM Neuroradiology. So in between Shri Chitra and PGI, lot of us got trained. I myself was trained at Shri Chitra. Subsequently, other people, now the DNB IR program has started in PGI. We have had our first pass out who's working with me in Army Hospital RNR. So in Armed Forces, we have slightly different problems. Turf war largely is not there. Of course, we do not have peripheral vascular work with us. It was there when you were in service. Peripheral vascular work, when we joined, it had gone to the vascular surgeons. We have the entire whole gamut of IR. We are doing complete neuro, onco, hepatobiliary, everything except peripheral vascular and aorta is with us at Army Hospital RNR. The problem that we are facing is a critical problem. Some people in government sector will understand, I had highlighted it to sir, is the problem of substandard equipment which has so far not been brought out. So when I want something, if I want a microcatheter for a neuroaneurysm coiling, I give specifications, I want this length, I want this kind of braiding, nitinol blading, this kind of a soft tip, so that I know there are 2-3 good brands of which any of them becomes the least price, L1, I get that. Unfortunately, if I want, we all use our standard 150 centimeter Terimo wires, everybody in every procedure. Now I cannot make BBQRs for that, so that 5 other companies which are manufactured all around in India with suboptimal torque transmission which dissect the vessel, they do not come in. All I can write is hydrophilic guide wire 150 centimeters because the vendor does not release those technical specifications. Because of that, our market is being flooded and we are getting substandard equipment which are harmful for the patient. Recently, when I joined Army Hospital RNR, our onco department bought a bulk of PICC lines in thousands. We used to be putting the PICC lines, but they procured it, and they were so bad in quality that even in small pediatric patients, we were changing the lines once or twice every week. So in one patient, we would go through 10 PICC lines in one month. That was the quality of those PICC lines. And so that is something that we are facing with. This is one of the major challenges that we face with our this thing, and this is also something I request as senior people to take up with, and maybe the committee as a whole, the society as a whole.
I think society needs to address this very important issue. Dr. Bajal, I saw him, is he here? Dr. Bajal? Yeah, please, can we have your comments? Dr. Bajal is one of those pioneers who developed a Bajal stent, I think, in SGPJ Lucknow. What a tremendous work he has been doing since then. So, Dr. Bajal, what is your take on this?
Sorry. So actually, I came in at the fag end. I came in at the fag end because I was at the other session. Probably missed most of the discussion. But effectively, my thought on going forwards is that we've got to first of all decide that IR is a full-fledged clinical specialty, and all of us are convinced inherently and strive to pursue it in that manner. We say this just to inflate our egos, but when real time, when we are working in our own environments, many of us are still banking on our colleagues to take care of those patients. So I think it has to go back to our training at MD radiology level, at DNB radiology level. And if at that level interventional radiology becomes an inherent, compulsory and absolutely a solid component of the training program, then I think IR will be recognized at all levels. I mean, be it at the national board, be it in the health ministries, or be it whoever are the office bearers whom Dr. Ashu is struggling with just to get a change of name or get an add-on. Because Otherwise, it's a totally unrecognized specialty. It has
So,
to start at that.
thank you, Dr. Baijal.
Sir, may I address his issue?
Yes, yes,
Of,
please.
again, he asked me from a government this thing, and I think amongst them I'm the one who's struggling. It's not going to change. So, but how you can, let me tell you that the current thinking of the government, and they are going to be here for some time, what looks like. See, there is an inherent trust deficit in the way doctors purchase. The government thinks you want expensive equipment because you make money out of it, okay? How many of us can put hand on your heart and say, I don't make any money from the vendor? I'll tell you why. You and I may not take any money from the vendor. Every room we use here, every meal we have here is subsidized by a vendor. Each one of this is under the scanner of the government. If you want high quality training, today again I go back to fetal medicine, people are ready to pay 50,000 rupees for 1 day training. You know, 50,000 rupees is 1 day training for obstetric ultrasound.
So Dr.
One
Ashu,
and the spots are sold out. When our students try, spots are always sold out.
No, what I'm saying is how they have been able to get it done.
I'm telling you, one is, as a society, get involved in innovation. You see, the rule is 25% manufacturing or interest to happen in India. I'm telling you, this vendor engagement modality has to change. Get involved with developing. Why none of us are in any of the boards? Only people from US and UK are on the boards, and we are only sitting here as consumers. And the vendors that we are using, we ourselves are bringing it down, the ones government. You have to get into the innovation side of it, using hardware in which we don't have an IPR is not going to work. We need to have an IPR in companies. We need to get involved with real R&D in product development also. That the government will support.
But Dr. Ashu, when I was in Army Hospital, I put up a demand for digital radiography in 2003. I was called up by the ministry. That time nobody had CR in the country. And in 2004, I had the first biplane lab of Asia installed in Army Hospital. Why? I was asked by the ministry, they called for my explanation. So my Director General said, you have demanded, now you go and explain. Your job is at stake. I went and sat in front of the secretary. First question he asked me, Dr. Sahab, aapka commission kitna isme? And I was prepared for that question, I am telling you. I had gone with a PPT. I told him, sir, if you give me 15 minutes, this question I'll answer after my presentation. And my Major General who had accompanied me, senior officer, he was shaking, कि look ये तो गया, क्योंकि वहाँ मिनिस्ट्री को नाराज करने का मतलब है आर्मी में you are sacked, you will be shunted out in no time, 48 hours. So I went, I presented, I had not a single DR in the country, not a single CR in the country. And by the time I got out of his office, my DR was sanctioned. Next time I went to him for biplane lab. My biplane lab of 5 crore was sanctioned. So I agree with you, Dr. Ashu, it is how we do it. Maybe I had people who listened to me. In spite of provocation, I didn't react. But I did my homework of 134 countries.
Trust deficit.
Yes, why we have created this trust deficit. In MCI, I introduced DSA compulsory for DNB radiology and MD radiology. How many of people know at what level we are supposed to have single plane, at what bed strength we are supposed to have biplane? It was introduced in 2012 in the curriculum. It is unfortunately diagnostic radiologists, HODs, don't even post students in intervention. DSA training is mandatory, I am telling you, as per the curriculum. See, we can only make guidelines, we can only help. Implementation is by us only. We are not implementing. So we are blaming everybody else. Dr. Murthy, I think, can I have your opinion? You have been a very big supporter to us for our all educational activities also. So I think, can you?
Thank you, sir. I'm just kind of trying to make 2 or 3 points that have been noted from the discussions. One thing that I relate to is the issue of turf is common.
Last 2 minutes.
It's not just, I won't take 2 minutes. The issue of turf is very common across the board, whether it is in Australia, in New Zealand, in UK, in the US. There's no American practitioners here, but the turf issue is common. Vascular surgery and interventional radiologists working, fighting for peripheral vascular disease or vascular, IRs is very common. That's because no one owns the patient, no one owns the organ systems, no one owns the procedure, no one owns the disease. We get, like Dr. Garish said, you get better at it, you prove that you are good at it, you're good at taking care of the patients, you will be able to do the procedure or perform that particular procedure or lead that that specialty. So I think that's a struggle that we will continue to have, and the only thing that we can do is to address the deficiency in our training to meet the standards expected. If it is a clinical bit that is a deficient, the vascular surgeon, why is the vascular surgeon able to tell that we are the only specialty? Because they are confident that during their training, they're going to see the patients, they're going to do the wound care, they're going to go to the OT, they're going to go to the wards. That's all included in the curriculum. IR training has a deficiency. It's common across. Even for us, it's the same problem. We're going through the change of curriculum. We've just introduced an IR curriculum that is integrated into the radiology curriculum, which will kick in at year 4, phase 1 and phase 2. We are going through the same sort of transition. So the key is curriculum. The key is training. Make sure that the training sort of addresses all these issues. It is a challenge for us because we are not only trying to look at vascular surgery, neurosurgery, you are looking at oncology, and tomorrow you're going to try and fight the urologist. Sure, that this is an issue. The second thing a comment that I would like to make is with regards to the name. Nomenclature, we spend too much of time wasting on it, my personal opinion. Take, for instance, ICU. Common man knows what is ICU. No one can, they may not be able to expand what is ICU. As soon as you say to a common man, we are in the ICU or I'm an ICU specialist, they know that you're looking after a critical patient. Just keep using IR. IR is easy to say, easy to sound. Most systems use IR as a word. It's just what you do is what is reflected. If you call yourself an IR, over a period of time, people will know you are an IR. Doesn't matter what it is, you don't have to expand it and say, oh, this is interventional radiology, this is what I do. Yeah, sure, when you have time to explain to them that you do pinhole procedures, but IR as your identity, work on that. It may take a few years, but it will stick to common public.
I agree with you, and so these points you must have read by now. Because of time, I think I'll just move quickly. So there are exceptions to what we have been discussing. Amongst us, some of our colleagues took the challenge. They have taken a lead and developed standalone centers. Dr. Rajesh and Atul from Nagpur, they led this movement actually. They started a small IR pulse clinic, and now they are starting a hospital. They already had a 30-bedded, now making it multi-speciality 100, primarily driven for IR practice. So what support services they need, they have to. Similarly, many other people have taken. Balaji is coming out with a very good hospital in Hyderabad. I've yet to see it, but it appears state of the art. So there are some exceptions, and please work in a setup. If you are in a private setup, best example I think I can think of, Dr. Murli is here. Dr. Murli, you have been working with clinicians so closely for your aortic work. Did you find any challenge? I think it is a win-win situation for both of you.
No, I think a lot of mixed things. Some of the clinicians will support you to the maximum. Some of them will be against. So I have now worked across 4 hospitals in Chennai. The latest one I had to move out to a new setup because the previous hospital they are closing down our setup. One of the biggest challenges when we start in a setup, you will have to work along with the cardiologist or anyone. But over a period of time, you should have your own setup. The first thing what we established was in Ramchandra, we had our own interventional radiology suite. When I went to Miyot also, over a period of time, we could increase the volume and created our own interventional suite.
Very
and the third
true.
place, when I went to Vijaya Health Center, it was the same thing. We did it that the Vijaya Health Center closed down. Now I have moved to a fourth hospital, and this hospital has got an interventional neurologist, a vascular surgeon doing a procedure, and even a nephrologist started doing intervention. They went to Korea, get trained. And this hospital management called me and told, why don't you join us? I told them I cannot. Because there are already 3 guys doing it. Why do you want to take me? So they told me very clearly, yes, you come here, you will have your own
Time
patients.
is up.
Everybody looks at their own development. You will have your own cases, you will do it. So I joined there with a lot of skepticism. But today I am able to do a fairly good number of cases. At the end of the day, you have to work hard, you have to produce results, and you have to move with all the clinicians as much as possible. That's what I feel is going to work in the long run. But the good thing is, if you have your own standalone setup, it helps you. Every hospital I go, I make the first condition, I need admission rights for me, otherwise I will not join.
Thank you.
It's as simple as that.
Thank you. What I have taken a small step in my new
fact,
hospital.
I want to add up when we were in
please,
Ramchandra.
Please go ahead.
When the accreditation came from, JCI, they told that you are interventional radiologist, these guys from America, they came for initial evaluation, not the JCI guys who are guiding us from Harvard. You are interventional guys, you are not supposed to admit patients under your name. How can you do that? So I told them, in this hospital, dentists admit patients, ophthalmologists admit patients. How do you accept it? No, they did MBBS training. I also did the same thing. It's as simple as that. So I told, if you want to have a challenge, I'll put an IV line. Ask the ophthalmologist put an IV line. They never do it.
Okay.
Then they looked at me and told, okay, continue the admission process.
Thank
Sometimes
you.
we have to be aggressive also.
Very good. That's what I wanted input from all seniors. What small step we have taken in our new hospital is state-of-the-art facility, recently inaugurated. We have a decent, very good cath lab. We have got excellent equipment. We have hired 2 DM intervention radiologists, one DM Neuro IR and one DM IR with lot of experience. One is student of Dr. Sham. He is trained there in CMC Vellore for 5 years plus. And Dr. Kavish, again, having 7-8 years of experience, DM Neuro IR. Full time. There is no workload in the hospital at present. I requested management कि if you want to develop this specialty, let's not have competition. Let's give them a free hand for some time. Let it be a pilot project because it's a corporate hospital. Ultimately, revenue will come into issue very soon. And I've told these 2 fellows, now platform is yours, turf is yours. How much you want to put in effort, the ground reality, the outcomes, the number of patients will determine whether we'll continue with this model or not. So it is an experiment which we are trying to make. So basic idea which I am trying to tell you is no turf wars will help us. Everybody has highlighted from panel and experts, turf collaboration. This is the only way forward if we have to progress. The medical legal issues, Dr. Jignesh fought a battle on legally. Dr. Jignesh, you are here. Can you just briefly tell us little louder because of the noise from there.
Yeah. So this was an issue regarding prostatic artery embolization. One of the senior urologists was doing some cases in a corporate hospital and then he was promoting it. We knew about this, but we were discussing, and then finally there was a flyer in the medical circles that he wanted to conduct a hands-on workshop to urologists about how to do prostatic artery embolization. So that was like beyond this thing. And then he was showing videos. We saw the videos. He was embolizing obturator artery and showing the urologist that it is prostatic artery, because obviously the audience were like that. So then we thought we'll have to go legally, and we put a case on that in our home medical council, Telangana Medical Council. And when the medical council gave a letter to the urologist came out with a lot of urology guidelines, their textbooks and everything. So the case was self-contradictory because the textbooks and all the books that he quoted had mentioned intervention radiology doing the procedure, but he wanted to fight, and then we went to the council. We had the discussion in the council because the case was we had a better winning chance. he gave us an affidavit legally in front of the council that he won't be doing the procedure, he won't conduct the workshop, and he won't repeat the same. So this was noted in the council's minutes of meeting, took a video and this thing, and he gave a signed affidavit in front of the council.
Thank you. So now this is a very important area which is left, last part I think. Policy with the government, reimbursements, and that's Ayushman, that PMJY scheme, rates, inclusion of procedures, IR procedures. Now this is a big challenge. People are working at their own level. Leon, you told me yesterday that from state level you have pushed it. Can you just tell us? But these are small steps taken by everybody. I think as a society, it should be a unified effort with the government. Then only it will work. Just Leon, if you can just briefly tell us the efforts you have put in and how much success you have been able to get.
Good evening everyone. So of course I think getting Ayushman approval in different states is actually been a very big task and has been very difficult because it's ultimately up to each state government to approve this Ayushman process. Even though the codes were given by the center and there was basically a HBP revision in 2022 and subsequently one more revision, but you know, even the 2022 revision has not been accepted by multiple states. For instance, in Tamil Nadu, usage of Ayushman was only permitted in government hospitals and not permitted in private hospitals. But along with basically a social worker and a consultant, Mrs. Bharati, I have to acknowledge her work here, and she has been a big driving force to help us get multiple connections in different areas. And currently in Tamil Nadu now, private hospitals can get empaneled under Ayushman and perform procedures under Ayushman. So this was a big achievement in Tamil Nadu state. In Karnataka state, there are only codes under interventional neuroradiology. Multiple codes to the tune of 15 to 20 codes are under interventional cardiology. So much so that even bronchial artery embolization is under interventional cardiology. Coiling of pseudoaneurysm of abdomen is under interventional cardiology. So there are multiple procedures that we perform, but we admit them under cardiology and then we do it. So it was less about remuneration in this case, but first being able to get the recognition. Me along with Bharati, along with Dr. Madhu and Dr. Srinivas, we were able to get some leeway into the governmental body. We were able to find out that the current chief minister's son is a doctor. So Dr. Yatindra Siddaramaiah is a doctor. Get through to him. Through him we met the health secretary of Karnataka, and then finally we even ended up going to the chief minister's home. Thanks to that, we were now set up into an expert committee. Through this expert committee we had a couple of Zoom meetings. They finally agreed to include HBP 2022 with a lot of struggle. They asked us to trim down the number of procedures. So the number of procedures were roughly about 100 as per HBP 2022, and they asked us to trim it down. They said the government can't approve so many things, there are budgetary constraints, and now we finally trimmed it out to 70. They had further meetings with us saying some codes look like you all have added multiple codes just to get more money out of the government. So we took some convincing and trimmed it down further, and finally they have approved 68 codes in Karnataka state, which is a big achievement for us. And they have also said that subject to, of course, it has to get passed in the budget session of Karnataka state. So that is the only last hurdle remaining. With regard to Andhra Pradesh, the authorities have agreed to consider the inclusion of interventional radiology in the scheme, because previously it was under the NTR Vaidya Seva Trust. Yeah, so currently now the scheme was managed by the trust, so now they are going to combine the two and they are going to do it. So hopefully it will get completed by April 2026. Then in West Bengal, of course, first round process is over thanks to the leadership of Dr. Shuvro Roy Chowdhury, so I acknowledge him in this. and the second round meeting unfortunately could not happen because of Sir's travel commitments, but he had very positive interaction with the governmental authorities. Finally, the last two states, that is Jammu and Kashmir, again they have decided to include IR procedures and empanelment of AIMS in Jammu. And so again their expected revision is by April 2026, and there's Dr. Ankit in AIMS Jammu who has been helping with this process. Finally, in Kerala, some amount of proposals have been submitted. We have to secure some signatures and hopefully this will go through. So this is the progress in these 6 states. It has been a little difficult, but really grateful, and I think all of us should be grateful to Mrs. Bharati, and I actually urge that if in the GBM today we could give Mrs. Bharati even a designation, because she's doing this purely out of help and out of her own interest. But even if she's just given a designation, it may not be a paid position, but even if she's given a title to this, because whenever she goes and meets governmental authorities, she tells me all the time that, doctor, whenever I go and meet government authorities, they say, show us your ID card, show us where you come from, and she says, oh, I forgot my ID card at home, and she makes excuses like that, and she somehow still managed to move through 6 states and do so much work. But I think if ISVIR can provide her with an ID card, then she can continue doing the great work she's been doing.
Okay, thank you very much, Leon. Our secretary was here, Dr. Nitin. Yeah, so kindly note few of the things for today's GBM, though may not be in the agenda, whatever is good for the society which you feel needs a discussion, if you can include it as any other agenda.
Sir, can it just take 2 minutes?
Yeah, please.
Just to take off from what Lennon said. So I was involved in the update of the list for Rajasthan in 22 and then 23. I was called as an expert to the health authority in Jaipur. So the people sitting there, as Lennon said, will always want to cut down the packages. And they will always say कि डॉक्टर साहब आप तो गवर्नमेंट में हो, आपको क्या फ़र्क पड़ता है, ये गवर्नमेंट वाला कर देते हैं, प्राइवेट के लिए नहीं खोलते. So it's for us to represent the community there and put our foot down that no, it doesn't matter if I am not affected, if somebody else of my fraternity is affected, I will not yield to it. So I was able to get many of those approved even for private, not government only. And what happens is that we say, okay, we lack effort on our part as IR. I'll tell you what happened. For neuro, all the things were made by me. I had done the homework with my team, my names, and I went and all of them were signed that day. And when the package came out, it was not under IR. It was under neurosurgery.
Under?
Under neurosurgery.
Okay.
And I'll tell you why. When I called up the clerk there, he said that the final thing when it happened, the neurosurgeon from SMS was sitting there and he told the IAS officer कि ये तो हम करते हैं, वो करते ही नहीं है. So then, sir, I'll just take a minute more. Then I had to use my contacts. And that's very important to have these contacts. I was at a stage when I thought that these don't matter, but yes, if we have to safeguard our turf, we have to safeguard our discipline. Then through a kind politician, I got a appointment with the health minister, and then he said that listen to this doctor. Then they said ki next update mein it will be included for IR also. So that's how things work. It's not always that we lack as a fraternity. It's also people from the other branch who are always ready to cut our...
See, that will always happen, Dr. Pushpinder. Only thing is, my request is, individually doing is difficult. Lot of good work has already been done. Actually, society should get involved with this. It will become much easier. So, Dr. Raghu, you want to say something?
Yeah. So, sir, thank you, sir, and good evening all. The issue is not Ayushman. My major concern is the CGHS and ECHS. There, actually, we don't have any procedure, and most of these procedures either are listed under hepatologist or cardiologist, or so. The major challenge is there. So, we need to work there as well.
Dr. Nitin, may I request you on behalf of the discussion that please take it up very seriously as an agenda, if possible today, because otherwise we will be meeting next year and there will be a lot of gap. So this issue, any comments
No,
from you?
Dr. Nitin has formulated a committee, sir, for this. So
I have heard, but I have seen also committee. But my request is the next executive, whosoever takes over, they should have a deadline of everything.
So, and I am part of this committee, so I worked in this capacity as a part of this committee formulated by
Yeah, lot of committees, they have made very good committees, and just keep monitoring, and at a shorter interval, target oriented results will only help us.
It is in progress, and hopefully over
Okay,
the coming
anything
years.
he wants to contribute? Yeah, can you give a mic please?
So, yes sir, all point duly noted, and whatever, there are few of them which is already been included in the GBM. In fact, there are many who have raised the issue, and that's there in the GBM point. Like Lennon mentioned, yes, when the issue came about the Karnataka state chapter, that was, Bharati was put in touch by me only. So, subsequently, all those contacts in Karnataka to reach the Chief Minister, everything happened through Bharati. So, before the Karnataka, the other thing that he mentioned about the Tamil Nadu, I would like to acknowledge Dr. Kalpana if she is here, because she was also instrumental in getting the codes clear. So similarly, the Andhra, everything, she has done most of the work, and it didn't start during my tenure. It was previously also, the previous executive committee were also working with her. And what I understand that she is, though for us, she is the face, and she is a volunteer social worker, but she is being paid, and also it's being paid with the interest of the whole IR community.
Okay.
So basically the company side has hired her. So of course she is helping us out, that's well and good. But any other points that you need to?
So I think if this recording is available, then you can go through the recording, and lot of points.
No, I was there throughout, sir. I was sitting here and I was.
So you have noted?
Yes, yes.
Wonderful. Thank you. Okay, I have missed out many people whom I requested to contribute. Very senior people are here. Dr. Govind, Dr. Indu Shekhar is here. Dr. Bipin, I can see, and many more. Lijesh, I saw him here, and they have sent me very good points. And for the shortage of time, we will just skip. So, what is the vision? How to take it forward? We have to have some target. Let's lay down a target of 5-year plan, and what Dr. Sanjeev Sharma started, I think we should restart the registries. The registry, he worked very hard for a few years, and people were not sending data to him, and then he stopped it because of out of lot of hard work not being cooperated by the members. But if we have to move forward, I think we have to be honest and support the program whosoever takes it up, because ultimately the registry data will be an important document vetted by society to go to the government. So I think this issue we cannot ignore anymore. Dr. Sanjeev, you worked very hard on these registries. Can you just tell the younger people why it was stopped?
I sure can, but the only problem now is the time. Because I can see everybody is getting fidgety for the GVM. Perhaps we need to stop this here. Maybe if there is time tomorrow, we can have another session on this.
Okay, so I'll just quickly wind up. So we have to have some targets. Society has to take the lead. I saw some guidelines by Dr. Shyam 2-3 days ago on reuse of these catheters or some material. Please get it approved by the government. You put it on the website carries no meaning, I am telling you. Unless and until you have the approval from the government, these will die down their own, by time. They lose value. So please do it and revive the outcomes of registries, outcome-based registries, and then achieve visible impact. I think we started in a very big way, but we have lagged somewhere as a society. We are not focusing on these two only for conferences, midterm CMEs, some awareness. It should be throughout the year, and it should be very aggressive campaign. And then we try for formal recognition as a clinical specialty from government, and keep on upskilling the engagement with them. And this mentorship by the society is extremely important, and naming the specialty. Dr. Murthy, I think, has left. So this is another lot of suggestions was given to me, but I also personally feel what we are, we should remain. Otherwise, there is going to be identity crisis again. So Dr. Swati, final word from you. I think we tried to discuss and we might have missed some important issues, but because of shortage of time, I need to close it. Yeah, please. She has been a very big supporter of our educational program in DRB intervention radiology. Whenever I don't have a speaker, I will tell Dr. Swati, can you pitch in? She has never said no. So I must thank you publicly.
I think next time we should have this contest for our members to coin a catching name for our specialty, and then let's, no, it's IR only. Okay, Khandelwal has decided it's IR only. Anyway, but I think this was a very fruitful discussion, and when we started we thought there is nobody interested, and we just started in front of almost empty hall, and now we can see it could have gone on for a longer time, and there are a lot of people here. Yeah, not for us. Exactly.
So, finally slide, I have skipped few. One line I want to convey. Future is going to be decided by design and not by chance. So, Dr. Bajal, you have a big task at your hand after you take over from Amar. These 2 years are going to be crucial for this society, how we take it forward. Thank you very much, panelists, all the experts and participants. Thank you.